Hello, good morning, doctors, and all the doctors who are live, as well as the doctors who are physically present. I, Rohan Gowde, Marketing Head of Cipla Inspira, cordially welcome you and invite you for the Orient SNORECON 2.0. And as we know, that Cipla Orient has always been a pioneer in terms of delivering knowledge and dissemination of information when it comes to Orient as a platform. And I would like to once again welcome Dr. Vikas Agarwal sir, who is the chief faculty, who has been instrumental for actually creating this entire workshop. So Dr. Vikas sir needs no introduction, as he is one of the pioneer in ENT industry, ENT fraternity. He has been the past president of ISSA. He is a certified robotic sleep apnea surgeon, and he is a current chairman of Committee for Sleep Disorder from IHNS. Along with him today, we have got four worldwide renowned keynote ENT speakers who will help us to enrich our knowledge in the field of sleep apnea. So without much further ado, I would like to invite our first moderator, Dr. H.K. Parikh, as well as Dr. Vikas Agarwal sir, to initiate the session. Dr. Peter Rodrigues and Dr. Vikas Agarwal sir to initiate the session and take this ahead, sir. Over to you, sir. Yes. Yes. Yes, sir.
Good morning, dear friends, colleagues. We have to all thank Cipla, Orient Division for SNORECON 2. SNORECON 1 was a fabulous success. Dr. Vikas Agarwal, young, dynamic, innovative. I call him innovative because he's got his own surgery for snoring and for sleep apnea. As far as I know, my knowledge, I really don't know. To me, I think he's done the maximum cases of sleep apnea and snoring in India. Maybe he will correct me. Thank you for inviting us. And the first session is, it's your session, Dr. Vikas.
So, very good morning to all of you, all my friends and colleagues here, as well as online. And for the moderation, Dr. Peter and Dr. Parikh, my very dear seniors. So, we'll start with the first talk, which is on progression of snoring to upper airway resistance syndrome to obstructive sleep apnea. Can you have, yeah. So now snoring and sleep apnea is a very, very common problem. We all know about it, so I'll not waste time on that. What is important is that to understand that it is a spectrum which starts in early life and gradually progresses. So it's a progressive disease. And as we all know, snoring happens and irritates every bed partner. Almost 40% of the people do snore. What makes it progress from snoring to upper airway resistance syndrome to obstructive sleep apnea? So let's try to understand that. Can you have the sound, please? Then I will start sleeping. Breathing is stopped by what? It's by the fall of palate. That's normal breathing. At the palate or tongue collapse, the brain has to wake up the patient. Forgets to wake up the patient. Person would die. So that is sleep apnea. So let's now understand what is the difference between snoring and sleep apnea, how it progresses. So the spectrum is like simple snoring. It goes to upper airway resistance syndrome. Then it progresses to mild, moderate, and severe obstructive sleep apnea. And finally, to obesity hypoventilation syndrome. So in simple snoring, a person is only making sound. He's snoring to glory, he's disturbing others, but he himself is not disturbed. In upper airway resistance syndrome, the person is snoring and his sleep is also disturbed himself by itself. But he's still not obstructing. So he's not having obstructive sleep apnea. So his AHI, apnea hypopnea index, is less than 5. When the same thing progresses further to more than 5 AHI, so 5 to 15 we call it mild obstructive sleep apnea, 15 to 30 we call it moderate obstructive sleep apnea, more than 30 we call it severe obstructive sleep apnea. And when the person is having a CO2 retention even in an awake stage, that's called obesity hypoventilation syndrome. So this is a spectrum. So there are many non-obese, normal-looking people who actually come to clinics of different doctors, mostly physicians, complaining of morning fatigue, daytime sleepiness, irritability, and loss of libido, and etc., along with snoring. So they may not even complain of snoring, but they are having these symptoms, but they are missed. And they are mostly case of upper airway resistance syndrome, where the person is already symptomatic, he's tired, right? He's having body ache here and there. And these are mostly cases of upper airway resistance syndrome, which are missed, which are being treated for diabetes, blood pressure, thyroid, and chronic fatigue syndrome, and anxiety, and a lot of other things. So even yesterday, I operated a patient, came from Surat. His main problem was anxiety. He said, I cannot sleep. Possibly it is anxiety, and he has got a grossly deviated septum and turbinate hypertrophy and sinusitis. All he needed was a correction of the nose. So he was a typical case of upper airway resistance syndrome. He had a little AHI of 15-20, young guy, 32-year-old. But his major issue was not actually sleep apnea. It was majorly the resistance of the airway. Because 50% of the adults almost have some kind of deviated septum and turbinate hypertrophy. 25% of them, of the whole adult, have allergy. So if we put them together, it's almost 2/3 of the population which is suffering from some kind of disturbance. And they start snoring later in their life. Initially, they may not be even snoring. So let me try to make you understand how it progresses. Suppose there's a 20-year-old guy and you try to hit him. He'll hit you back. He'll not even think. He will not get disturbed. He'll simply hit you back and go off to work. But the same person, that is like simple snoring. The person is disturbing others, but he's not himself disturbed. The second thing is upper airway resistance syndrome. When the same person becomes, say, 35, 40-year-old, and you try to hit him, he will possibly not hit you back. He will not fall down also, but he'll get affected. He will feel bad about it, and he'll keep thinking on what is to be done. That's upper airway resistance syndrome. But the same person, when he's in 50s or 60s, when you hit him, he'll fall down, but he's not as old that he'll not be able to get up. So he'll try to get up from his position and try to spring back. That is mild to moderate obstructive sleep apnea. And same person in the 70s possibly will not be even able to get up. That is severe obstructive sleep apnea. So this is a progression of age, so that muscle tone also in a person decreases along with age. And that is one way of progression of obstructive sleep apnea from simple snoring to upper airway resistance syndrome. So in snoring, what happens? There's only sound produced by the soft palate or various parts of the airway causing snoring, for which majorly it is the nose which is responsible. It's not really the length of the soft palate or weight or anything. In the initial part of life, because the nose is blocked, so the person starts snoring. So in initial parts of life, if you take care of the nose, possibly most of them will not progress to a proper snoring and sleep apnea. So if somebody has got a deviated septum, he will also have turbinate hypertrophy on the other side. If somebody has got a polyp or an adenoid. So what happens when the nose remains blocked? The mouth has to remain open. And when the mouth gets opened up, the mandible goes down. When the mandible goes down, the hyoid goes behind. When the person is lying, actually, the hyoid goes down. Base tongue is attached on the hyoid. And therefore, the tongue also collapses. The soft palate also collapses. So this whole thing works like a domino. So when the nose is blocked, person starts snoring and then gradually go on to sleep apnea. We all experience this when we have cold. We all tend to snore to a certain extent. And it is very well proven that it is not only contribution of weight gain to sleep apnea or snoring. It is sleep apnea which itself, or snoring, upper airway resistance syndrome, and sleep apnea, which also leads to weight gain because of the disturbance in the hormones, ghrelin and leptin. I'll not go into detail. That itself leads to weight gain. So that's a cycle in itself. First, there's snoring, sleep apnea, that leads to weight gain. Weight gain leads to more snoring and sleep apnea, that leads to more weight gain. So it's a vicious cycle from which the patient possibly never comes out unless you really intervene in between. And it's very, very clearly proven that sleep apnea leads to weight gain. Now, this weight gain, when there's a weight gain, the demand for air or oxygen is more, and then that leads to dynamic obstruction. Initially, the nose blockage was a static obstruction. Now, because of the weight gain, which is happening because of upper airway resistance and sleep apnea, that leads to a dynamic obstruction. Dynamic obstruction happens behind the soft palate most of the times. So how does obstruction happen when the person's requirement is more? So to understand that, we have to understand the flow of fluid in a tube. In this case, the air in the pharynx, which is governed by two basic laws of physics, the Poiseuille's law and Bernoulli phenomenon. What is Poiseuille's law and what is Bernoulli phenomenon? Without going into detail of this, let's understand that when the air passes from a wide bore channel to a narrow bore channel, the velocity of the fluid increases. That's called Poiseuille's law. That means the velocity of the fluid increases the moment the person is having an increased weight. And the Bernoulli phenomenon says that when there's a increased velocity, and there's a sucking effect on the wall, there's a negative pressure created. That's called Bernoulli's phenomenon. So Poiseuille's law and Bernoulli phenomenon lead to narrowing of the upper airway. And in this case, the upper airway, the collapsible part of the upper airway is the soft palate. Therefore, the soft palate actually tries to contract, collapse. That's the area. And we know our pharynx is a collapsible tube. So when the person is actually in the lying down position, the tube is like this. So it's more prone to collapse. So pharynx is not a circular tube, it's an elliptical tube. So it's even more prone to collapse. And it collapses like this. So this is the way the whole pharynx collapses, and that causes the opening and closing of this tube causes snoring. Now, whether this tube will close or will remain open will depend on the balance of forces, which is the collapsing forces or the distending forces. Unfortunately, the distending forces are too little and not too strong. They're weak in nature. So one is the tracheal tug. So one of the ways to understand is that there are certain pillows called anti-snoring pillow. If you use that pillow below your neck remains extended, and then the snoring becomes less. So that gives a pull on the trachea. When the trachea is pulled, the pharynx remains distended and it cannot collapse so much. That is the tracheal tug. The other is the dilator muscle tone. When the person is awake, the muscle tone is in the dilated mode. When the person is asleep, then everything collapses. So the distending forces are very small in number, whereas the collapsing forces are too strong and too many in number, such as abnormal anatomy, mechanical forces, surface adhesion, gravity, Bernoulli, etc. So that decides whether the lumen will remain open or will remain closed. Now, the differentiating factor from snoring to sleep apnea is the Starling resistor model. So what does it say? I'll not go into technical detail or the physics of this model. This only says that when the airway, when any tube is collapsed, even if you try to suck harder, it will not open. But if you give a little pressure from the top, it will open up. That is the Starling register model. The example of this is that if you try to suck, say, juice with a very poor quality straw, which is very thin, and you try to suck it harder, it will collapse. If you try to suck harder, it will collapse further, it will not open up. And therefore, that is the causative factor for sleep apnea. Snoring is opening and closing repetitive. And when it is permanently closed, that's called obstructive sleep apnea. And that is the result of the Starling register model, which I just explained. And when that happens, even if the diaphragm is trying to pull the air, the pharynx is completely closed and it does not open up. And that leads to obstructive sleep apnea. So gradually, the airway which was collapsing and opening with more addition of fat, with more pull from down because of body weight, gradually the snoring converts into obstructive sleep apnea. So this is what I wanted to make you understand, and therefore we need to, and one of the contribution also is the viscous secretions which are secreted from the ethmoids. So postnasal drip again is a very, very important cause from progression from snoring to obstructive sleep apnea, and therefore the role of maybe ethmoidectomy or endoscopic sinus surgery in opening up the nose as well as removing the postnasal drip which is caused by ethmoids. So a CT scan leading into understanding of the ethmoids and turbinate hypertrophy and adenoids is a very, very important aspect to prevent the progression of snoring to upper airway resistance syndrome to mild, moderate, and severe obstructive sleep apnea. So the message here for all our ENT colleagues is that if we can stop the progression of a nasal disease turning into a pharyngeal disease over a period of 5 years, 10 years, 15 years, then possibly, and nasal surgery can be performed by every ENT surgeon very, very effectively. So my message, opening message for today's, SNORECON is that if you want to prevent snoring, if you want to prevent obstructive sleep apnea, then you have to treat the nose very, very aggressively right from the word go when you see the patient in the OPD. Thank you very much.
Thank you, Vikas. It is a chronology of snoring to sleep apnea. Very well explained. Now I will require.
Great show, because you're an innovative man, you know. You got some new surgeries. And even that explanation with the person slapping, I've never seen before. Is that your innovation? I've not seen it in any textbook at least yet. How it progresses through the years. And you gave it the simple slap. You gave the example. Great. Congratulations.
Thank you, sir. Rahul.
Now, I request Dr. Rahul Modi to take over the pathophysiology of consideration on USA treatment.
A very good morning to all dear colleagues out here. A big thank you to Dr. Vikas for the kind invitation. Always a pleasure to be a part of SNORECON and all the dear colleagues who are attending online, chairpersons. So I am yet again talking on my favorite topic, which is not just sleep apnea, but pathophysiology. Can we have the slides, please? Pathophysiology of OSA, and believe me, we are all surgeons at the end of the day, and this was one section that I felt that we used to all miss out during our ENT, that we used to never focus on. But sleep apnea is something difficult, very different from your routine surgical issues that we tackle. And the point that I'm trying to make here is this: bloodletting was the procedure of choice for all that was wrong in the human body for almost 2000 years till late 19th century also. And there were British textbooks which were describing bloodletting as a treatment of choice from everything from asthma, cholera, cancer, and convulsions. And that precisely came in because of the poor understanding of pathophysiology. what we are trying to do here is trying to decipher a big elephant in the room, where the pulmonologist feels it's a physiological problem, where the ENT kind of touches and feels it's the anatomical problem. The psychiatrist, Dr. Guy Minalt, and everybody who discovered sleep apnea for us thought it was a brain related problem, and it's perhaps all of that. And that's the reason you will find every specialty understanding sleep apnea in their own way. So the initial descriptions that came in for sleep apnea came up in the book by Charles Dickens, and where he described a child, typically Joe the fat boy, who had snoring, obesity, and daytime sleepiness. A child who was always sleepy throughout the day, was fat, chubby, and used to snore very loudly when asleep. And that's our initial understanding of sleep apnea too. We know that OSA requires recurring collapse in the night. It's not one time, it's recurring collapse of the pharyngeal airway throughout the sleep, leading to complete or partial cessation of breathing despite ongoing efforts. So it's not a person who is under the effect of alcohol or under the effect of some sedatives. It has to have ongoing efforts. So it is obstruction during sleep leading to apneas. Now, when we talk about the pathophysiology, how we understand is the person goes off to sleep. There is decreased muscle responsiveness, as Dr. Vikas has pointed out, leads to hypoventilation. Further reduced muscle activity leads to narrowing and collapse. There is increased surface forces. The person has an apneic spell, beyond which the breathing effort keeps on going, the saturation levels drop, and there is an arousal as a life protecting mechanism. If that doesn't happen, we lose the patient. The arousal essentially leads to reversal of all of this, and the person tends to fall back to sleep again. And what does recurring collapse causes? Recurring hypoxemia or intermittent hypoxemia, which is responsible for a lot of the symptoms. Along with that, repeated arousals or micro arousals lead to a fragmented sleep, which are responsible for the symptoms that the patient present to us with. So what are the consequences? So the first thing which really brought sleep apnea to the fore of doctors' imagination was actually the intermittent hypoxemias, which lead to increased pulmonary pressure called pulmonale, adverse cardiovascular events. Sleep fragmentation was, however, the first recognized downside by the neuro team, by the psychiatry team, which is essentially you're having repeated arousals in the night. So you will have a lot of neurocognitive challenges during the day. You will feel sleepy, not feel fresh, memory issues. And we are in a generation where sleep is a luxury as it is. Getting 6 to 7 hours of sleep in a city like Bombay itself is a big, big achievement. And add that the poor quality of sleep, and you are magnifying the symptoms which would have been physiologically milder. Now, when we know about the upper airway is our territory, the ENT territory, we understand it very well. There is a rigid portion, which is the nose. Then comes the larynx and the trachea, which is again rigid. However, there is an intervening collapsible segment between the two. And when we talk about the Starling resistor concept, which is the primary model to understand sleep apnea, what we have is the collapsible segment, which can be completely open, which can be completely closed, but more importantly, it can be partially open also. So depending upon the upstream and the downstream pressures and the flow, you will have the situation of the intervening collapsible segment. So when we talk about the physiology of the upper airway, what forces allow the airway to remain open? It's a good dilating muscle activity and a structurally large airway. And what causes collapse of the airway is the decreased intraluminal pressure, increased extraluminal pressure if there is a lot of fat around that tube. If there is increased compliance, inherently somebody has got a massive retrognathia, a Pierre-Robin sequence, you will have increased compliance because structurally that airway is narrow. And currently all our efforts when we talk about CPAP or surgery are guided towards maintaining that upper airway. So when we talk about therapeutic targets, what are we doing? We are trying to make the airway non-collapsible. Whether we blow it up with a CPAP or we operate, we are trying to act on that part of the pathophysiology. So if the anatomy is constricted, which is kind of like a static obstruction, the peak rate essentially becomes very high. The critical closing pressure is on the higher side. It's easier to collapse that airway, and a more collapsible airway leads to OSA. How do we treat it? Like we discussed, we give CPAP, we do surgery, we give oral appliances, and that has been, and even weight loss to a great extent works in that paradigm. Now, when we talk about what are the outcomes our, so to say, standard approach has achieved, CPAP, as we know, has challenges. Oral appliances, frankly, very limited applications in the select group of patient. And surgery, if you go through the literature, has variable outcome, which essentially, as a surgeon, if we don't have good predictability, we then shy away from intervening. So the question that comes in, if our model is so perfect, why aren't our results so good? Why is there so poor compliance on CPAP if CPAP is such a magical device? Why doesn't surgery give us guaranteed outcomes that we get, say, when we do a tympanoplasty, when we do a polyp surgery? So the question is, we need to go back to the drawing board and ask ourselves, are we missing an important fact in the link? And when we go back to the physiology that we studied in our first year MBBS, Guyton, Ganong's, we know that upper airway is a complex structure. It's not a mere pipe that you can blow up. There are mechanical issues which we have discussed, but there are other factors such as arousal threshold, respiratory variations, including the neurological drive to the upper airway to maintain the patency, especially while the person is asleep. So what research in the last 20 years have shown us that along with anatomical factors which decide the size of the airway, there are non-anatomical factors such as the arousal threshold, loop gain, and the muscle responsiveness. And up to 2/3 patients suffering from OSA have one or more unfavorable non-anatomical factors. There's too much of, it's a heavy sentence, but essentially 2/3 of your patients, we need to think about beyond the airway. So airway is not just a floppy tube which you can blow up to improve it. So we talked about the muscle tone. We know that the airway is a dynamic structure and the muscle loses some amount of tone when the patients go to sleep. What research has shown is in OSA patients, even when they are awake, they have to have a higher EMG activity to keep the airway patent. And they have very poor neuromuscular control when they go off to sleep. And to beat this, the new kid on the block, or rather not so new kid on the block nowadays, the hypoglossal nerve stimulation, essentially works by providing a signal to the hypoglossal nerve to stimulate the genioglossus muscle to keep the airway in the forward position. So there is an implantable device, pulse generator, which will sense your breathing pattern while asleep. You need to switch it on every night. And it kind of sends a signal to the tongue to go forward and maintains the muscle tone. However, even if you see whatever research has been done for this, they are very selective about their patient criteria. So the whole thought process is they are keeping the pathophysiology in mind even when prescribing the latest treatments. There are drugs being studied which, when taken in proper doses, have shown to improve neuromuscular response. So they have the noradrenergic drugs such as the oxybutynin and the antimuscarinic drugs such as the atomoxetine. And there are research trials currently going on. One of the trials are in phase 3, where they're trying to improve the muscle tone just through the pill. So perhaps we'll stop saying to our patients that there are no medications available to improve your sleep apnea, and hopefully we'll get a better answer soon. Simple exercises done on a regular basis guided exercises have shown to improve all parameters of OSA, more than 50% improvement in AHI, more than significant improvement in your Epworth sleepiness scores, oxygen saturation indices, and everything. So there is more to sleep apnea than just CPAP and surgery. Now, classically, when we think about OSA in our patients, we talk about them as sleepy individuals, our prototype being the Kumkarant, who is sleepy, who does not have a very high arousal threshold, who's difficult to wake up traditionally. However, what research has shown that up to 30% of individuals can have very low arousal threshold. So they may actually present with insomnia. But when you take their detailed history, the trigger for their insomnia is their snoring, is their obstruction event. So what you need to actually do in these cases is to work on their insomnia along with sleep apnea to get better outcomes. So you need to be very careful when you get such patients. And how do you identify these patients? When you get a sleep study, you look for their oxygen numbers. Their obstructions will be predominantly of the milder variety. The hypopneas will be more than the apneas. And their AHI number will be always on the lower side, but their symptoms will be out of proportionate to that. And you're actually giving them special sedatives to improve their arousal threshold, stabilizing their sleep, reducing the obstructions, and they get a better sleep. Coming to the ventilatory loop gain phenomena. So think of this way. When we are breathing, each breath when we take, awake or asleep, it is guided by our CNS. The drive is guided by our CNS. Thank you. And what loop gain is essentially, it is the degree of response that happens to the disturbance in breathing. And it is typically found that in patients with OSA, they tend to have a higher variation or a high loop gain. Sorry. Now, what are the potential treatments? Oxygen and acetazolamide is known to improve the loop gain. And if you combine both oxygen with a mild sedative, you can get an overall reduction in the AHI by 47%. And more than 45% of the patients, well-selected patients with oxygen and a sedation, had improvement in their AHI levels. Sorry. Now, think about the airway as extending from across a spectrum from 100, which is a wide open airway, to 0, where the airway is completely collapsed or closed like a CA larynx. Now, if the patient comes to us at 100, he will never have a collapse. And a patient with laryngeal CA will always have sleep apnea symptoms because he's not able to sleep. Problem is, most of our patients will come in the vulnerable anatomy zone, where their final outcome is decided by the non-anatomical traits. So you have a baseline exposure, an effect modifier, which is the non-anatomical trait, which essentially helps in deciding the outcome. So if you have a patient who have got a very compromised airway, you don't need a lot of contribution from the non-anatomical traits to make the person symptomatic. However, if you have a patient with a very wide airway, you need more contribution from the non-anatomical factors for that person to have OSA or not have OSA. So if you have a compromised airway, then your anatomical interventions will work very well. But if you have a wideish open airway, doing more surgery on him, giving him more CPAP may not give you that kind of an answer. So along with anatomical targets, we have targets where we can increase arousal threshold, improve muscle tone, so to attack the pathophysiology at multiple spots. And essentially, this is a PALM score which divides the category of the patients into 3 things. One is a very collapsible airway, very obese patients. Second is your middle of the line patients, which are about 60%, 58% of your patients, and the persons with a very wide open airway, a difficult to collapse airway. Now, in a very collapsible airway, you need something like a CPAP, you need something like a maxillomandibular advancement to improve their airway. And these are the patients for soft tissue surgery. So roughly about 20% of your patients, primarily, if you want to do soft tissue surgery, they'll give you excellent outcomes. However, close to 40% of your patients will need, or rather 50% of your patients will need good support from the non-anatomical interventions along with whatever you're doing for the airway. So combination therapy is the way to go forward. And how do I apply this knowledge? This is a paper I quote in most of my presentations. Dr. Seema has seen this often. It's a paper by Dr. Michael Friedman, very simple, written 20 years ago, and I still feel it's one of the bedrock papers for sleep apnea. Is essentially when I'm seeing a patient who's got a compromised anatomy, meaning he's got a surgically favorable anatomy with large tonsils, a low tongue base, wide open skeletal framework with a lot of soft tissue in it. If I operate this subgroup with a simple surgery, I will get a good outcome. 80% success rate as per the Shares criteria. There is a lot of controversy around that, but that's the message that I want people to take home today. Now you make the anatomy equivocal in the sense you compromise the skeletal framework a little, you reduce the size of the tonsil or increase the tongue base, your surgical rates become half. If you compromise the anatomy further, if you get a high tongue base with a tonsil grade 1 or 2, your success rate is 1/10 of what you will get. So as surgeons, we treat anatomy. We need to take that anatomy in context with the larger pathophysiological picture. We can't just focus in isolation because otherwise we'll get, you saw the difference in results with a simple change in the name. So what's the take home message? That we need to understand the various factors when we are treating OSA. Anatomical factors have to be treated by anatomical traits. Weight loss is an anatomical intervention. CPAP is an anatomical intervention. Surgery is an anatomical intervention. Non-anatomical factors need combination therapy. So you need to keep that mind open. And treatment of OSA should be tailor-made to each patient so that we don't get this kind of a scenario for our patients. Thank you so much.
Thank you, Rahul. Going back the history, Charles Dickens
Yes.
and the fat Joe boy.
Yes.
Thank you so much for the
you.
information you have disseminated. Just for you and because do you always do a sleep study before planning a surgery? Or
Oh, absolutely. We're going to discuss that, but you don't touch a patient without a sleep study.
Okay.
Yeah. I mean, you're doing a sleep apnea surgery. It's like you won't give a diabetes medication without knowing the blood sugar
But
levels,
it could
right?
be a clinical diagnosis also, no? Sleep.
No, I mean, in adults, I don't think so. We're allowed to do that. I think there is enough guidelines now to say that we should do a sleep study. In pediatrics, yes, you are allowed to do a clinical diagnosis. But in adults, I don't think you can get away without, because the problem is if you're unable to cure the sleep apnea and the patient will get a sleep study done post-op and will show some, you don't know how much was it before, right? You don't know what levels are you starting. You may start with an AHI of 100. You operated, you made it AHI 25. You did a fantastic job. Patient is going to come back and say, doc, he doesn't know he had 100 before, right? He's like, doc, I still have sleep apnea. What have you done? It's like doing an audiometry before doing a tympanoplasty. You don't know whether the ear is dead or not, right? You need to know before going in. You may have done a very good repair. Patient will say, my hearing is not improved because it was a dead ear to begin with. So it's very essential to know what you are dealing with, because your surgery may not change in that sense by looking at the sleep study, but your counseling will change a lot. Your entire planning will change a lot. You want to set the patient's expectations properly. You want to know what is your starting point. So
Your quote mentioned weight loss. Is it a very important factor?
100%, but the patient needs to be overweight for that. I mean, it's not necessarily. So, I mean, we're going to highlight in our presentations later on that in patients with moderate to severe OSA, less than 50% of them are overweight. So it's not a weight issue anymore. Weight is an important factor for a lot of our patients, but we cannot blanket. There are patients who are thinner than I am, having frank OSA, all the symptoms, younger than I am, so to say, fitter than I am. But I mean, it's a compromised airway issue. You have to correct a
Fitter
compromised.
than you, difficult to believe that.
No. So there are, I mean, I have doctors who are in their 30s having frank symptoms. That's because what Dr. Vikas has showed, a compromised nasal anatomy, all symptoms of OSA. So, I mean, you need to fix that. I mean, so it has to be custom made. The whole message is it has to be custom made. We cannot give a standard weight loss advice to a guy whose BMI is, 20 to 23. It's not going to work. So
Thank you
that's
so
the point.
much, Rahul.
Sure. Thank you.
We welcome Dr. Rodolfo Lugo, who's going to speak on CPAP versus surgery, how to proceed.
Hi, Rodolfo, can you see me?
Yes. You can hear me?
Yeah. Can you increase his voice a little? Yeah. So just a word about Rodolfo. Rodolfo is from Monterrey, Mexico, and he's one of the world's most sought after speakers now. And he's a great person. I'm sure must be sitting with a wine in his hand at 10:30 in the night. Is that right, Rodolfo? Can you show me a beer? Wine? Show me a glass. Yes. See. So fine.
It's a night time.
Yeah. So over to you, Rodolfo.
Thank you, because it's a big honor and for me to share this moment with the Indian gang. This is a sleep surgery big group in the world. The Indian sleep surgery group, the IASA is one of the best groups in the world, and it's a real honor to me. Thank you for the invitation. And I talk about the CPAP versus surgery, how to proceed. And it's like the Dr. Raul and Dr. Vickers talking about that. This is a very complex problem. I live in Monterrey, Mexico is in the north part of my country. It's the second major city in my country. 6 and 7 million people live here. It's a very industrial city, a lot of business, and I welcome you anytime you want to come here. And it's two options here: the surgery for improving CPAP or CPAP therapy compliance of alternative treatment. You need to select this kind of patients, and this is a clinical aspect of all that issues the Dr. Raul and Dr. Vickers talking about. Is the 3 types of patient. It's not 3 types, but this is very simple to explain. Separate these patients in three big groups. The classic symptoms patient, the 42%, almost that. The don't sleep well group, 33%. And I feel good. I only have a snoring problem. I don't have any problem with my sleep, and I don't feel anything. I only snore, the 25%. And we need to focus in this kind of last group, the I feel good patient, because that's so hard to have a good complaint or CPAP a good complaint. And this is a little algorithm we work here. The difference on the no CPAP user, the no adherence, no poor compliance CPAP users. The patients who accept the CPAP but has a suboptimal use, 2 hours, 1 hour, 3 hours, and they don't want the CPAP. Yes, it's good for me. I have a good outcomes. The pressure is going good, but I don't want to use it. And this is a very common group of patients. Yes, we need to go back to see the nose. The nasal function is a key factor in this kind of patients, and we can mix and tailor the treatment. Like Dr. Raul says, this is no a kitchen recipe. All the patients have under the same treatment. I think this is so wrong to do. We can choose between the dyes, looking for oral appliance titration with CPAP. After the nasal surgery, go to the new titration of CPAP. In the patients they don't want to use CPAP, looking for alternatives, sleep surgery and oral appliance. These kind of patients, that's very common to see in our office, and they go under the nasal surgery. We can make the dice previous to nasal surgery and looking for a new titration CPAP after the nasal surgery, or going some months after that to a sleep surgery. Depends of the outcomes we can looking in the dice. The fact is the nasal surgery improves the snoring. In some patients, it's not common, but in some patients uh, feel a little difference in the snoring. The daytime somnolence is going good. The quality of life, yes, it's going good. The effort, and the quality of sleep going good. And in the CPAP, compliance is good. Is good. When I go into nasal surgery, a lot of papers talking about that. The daytime somnolence, the quality of life, nasal surgery for snoring, the clinical indication of nasal surgery for CPAP intolerance, nasal function and CPAP use in some patients. It's a lot of papers talking about that, and exists a link between the nasal resistance and the CPAP compliance and oral compliance. This is a good point because it is the key for the door of the sleep surgery and sleep medicine. We need to maintain our focus in the nasal resistance. This is a real fact. A lot of papers talking about that. And, management of the nasal resistance optimize the CPAP or the oral appliance too. We saw a lot of papers and studies talking about that. The resistance with positive airway pressures, the weight measures for nasal resistance to resistant CPAP during the sleep. The relationship between the nasal resistance and the CPAP compliance is very, very, very strong. And if you see a younger patients, it's very, very common to have a problem with the CPAP adherence and the CPAP compliance. In that group of patients, we need to focus in alternatives. And the DICE is a very good tool to show to these patients in the office the alternative we can present to the patient, and they can select or suggest to this patient we can do. But all the patients in study, all the patients going to a sleep study, all the patients going to a CPAP titration. That is a fact. In all the patients, we can do that. I never jump that steps. And another fact is the nose is more than 50% of the total resistance of the upper airway. Is that the reason Dr. Vikas talking about that? Is you have a good nasal function, it's your green light to make forward to sleep surgery. If you don't have any nasal good function, you don't think to make forward because it's a problem with you have a problem with the nose. And the nose is our field. Is that the reason with the ENTs going to the sleep surgery? We need to be a good rhinologist. If you want to be a sleep surgeon, you need to be a finest rhinologist. This is a must. If you want to be a sleep surgeon as an ENT, you need to have a good experience in rhinology surgery. Is that the reason we need to take action when you see any problem in the function and nasal function in this kind of patient? This is a example on our patient with a poor adherence of CPAP. Look in the oral breathing there. It's typical. And in the first step of the dice, you can see the epiglottis in the floppy pattern there in the inspiration. Okay. Is that the reason always we need to put the CPAP during the dice? This is a good inspiration in the long duration dice. And you can put in different pressures, and you can see The epiglottis collapse is still there. 5 centimeters, 8 and 12. Is that the reason this kind of patient has a problem with the compliance? And we need to take action in this kind of patients to offer some tailored treatment there. And, this is another, sorry for that. This is another sample of the CPAP dice. And this young patient has a problem with the CPAP, with the epiglottis too. And look the higher pressure he needs to break the collapse there. High pressure means low compliance. Is that the reason we need to going back to be a good rhinologist and looking for all the anatomical specs of the nasal functional issues? Because the nasal valve, we need to be a good exploration, explorate the patient, explorate the nose in the office, looking for the valve, looking for the problem like that. And there's a lot of studies about the Bernoulli effect of the Starling resistor theory of the nasal passage of the airway in the airway, and you have a problem in the first part of the airway tube there. You have more collapsible problems in the under part, in the flexible part of the upper airway. So you have something like this, a problem with the nasal valve and the anterior problem and the anterior aspect of the nose. You need to go back to go there to correct there. And nasal resistance, the oral breathing, and the increased collapsibility of the upper airway. And you go to the operation room to suggest a nasal surgery in this kind of patients. You can perform anything you want there. You have experience with the turbinates, the valve. One of the most common procedure we perform in the office is the reduction of the turbinate in CPAP users, and you can perform that in a very easy way to coblate with the coblation or decoblation, all that devices there under local anesthesia. You can insert the probe there, and you can reduce the volumetric reduce of the turbinate, and that is the point of the optimizing the CPAP therapy. Another kind of turbinate reduction surgeries under the operation room, like the microdermator, the inferior turbinectomy techniques. You can do anything you want in the turbinates because the most important fact is the outcomes. If you have a good experience with the turbinectomy, it's okay, but you need a very good experience with that. And the valve. The valve, some patients is very easy to explore. This patient is, has a scarring problem in post-septal patient, but it's not that easy. You need to make more finesse aspects in the valve problems. And you can perform anything you want in the internal nasal valve, like the sprayers, graft sutures, or in the internal valve and the external nasal valve. This is an example patient with a post-rhinoplasty, has a lot of problem with the nasal breathing and oral breathing aspects. And you can see the collapse there in the inspiration mode, and you can see the nasal valve there in the endoscopic view. And after the surgery, you need to correct that with the rhinoplasty techniques. And in the inspiration mode, the nasal valve is correct, and the millimeters, you can see the difference in the nasal valve endoscopically. And another kind of maneuvers and procedures like the suspension of the nasal valve with external suture stitch technique. This is a very old technique. This is mentioned in the Friedman book and another kind of rhinology books. This is for patients with a lot of surgeries, previous surgeries, and they don't want to go to the operation room right now anymore. This is the reason you can make this procedure, but this is a little relief in the bulb. You can do that, or with the barbed sutures. I have a little procedure with barbed sutures on the directional with a beadlock, and you can put the barbed there. It's very easy to do, and you can perform a suspension with that suture. And a lot of papers talking about that, how to proceed and select the patient with the management of snoring of sleep apnea, with a tonsillectomy, with a nasal surgery, and this is very important to see the level, the pressure level of the CPAP titration. This is one of my important points in the clinical aspects of the office. You can see the patient there, go to with CPAP. He says he's a lot of issues there. I have a lot of problem with the pressures. You can go to see the pressure level, and you can reduce it with a lot of procedures. We are the only doctors in the sleep medicine area. We can reduce the pressure with the surgery. It is the reason it's important to be a good rhinologist in this aspect. And in this paper talking about that, in another paper, look in this kind of patient with a combination of surgeries there, and may increase the other CPAP. Look to pressures in this paper from Brian Rottenberg talking about the levels going down after the surgery and pressures in the CPAP. And this is a very classical paper talking about the nasal surgery in sleep apnea patients, and another classical, the Horman and Bear's book. This is one of my patients with CPAP pressures pre-op. You can see the level of the pressures in 10.9 in the 19.5 percentile in the radar, 10.9. All right, we can go to make the nasal procedure. You can choose if the patient has a wet problem with the turbinate, the patient have a bell problem or lateral wall problem or polyps problem. Any you have in the nose, you correct it. Go to the retitration, go back to the CPAP titration, and you can see the pressure is going down in this. This is the very important clinical aspects. This is no CPAP versus surgery. In sometimes the sleep surgery, the nasal surgery is the best ally of the CPAP. Is that the reason we can choose these outcomes in some patients with that difference? And this is very good because you show these outcomes to the pneumologists or the neurologists, and remember the patient, the pressure is going down and has a good adherence and good compliance. Oh, and you can, why? It's always very often that doctors ask me what kind of procedure I perform, like recite, it's a turbinate, it's a septal, it's a rhinoplasty. No, it's tailored treatment, depends on the patient. In conclusion, low pressures, better compliance, nasal surgery, CPAP optimization concept, or select the ideal patient or sleep surgery after that. You going back to CPAP, the CPAP is no good. Okay, this is a select patient. You can go to alternative treatment like the sleep surgery, multilateral surgery, and all of the stuff we can do in this patient. This is the last paper talking about that. It's a myth or reality to take out the CPAP in selected OC patients. It's the Italian group, and it's a good. In 26 patients, we have a good percentage of success in this paper. In the last part of the lecture, I want to invite all the Indian sleep doctors and colleagues to go to Panama in the next year, in April 14 to 17, in Panama City. The combined Sleep International Sleep Disorder Academic Congress and the Ibero-American Sleep Surgery Society, the society sister, the brother society of the ASA, and I hope to see a lot of Indian sleep doctors there in Panama the next year. And we hope to see you there. This is the International Sleep Breathing Disorder Training Fellowship combined with Italy, United States, and Mexico. 6 months of training for young doctors who want to get more involved in this area. they're invited to see this option to young doctors. And this is some of our fellows of the Mexican group or Latin American group is all my former fellows to that program. And this is my some of the Indian Sleep Power Group, and I'm very honored to this invitation, and I love your country and eager to return in the next year and soon go to the India right now. Thank you for the invitation and see you soon.
Dr. Rudolfo, just to your
Thank
talk,
you.
but I don't have a glass of wine to, but you can
It's a
have wine
night.
you have it on my behalf. Not only I have to thank you for your wonderful talk, I have to thank Dr. Vikas for calling you here. Just one thing, you do this DICE procedure, which patients you select for it?
The DICE, your question is about the how select the patient to DICE?
Which patients you do it in? DISE. You do it routinely?
Yes. When the patient is going to the office with looking for alternatives and the anatomical aspect of these patients is suitable to alternatives, I'm going to the DICE. The only point we have a little difference is in the nasal aspect of the patients. It's like at a CPAP optimization patients going to the nose surgery. Okay, we can look for a little DICE previous the surgery to put the CPAP there, to looking for another obstruction secondary to the nose. And that is the only difference we can perform. A DICE in a nasal optimization surgery or CPAP therapy, but this is the only difference. But yes, I perform a DICE, a long duration DICE with oral appliance titration and CPAP looking pressure CPAP using in all my patients to go into sleep surgery protocol. Yes.
You showed the cases of nasal valve collapsing.
Yes.
And you showed the reconstruction you do. Have you done a reconstruction with a cartilage to strengthen the nasal valve?
Well, yes, I try to perform a lot of techniques involved. You know, it's very complex area, but this very important to looking for that, because a lot of nasal surgeons in the world forgot the nasal valve aspects with these patients, and these are the reason we have a lot of patients after the surgery, rhinoplasty, septoplasty, or any nasal surgery, has a complaint on the nasal valve. And that's the reason we need to focus in that techniques, procedures like Dr. Pickers do. And another kind of procedure we can perform in the mucosal aspect of the cartilage area of the nasal valve.
Thank you, Dr. Rudolfo, and cheers to
Thank
you.
you. Thank you. Thank you. It's an honor. Hope to see you soon, my friends.
So now back to basics. Yeah, back to basics. We have been taught how to take history and the importance of history taking and examination. So I invite Dr. Simap Sheikh for his talk.
Thank you. Thank you, Vikas, for having me here for SNORECON. Thank you, Cipla, for organizing the logistics to get all of us here together. Good morning, dear chairpersons. Good morning, all friends here and offline. At the outset, I have my disclosures in strict accordance with NMC guidelines. Today, I have a very simple yet daunting task of trying to tell you about history taking, which is like one of the simplest things. But sometimes it gives us so much more information that if you ask them the right questions, you'll probably know a lot of things that you can do with regards to how you want to progress further. I'm going to restrict my talk to history taking, clinical examination, and a few of the things that would be probably part of your first consultation with the patient. And that's something that you've got to do in the 20-25 minutes that you have. So the first 5 minutes generally go in listening to the patient. You've got to listen to them. You can't just go on, sorry. You can't just go on asking your questions. So the listening takes about 5-6 minutes. You've got to be a patient listener. Then you pick up a few things while you're listening, while you're talking. And that's how you take it forward as to how you're going to formulate what you're going to do next. We definitely strongly recommend FNLP as a part of your examination. It's not something that you do it separately. It's like when you do an otoscopy, it's part of your clinical examination. FNLP for sleep is exactly that. Bring you greetings from Pune. It's the Oxford of the East. And we do understand there's a huge underdiagnosis here because the incidence is very, very high. You can imagine it's to the rate of 19-20%, which is very high. And then the patients are going to present to you, not directly, at least now they do, but generally you will have to maintain a very high level of suspicion and you will have to ask those leading questions. But as you start a niche sleep practice like some of us do, you're going to get patients who are going to give you all kinds of symptoms. They're going to come and talk about insomnia. They're going to talk about sleepwalking. They're going to stop talking about bedwetting. So you have to first figure out and differentiate these. You don't want to be dealing into parasomnias, dysomnias. We are looking mainly towards OSA. And when we look at OSA, this is what we are actually going to be looking at and asking them. You've got to look at symptoms of gasping, choking episodes. You've got to look at symptoms of snoring, early morning headaches, and the very characteristic giveaway is the not feeling fresh in the morning, along with, of course, daytime somnolence. But the not feeling fresh in the morning is a very, very straightforward giveaway of underlying sleep apnea. But now the question again about snoring is this. Are you going to be actually evaluating all the snorers who are post drinks in the night? Are you going to have those who are occasional snorers or the habitual snorers and the heroic snorers? And the answer is very simple. We are looking at only the habitual, heroic, or any snorer with quality of life issues or with daytime somnolence. We're not looking at the occasional snorers. There are plenty, dime a dozen. We're not looking at the ones after alcohol. We do understand that. But you have to look at all of these very specifically. And when we look at them, what are we actually trying to elicit from the history and all this examination? We're trying to differentiate what is simple snoring and snoring with sleep apnea, because the treatment would be totally different. A simple snorer is like somebody given to you on a golden platter. He's the right person for you to treat, fantastic success rates. The one with sleep apnea, we've got to differentiate whether he's going to be an obstructive one or a central apnea one. And again, out of these, whether it's snoring or whether it's the sleep apneic, you are trying to locate where is or are the obstructions in this particular patient. So that being our aim, we also in that same history and examination have to try and understand a few questions in your own mind. Are we looking at skeletal or soft tissue obstructions, or are we looking at them both? Is it a single or is it a multi-level obstruction? Is it likely to be surgical or non-surgical? Can you get away with very simple office procedures, or will we require something very complex? Now, understand that in those 5 to 10 minutes and 15 minutes, these questions must race through your mind because you've got to give answers to the patient after your first consult. So some rough ideas. And therefore, all your important history taking, will be directed to everything to do with quality of life quotient issues. So everything that the patient has a difficulty with quality of life, you've got to try and elicit that. But also understand a few other points. How has that patient reached your clinic? When I say this, I don't mean how by car or truck or whatever. I'm talking about, has his wife brought him? Has his spouse brought him? Or has he come on his own? Because that will give you a very, very strong indication of his motivation and whether he's going to continue forward with treatment or not, or is he just a casual consult that has come across to you. You also need to understand whether he understands the disorder and a rough idea of his background. That doesn't mean I'm asking him what is his annual income and I'm asking him to put it down on a paper. I'm trying to understand from his background whether a farmer coming to me is not going to give that much importance to his snoring vis-a-vis a person who's in the corporate world, who's going to definitely give a lot of importance to his problem. So the socioeconomic status along with the profession of the patient, because again, like I said, if it is affecting his profession, if he's an employer, he'll have a different attitude. If he's an employee, he'll have a different attitude. So the employer is a boss. He will have his own way of dealing with problems. He's the boss of the company, he's whatever. So that is important, because if he's an employee, his work performance is getting affected, and this is important for him. Otherwise, he's going to get sacked. He's going to lose his job. You also have to try and get an idea without intruding into anybody's private life as to any kind of situations that are happening in their marital background. So that's something you have to elicit, or rather the spouse herself will tell you. And without exaggeration, 80% of couples with these kind of problems are already those who can afford to sleep in separate rooms are sleeping in separate rooms in today's date. So this will also give you kind of an idea. The other thing you would want to know is, where are they coming from? A person coming to you from within the city is very different in the management protocols that you will follow from somebody who's coming from outside the city. It will also be very different from a person who is outside city, where you need to get investigations done at a faster rate as compared to somebody within the city. You also have to try to identify over here, when you generally start a niche practice, you will get people coming to you from different parts of the country, different parts of the cities. You have to try and understand whether has this person really come to you just because he's heard your name and he wants to put it on the bucket list. कोल्हापूर मधनं मी जाऊन मुंबईला पुण्याला यांना भेटून पण आलोय, पण तरी काय झालं नाही. Because these people are difficult ones who will create the reputation for sleep apnea treatment. So you've got to try to judge this within your history taking in those first 15-20 minutes. If he's just come here to tick the box that I went and saw Dr. Seema Abhishek also, then that's not the kind of patient that you would want to be very happy about. But the presence of comorbidities, obviously you will need to ask diabetes, asthma, blood pressure, because these will affect your treatment protocols in the future. This changes in pediatrics, because this is not the same history that you're going to elicit from the pediatric patient. You're going to look at hyperactivity, you're going to look at mouth breathing, snoring. Bruxism becomes very common in children. Bedwetting is a very big issue, but the most important aspect I give importance to is the scholastic performance. And that does not mean we're talking about last unit test to this unit test, his marks have decreased. No, you look at the scholastic performance over a period of about 6 months to a year. And if there's a gradual decrease, then that is worrisome, and that requires faster and earlier intervention. So when we talk about examination part, besides the history taking, this is all the armamentarium that we have, out of which cephalometry is nowadays redundant. We don't do it. Sleep nasal endoscopies in India are not available. So we stick to whether the clinical evaluation, the FNLPs, and the dynamic MRIs or DICE, as we normally talk about. In a clinical examination, it's right from the beginning what you assess with the way that patient walks in with his body language that tells you whether he's already in some stages of endogenous depression, motivation issues, he's just fed up and he's just here for just another consult. These are things that you need to pick up when you're dealing with the patient as they enter in. You read a lot about collar size and this and that. I have till date not measured collar sizes. I've never asked them for collar sizes. It's all for academic things to write down. But you are overall judging the obesity issues anyways. And that patient walks in, you're looking for central obesity, you're looking for neck adiposity, you're looking for any other thing overall that you find is going to affect your treatment protocols. And then when you actually get him to stop talking and take him to the examination place, this is not for me to tell you about how you look into the nose and how you will obviously see a structured deformity there. About the oropharynx, you'll see large tonsils, maybe an uvula. Rahul has already spoken about Dr. Friedman's paper in this, which is a very characteristic one. You can all read about it. But the basic thing, what we are looking at is the tongue position and the size of the tonsil, which will give you a rough idea. So clinically in those 10-15 minutes, again, if you're looking at a bigger size of a tongue, if you're looking at larger tonsils, you're getting a rough idea which and what position of Friedman you're trying to put them in. And based on that, obviously the surgical outcome for palatal surgeries would differ. It won't really tell you much about the surgical outcomes for your other surgeries, but at least you have a better idea that if I'm dealing with a huge base tongue or a huge tongue, in fact, because like Vikas says, you don't see the base tongue from the outside, you will not be able to do very good surgeries for the palate in such patients. So that's what probably Friedman just tells us about. And in the scopic evaluation, so you've done with your history taking, you've done with some judging, you've done with some clinical examination. And then when you go to the evaluation with the scopes, we are only going to do either the FNLP, which like I said, is part of the regular clinical examination, or that you do a DICE or a dynamic MRI. We will discuss across the day. But what's important to see here is you are going to have to look at not just the AP collapses that we are normally training our eyes to look at, but you will be looking more towards the mediolateral collapses also, because that's how the patterns are changing now. And you need to be able to judge this in your typical evaluation. So you might just see something like a huge tonsil there, which is blocking that entire airway, but below, down below, everything looks nice and open below the tonsils. I'm unable to forward it from here because of the, just give me 10 seconds and everything below that is quite clear. So let's not, or you might have something like a completely collapsed epiglottis that even Rodolfo was showing you, and that could then give you trouble for usage of CPAP. So let's not get there. Then we went into advanced DICE to be discussed later. But then in short, what is the protocol that you would follow? So you will follow the typical history taking and try to evaluate in those first 7 to 8 minutes of that. Then there is 2 to 3, 5 minutes of your examination part. And then after that is the next 5 to 7 minutes or 10 minutes where you really have to sit down and explain everything to the patient and the relative if they're there. So you've done a history taking, you do a clinical grading, which gives you a rough idea, reasonably rough idea, not a complete idea. And you do an FNLP where it is. And on that day one itself, in your first consult, the patient leaves by filling out an ESS form or any stop bank questionnaire that you prefer to use in your OPD. You schedule the sleep study at that same day or that same night, along with the CPAP trial. And if there are associated conditions of allergic rhinitis and things like that, you make sure you treat that before you get into the evaluation part. And in that first day consult itself, you've got to keep it in mind, because by now in those 10 to 12 minutes already while talking to the patient, you have an idea of what he actually expects from you. What is he here for? And if his expectations are not exactly what we are supposed to be talking about in sleep apnea, then you've got to make those changes. You also have to judge in that what is the patient's comfort level, what are his choices. There are some who will come and tell you point blank, I don't want any kind of surgery, what else can you do for me? There are some who will come and tell you, I'm using CPAP, but I'm fed up with CPAP, what can you do for me? So you've got to understand their choices and keep your own self-training and expertise in mind. And in a previously operated patient that comes to you, it's very important to take this kind of a history. What were his issues then when he's come to you? What are they now? Was a sleep study done that time? If it was a level 3 done, then this time you might want to go for a level 1. You need to know that. Was a DICE or an FNLP plus Cine MRI done at that time? And what were the findings? He should have them with you so that you can compare it with what you have now. Was a CPAP trial done that time or not? If at all any procedures were performed, what were the procedures performed? Were they performed single stage? Were they performed multi-stages? And what were the results, outcomes of that? Were they checked with a repeat PSG or not? These are important histories in an operated patient. Were there any intra or post-op issues at that time? And what are his present expectations? Because when you have to evaluate these patients very properly when they're operated in a UP or any palatal procedures early, and you'll probably find a lot of things as you see below, that the patient has been operated for a palatal procedure, but they probably missed out on quite a few things along the way. And that's what you've got to locate. So you will see over here as you go down that the AP collapse still persists. There is a little bit of salpingopharyngeal folds that are coming in. And as you go down, you will see a very huge tongue base, which probably was missed for whatever reasons. and a collapse of the epiglottis that was missed at that time. So that is why in an operated patient, it becomes very important. This is even pre-DICE. This is just in an FNLP. This is your part of your routine evaluation. So the other few topics you may need to touch on, I won't go into detail, is how you kind of give them what is success of treatment, because they will ask you. So you've got to give them a rough idea about downgrading your problem, improvement in quality of life. Don't talk with terms of cure and things like that. You may have to give them an idea, like what Rodolfo said, that there's CPAP versus surgery. There is surgery of two types. There's surgery for CPAP optimization, and then there's actually surgery for surgery versus CPAP. Figures are there for you. It's there in literature. There are things that you will have to talk to them without rubbishing away CPAP. Because we do right now acknowledge that probably for lack of better evidence and lack of better words, CPAP is the gold standard. But you will have to give them an idea that CPAP is not the final answer, as was once thought earlier. There's lots that we can do, although surgery is also not the final answer. And in a broad perspective, these are the kind of patients that you will select from that history taking and this about taking up for surgery. This is a very broad surgical candidacy, where we as ENT surgeons will not give too much importance to the AHI. We will talk about that through the day. We will not give that. We will be looking at the anatomical obstructions and try to get rid of those. Like I told you in the beginning, primary snorers will be given to us on a golden platter. And anybody who's had a failure of CPAP compliance obviously is somebody that we need to look into. And BMI, we try to keep below 30 as much as possible. So do understand that surgeries are not technically demanding, but it is the application of the mind and the selection of that cases, and that starts from your very first history taking and clinical examination as to which ones you will take forward. Thank you very much.
Dr. Simab,
Sir, sorry.
thank you so much.
Thank you, sir.
That was extraordinary, I must say.
Thank
But
you, sir.
what is the heroic snorer? What do you mean by that?
So heroic snorer generally is defined as a person whose snoring can be heard behind a closed room.
I see.
So outside the room with closed doors, if you are able to still hear his snoring, that's termed as a heroic snoring.
Okay.
And there is no dearth of heroic snorers, let me tell you that. There is no dearth.
What is the full form of FNLP?
A flexible nasolaryngopharyngoscopy.
Okay.
Sorry,
You kept mentioning that
yes,
right in the
I
beginning.
shouldn't be putting, but
Yeah.
it's a SNORECON. So
I have to thank Dr. Parikh, my co-moderator.
thank
Of
you.
course, Vikas, the pioneer
Absolutely.
in snoring and sleep surgery.
Absolutely.
Well,
Because
I'm
of whom
sure
we are all here
He's
today.
done most cases in India. That's what I'm sure. Thank Orient and
Cipla.
Cipla. And one more thing I have noticed, to become a sleep apnea surgeon and to become a surgeon for snoring, you have to be young, handsome, and dynamic. Like all the three speakers, including Rudolfo.
Thank you, sir. Thank you for the compliments.
So thank you so much, Dr. Simab. So with this, we come to end of session 1. So I would now request Dr. Vikas Agarwal to share a memento to our moderators. Yes. So we would now begin with session 2 on sleep study, which and when, by Dr. Prashant Chajid. So I welcome. Okay. And the moderator would be Dr. Milind Navlake and Dr. Rashmi Menon. Okay.
Good morning, everybody. Thanks, Cipla, and thank you, Dr. Vikas Agrawal, for arranging such a nice conference on snoring and OSA. So, I would call upon Dr. Prashant Chhajed to talk on a topic which really bothers most of the clinician, you like me also, that which sleep studies to do in which patients and when. So, Dr. Prashant Chhajed.
For this invite. Yeah, thanks Vikas, thanks Cipla for organizing it. So I think the topic, I mean, amidst all the surgeons, I think I'm coming from a physician's perspective about sleep apnea, and I think the topics are extremely important. Sleep study, which and when. I think this is a very important topic, just because of the fact that there are different types of sleep studies available, and then one has to choose which I should do when. So I just want to also give a disclaimer. I'm a clinician, researcher in interventional pulmonology, but yes, I practice sleep medicine. So yes, we have a sleep center. We do a lot of sleep work, but the research focus is pulmonary interventions. So now, I think the important point about sleep study, which and when, I think such an important point to be discussed. So what I'm going to do is I'm going to talk about the factors and the aspects leading to or associated with associated to the sleep study, and then which can help us to decide which one would use. I mean, how does one go through that pathway? So I think sleep apnea is already discussed, but just to tell you the briefly, pointer. Thanks. So just to tell you briefly, I mean, sleep apnea is about pauses or breathing or shallow breaths. It is associated with oxyhemoglobin desaturation. We all know that there is desaturation, but there's also an important point, arousals or oxyhemoglobin desaturation. That means you have a pause in breath, which can lead to a drop in oxygen. It may not lead to a drop in oxygen, but it leads to an arousal. That means electrically, if that individual is getting aroused, then yes, that is also sleep apnea, and we will discuss that. So we have to discuss about the respiratory parameters. We have to discuss about the oxygen related parameters, and then we have to discuss about the neurological parameters. So what are the definitions of sleep apnea? And every point here is going to lead us how we decide to do which study and when. So sleep apnea is decided as a cessation of breath flow for 10 seconds. You have obstructive sleep apnea, you have a central apnea, and you have a mixed apnea. I'll show you the examples of what an obstructive sleep apnea and a central sleep apnea means. In an obstructive sleep apnea, there is an actual physical obstruction in the upper airway. In the central airway, there is a central mechanism where the individual is not breathing, but there is no obstruction to the airway. That is the central sleep apnea. And you can have a mixed sleep apnea. When we talk about mixed sleep apnea, you have obstructive component, and then you have central component also. Okay, one important thing to remember whenever we talk about central sleep apnea is in clinical practice, it's cardiology. Okay, if you've identified a central sleep apnea, you always need to evaluate for cardiological issues in those patients. Of course, there are other reasons also. Then, we always hear about apnea hypopnea index. That's all discussed. AHI, this is less, this is more. What is AHI? It is calculated by the number of apneas and hypopneas occurring per hour. And there is a way how one defines an apnea. Okay, there's a way how one defines an hypopnea, and then you divide that by the number of hours of sleep. Again, the important point is number of hours of sleep. So you can have a sleep study where the number of hours of sleep studies can be accurately calculated, and then you have a sleep study where you cannot calculate the number of hours you actually slept, but you can only have the amount of time of recording. That means the recording might be 6 hours, but you might have slept for 4 hours. Okay, so there are some sleep studies which will not tell you the difference between these. Then there is something called the respiratory disturbance index. So what is the respiratory disturbance? Apnea, hypopnea is very clear. You have an apnea. What is apnea? Apnea is a complete closure. Hypopnea, there is a definition. You have a 30% reduction in the airflow. And then that gives you an AHI. And a respiratory disturbance index gives you apneas, hypopneas, and respiratory effort related arousals. That means this individual can have a arousal. That means the brain is waking up because there is a reduction in the airflow, but there may not be associated oxyhemoglobin desaturation. These are called RERAs, and for this purpose, you need to have an EEG. Without an EEG, you will not know whether that individual is waking up or that individual has an arousal. Okay. Then there are different definitions here. You have Chine-Stokes breathing, you have complex sleep apnea, which can, there's an emergence of sleep apnea or central sleep apnea. Once you give CPAP, we will not go into that. Then you have a definition of hypopnea. There's a clear decrease in the amplitude of airflow. That means there is an obstruction of more than 30%, or there is a reduction, which is a valid measure of breathing of more than 30%, and there is an oxygen desaturation, and the event has to last for 10 seconds. So to simplify it, you can have an apnea as a closure of breathing. The airflow has to be paused for 10 seconds. You need to have a reduction in the amplitude of at least 30%. That is hypopnea. Complete is apnea. Okay. And then the event has to last for 10 seconds. Then there is a respiratory effort-related arousal. Whenever the word arousal comes, you can only talk about arousals when you have an EEG. Okay. And there are different types of sleep studies. As I said, all sleep studies will not tell you whether the individual is arousing or not. Then there is something called an upper airway resistance syndrome. I think this was already discussed earlier, so I will not get into that. You have obesity hypoventilation syndrome. Now, is every sleep apnea is an obese person? So is every obese person having obesity hypoventilation? No. For obesity hypoventilation, you need to have an increase in the carbon dioxide levels. That can be done by checking a ABG, or that can be done by taking transcutaneous CO2. A very important thing which is often missed is an overlap syndrome. What is an overlap syndrome? In clinical practice, very important. You have a patient with sleep apnea. Okay. You have a patient who has underlying COPD. And in several of these patients, if they have a severe COPD and sleep apnea, CPAP will not work for these patients. These patients may need a bi-level device. So if CPAP may be inappropriate in some patients with a overlap syndrome, we'll discuss this as we go further. As I said, this will be discussed by the surgeons. You have in an obstructive sleep apnea, you have a closed airway. In central airway, in a central sleep apnea, the airway is open, but the individual is still not breathing. The reduction in breathing is at a central level. Now look at this. There's a cessation of airflow. This is the airflow, up and down. Because of obstruction, there's a cessation of airflow. No airflow happening, but the respiratory effort is still being made. Thoracic abdominal movements are still happening, okay? And that is an obstructive sleep apnea. In a central sleep apnea, you will have a straight line here, and you will have a straight line here also. The thoracic and abdomen bands will not move at all. There's no effort, and that is central sleep apnea. How does one make a diagnosis of sleep apnea? You need to have the symptoms. This was discussed very elegantly earlier on. You need now, very important thing, there is AHI. They say, Arey, AHI mild hai. Somebody will say, I will not treat. This AHI is mild. Somebody will say, I will treat. Lot of confusion around. If you have sleep apnea, which is you need more than 5 events per hour. That means you need to have an apnea hypopnea index of more than 5 events per hour. Okay. Or to call this as a syndrome, you need at least more than 15 events per hour in the absence of associated symptoms or disorders. That means if you have symptoms of sleep apnea as were discussed, and you have index more than 5, then yes, this individual has an obstructive sleep apnea syndrome. But there will be some patients who will only have an AHI of 10, but have no symptoms at all. Okay. They have OSA, but they don't have the syndrome. Very important point, sir. How does one say that this apnea hypopnea index of 10 is important? This apnea hypopnea index of 10 is important in the absence of symptoms if that individual has a comorbidity. If that individual has blood pressure, diabetes, stroke, heart failure, depression, impotency, all those symptoms, then this becomes an important thing to treat. Because if you have no comorbidities, if you have no symptoms, and if you have an AHI of 10, then you may think about observation, alternative therapies, or weight reduction, follow-up, etc. There is a paper which has clearly shown, Yagi, and we also gave our contribution to that in the New England Journal. They had two groups of patients: sleep apnea patients, AHI more than 5, okay, who were treated and who were untreated. Those who, and now you'll say why people were not treated. They were the patients who refused to take treatment, and that became the control arm. So if you have an apnea-hypopnea index of more than 5 and you are not treated, you have a higher chance of death if you compare to those who had an AHI of more than 5 and were treated, okay? So therefore, this is extremely important to understand. Look at this: obstructive sleep apnea and comorbidities. If you know, this is a combination. If you have one comorbidity, if you have no sleep, if somebody has no snoring, no sleep apnea, you can have one comorbidity, which is normal nowadays. If you have a simple snorer, you have only more dominantly one comorbidity. But if you have sleep apnea, the chances of having one comorbidity is very less, like a blood pressure, diabetes, heart or problem. And if you have, the chances of having 2 or 3 comorbidities is very high. Chances of having more than 4 comorbidities is also quite significant. That means if you have sleep apnea, your chances of comorbidities are very high. You have to look about 4 comorbidities and take that into the decision. Okay. Now you will tell me, Doc, why am I discussing where the talk is about sleep study, which and when? Look at this: obstructive sleep apnea causes a lot of things, causes sympathetic activation, metabolic dysregulation, inflammation, oxidative stress. All these can lead to cardiovascular disease. But an important thing which is here is recurrent arousals. Okay, recurrent arousals can be detected only on the EEG. The point where I'm leading you to is, if you want to do a sleep study in a patient who is having comorbidities like blood pressure, diabetes, stroke, cardiac failure, you have to have a study which will give you arousals, and that is going to be a sleep study with an EEG. That's where I'm leading you to. This is the paper which we had also published in the New England Journal. We discussed about sleep apnea and heart disease. And in this particular paper, it became very important that they found that individuals who had an AHI, not in our paper, but the one we related to, the one we wrote about, if you have AHI of more than 5, but if you have an arousal index of 26, you have an increased risk of death if you are not treated. Very, very important. So I come to a very important point here. Respiratory event related arousal, RERA. It is a respiratory effort related arousal, and which arouses the patient from the sleep but does not fulfill the criteria for apnea or hypopnea. That means there's a reduction in the airflow. The brain is sensing it, so the brain awakes. So these are the individuals who can have a low apnea hypopnea index, but they can still have symptoms of sleep apnea. Okay. So how does one approach now? I've given you a background about comorbidities, what is a RERA, when you need to do EEGs. So as I think this was very well covered in the earlier lecture, so you talk about screening, you talk about questions, there are questionnaires. Then if somebody comes with a positive questionnaire, you also screen, you go ahead with a diagnostic study. The questionnaires are based on symptoms, anthropometry, demographics, and comorbidity. So, okay, there are different questionnaires which are there. There's an Epworth Sleepiness Score. There's a Stop Bank questionnaire, which was discussed. So all these questions will give you a sensitivity of identifying individuals who should undergo a sleep study. So now, after having discussed this, what are the types of sleep studies? You have a diagnostic study where you make a diagnosis of sleep apnea, and you have a titration study. I'll discuss very briefly that with you. Split night, all these things I will not discuss. We'll focus only on the diagnostic sleep study and the titration sleep study. So polysomnography is a test that involves recording of multiple systems in our body while we sleep. You're talking about respiratory monitoring, cardiac monitoring, neurological monitoring. Okay, these are the multi-system monitoring that happens. And this is a very important slide now from a practice perspective. You have different levels of sleep studies. Type 1 is a fully attended polysomnography in a lab setting. So if you come to a sleep center, you have a technician, you have a polysomnography device which is being done. That's a type 1 study. Type 2 studies are polysomnography. You have portable polysomnographies, but the technician will go put up the polysomnography for the patient, comes back, and in the morning goes back to collect the device. That is unattended polysomnography type 2. And type 3 and type 4 are the limited channel studies. Now, important point here is for type, for type 3 and type 4, you have type level 1 and level 2, you have the EEG, EOG, EMG. You can stage the sleep studies. But for the type 3 and type 4 here, you do not have the EEG. If you don't have the EEG, you cannot have the sleep studies. So the point is, what's the big deal? There are some patients in whom the limited channel will be adequate, and there are some patients where the limited channel will not be adequate. And that's what is a question, I think, which the moderators were discussing, and they need to make a decision making. In polysomnography, you have sleep signals, respiration, cardiovascular, limb movements, body positions, etc. Sorry. Yeah. Okay, these are the things. So the question is, when I talk about a polysomnography, that means a full sleep study. Polygraphy. Okay, polygraphy is limited sleep studies. Polysomnography, so in your decision making, yes, because maybe I can combine both the lectures together. Yeah. I've got one more after this. We'll combine it. Yeah. Why is polysomnography needed? It gives you assessment of sleep stages. So whenever you want a sleep stage to be determined, you need to have a polysomnography. Why is this important? Some people can have a mild degree of drop in oxygen because the limited channel studies are dominantly dependent on respiratory movements and the drop in oxygen to detect sleep apnea. There are some people who can have a mild degree of drop in oxygen but have more arousals and sleep disruption. You don't want to miss this. Now you can say, doc, if somebody's coming with the symptoms of sleep apnea, what this big gungo about type 1, type 2, type 3, type 4 level sleep studies? If you have an individual, now the guidelines are very clear. The heart guidelines, the diabetes guidelines, the hypertension guidelines, they say that if you have a newly diagnosed patient, you need to screen them for sleep apnea. You can start with symptoms, or you can have whatever reason you suspect sleep apnea, but some of them may not have enough symptoms of sleep apnea, but they have comorbidities. They may be just obese, they may have less symptoms, and in individuals where you have less symptoms, okay, you don't want to miss a mild sleep apnea because a mild sleep apnea in comorbidities needs to be treated. So what are the pros and cons of a sleep lab study? That means, somebody has to come to a sleep lab, for example. It is better at diagnosing all form of sleep disordered breathing, not OSA. What is sleep disordered breathing? Sleep disordered breathing means you have upper airway resistance syndrome, you have sleep apnea, obstructive, you have central sleep apnea, you have obesity, hypoventilation. The entire spectrum can be taken care by the in-lab sleep study. It's a gold standard. Con is what? Patient has to travel to the sleep center. There can be geographical issues. It's a foreign environment. Some people say, doc, I cannot sleep well in a foreign environment. So how can I do a sleep study? You need a skilled technician. You need skilled technicians actually for every study. Okay. Now, HST is a home sleep study. Patient can sleep at home. More patients can come into the diagnostic. You can do more studies if the patient, because more patients will be willing to do the study at home, at least in our Indian culture, in our Mumbai culture. What is the con? Attended sleep study is expensive. Okay. That means that in the lab, or even if I have to put my staff at somebody's home for the whole night, it's expensive. Polygraphy, if you do a limited study, okay, it has limitations. It cannot diagnose other conditions. Sorry. Now I want to show you a case. Okay, now this is a patient who has symptoms of sleep apnea, who underwent a polygraphy. I'm sure it's not reflecting properly. Maybe, yeah. The AHI in this particular polygraphy is 2.4. What will you do? Individual has all symptoms of sleep apnea, but the polygraphy did not detect the sleep apnea for this patient. So we subjected him for a proper polysomnography. In the polysomnography also, the AHI, apnea-hypopnea index was 7.6. It's mild. Okay, but there is, because we did a polysomnography for this patient, the apnea-hypopnea index in REM sleep is 23.6. Okay, so you have a moderate sleep apnea in REM sleep. That is the diagnosis for this patient. Moderate apnea and REM sleep, and therefore, and there is also significant desaturation. I mean, it's not going less than 90, but yes, he's going down to less than 95 also. So we did a titration study for him. And if you see here, you know, the AHI becomes 0. And look at this, the CPAP pressure of 10 is required. So the point I'm trying to put across is, if you have symptoms, if you've done a polygraphy, limited channel study, if the diagnosis is not fitting with the clinical situation, you need to do a polysomnography. There are different guidelines here, clinical practice guidelines from the American Academy of Sleep Medicine. And what is the message that comes out from this? The message that comes out from this, you cannot treat patients just based on questions. I showed you questionnaires. You have the St. George, you have the Epworth Sleepiness Score, you have the Berlin questionnaire, your stop by. It does not mean that, oh, this patient has a high probability of sleep apnea. Why do a sleep study? We just treat it. No, they are not diagnostic. You need to do a diagnostic test. Now they say a polysomnography is the gold standard to give a clear message of which, when. If you have a comorbidity, you must do a polysomnography. If you are having, you know, if you think that there is a chance of a mild sleep apnea, you should do polysomnography, because if, like I showed you, that individual has a mild sleep apnea but a high in REM sleep, the polygraphy missed the diagnosis completely. And why is the polygraphy missing the diagnosis? In polygraphy, you put on the machine, you switch it on, and then you switch it on. Now, in those 8 hours of recording, if the patient slept for 4 hours, the machine doesn't know. In those 4 hours, that patient had that apnea hypopnea, but the average is for the 8 hours of recording. And the risk of polygraphy is you may underestimate the apnea hypopnea index. There's an algorithm. I will not go through this entire algorithm where you suspect sleep apnea. Now, suspicion of sleep apnea can be 2 ways now. Not only snoring. Suspicion of sleep apnea is if somebody has snoring and symptoms of daytime somnolence, etc. Plus, if your subspecialty, if your colleague from other specialty says, I've got a person who's got a uncontrolled blood pressure, heart failure is not getting controlled, there's a repeat stroke, there's a repeat arrhythmia, that is also suspicion for sleep apnea, and that gives you a pathway. And as I already gave you a background, in selected patients with a high probability of sleep apnea, but no comorbidities, you can do a polygraphy study, but in others, you will need a polysomnography study. Okay, there are statements about, you know, follow-up studies. Is a follow-up sleep study required? Most of the time not. But there are some times when you need a follow-up sleep study, okay? Follow-up sleep study, that means you've diagnosed, you've titrated, and you've got ahead and followed up the patient. Only if the patient continues to have symptoms, okay, on treatment, that means patient can have complex sleep apnea. Okay, that's what you need to find out. And if in my practice as a pulmonologist, I have patients who have sleep apnea and underlying chronic disease. You know, people have been on steroids, etc. They develop sleep apnea. So initially the CPAP is fine. They're doing fine. But on CPAP, they start getting symptoms. You need to repeat the sleep study to see whether they are having hypoxemia because of the underlying lung problem. And therefore, that can be very helpful. We have the in OSA guidelines, which talk about gold standard. They say that the type 1 study is the gold standard, and you can do home studies, but you must know the pros and the cons of the home study so that you can make an accurate diagnosis and you don't underdiagnose a patient with sleep apnea. So that's my first part of the lecture. I'm just quickly going to, if you, with your permission, with the chair, there's a second lecture. I'll do that also very quickly. And this is the second one. So we made a diagnosis about sleep study, and I think I've given you an idea about when to choose which sleep study. Okay, I've tried to keep it simple. Now the question is CPAP trial, which, when, and how long? You know, the trial word is a bit of a question. You know, why CPAP trial? You know, CPAP is the golden treatment. Why we use the word trial? I'll take you quickly through this. CPAP is the gold standard for the treatment of sleep apnea. Yeah, I'm saying this amidst all our ENT colleagues. Yeah, love you guys. clinical benefits of OSA with PAP therapy are established. You have short-term therapies, short-term goals, benefits that you maintain open airway, you improve quality of sleep, and you alleviate daytime symptoms. And in the long term, you reduce the mortality and the morbidity. Okay, this is clear. So remember, CPAP, when you talk to your patients, you talk about immediate benefits the next day, and then you talk about long term. It's like cholesterol. You have a cholesterol problem. You have a high dyslipidemia. That's not causing you a problem, but you still treat it. Why you treat it? What's going to cause you long-term problems? That's a simile I've given you. Now, treatment of obstructive sleep apnea with the CPAP. What are the AASM clinical practice guidelines? Now, there's so many things here. I'll tell you what. The summary. The summary, it says, is very simple. If you have a moderate sleep apnea, you must treat it. Okay, that is what is moderate sleep apnea. Index of 15 events per hour or more, that has to be treated. The discussion happens if you have an index between 5 and 15. In that index of 5 and 15, if you have symptoms of sleep apnea, okay, that means you have any daytime symptoms, you should treat it. In that index of 5 and 15, with mild sleep apnea, if you have a comorbidity, you must treat it. And doc, whom should we not treat? You can have somebody as a mild sleep apnea who's just had snoring complained by the spouse, okay, and has no daytime symptoms, has no comorbidities, but says obese, or has the surgeons will discuss with you, has got upper airway abnormalities, okay, that is causing the snoring. He has no. I think they would be the candidates where you have to talk about weight reduction if they're obese, and you have to look for treatable, curable cause. Reasons for that obstruction. Now, PAP therapy is the mainstay, and what is its role? I already discussed with you. It gives you immediate relief from symptoms the next day, and it helps you with a long-term benefit. Now, what are the indications of PAP therapy? I already explained to you. AHI or RDI more than 15 events per hour. I put this slide again here from AHI. You will know from a polygraphy. But if you want a very good RDI, a respiratory disturbance index, where you have a AHI plus RERA, you need a polysomnography. If you have an AHI or RDI which is more than 5 but less than 15, but you have symptoms or any cardiac condition, we must treat that with CPAP, or if that individual is eligible or a classical candidate for surgery, that can be considered. CPAP, I will not get into the details of when it was started, but what does the CPAP do now? The CPAP is providing a air splint. There is an obstruction here at the upper airway level. In sleep, the muscles are relaxing. There's a tongue fall. Okay. And what does the CPAP do? It gives you positive pressure. Positive pressure. It's a continuous positive air pressure. It splints the airway open and it stops the obstruction. Okay. Brain can sleep well and oxygen fluctuations become less. It's a mechanical problem. Nothing wrong with the other systems. So if you treat the mechanical problem, you can help the other systems also. What are the clinical guidelines for treating sleep apnea with PAP devices? I think once an individual is diagnosed with the sleep apnea, we must do a titration study now. Okay. And that's why the issue comes. CPAP trial. The topic is CPAP trial, which, when, how. I think the word trial, I don't use a CPAP trial in my practice at all. Okay. And I'll tell you why it's important not to do that. I'll discuss as we go ahead. Now, somebody is diagnosed with sleep apnea. Okay. Now you have to decide about the treatment. Either you go the surgical path, you go the CPAP path, or a PAP path. Or you say only diet modification, positional, mandibular advanced device. There are many options there, but let's simplify it. Okay. If I decide to go under the PAP, I think this individual, I want to give PAP therapy. What are the options? You have CPAP, auto PAP, BiPAP, ASV chordo. There is a adaptive servo ventilation for cardiac failure patients, but CPAP and BiPAP is something that one needs to remember. This is the nasal CPAP here. This is how it goes on. I had these different masks here. Now the masks have improved a lot. You just have these small air pillows, etc. Simple masks, which can be very easily just go at the back. So the masks have improved. That has improved the tolerability of the CPAP by the patients and the acceptance also. What is it doing? This is the normal airway, the sleep apnea airway, and a pneumatic splint which is formed here by the CPAP. Now, what is the CPAP doing? You have before the CPAP, you have so many events that desaturations are happening. You give the CPAP and clearly the desaturations improve. Why there is no desaturation? The airway obstruction is gone. Airflow to the lung is normalized. Oxygen transfer is normalized. Benefits of CPAP, it reverses desaturations. Okay, I showed that to you. It reverses arousals and apneas. Okay, because there is no mechanical obstruction anymore. There's no arousal. The brain doesn't have to wake up. Abolishes snoring, reduces sleepiness often in just one night, improves daytime vigilance, and helps with blood pressure, cardiac failure, pulmonary hypertension, arrhythmias. There's so much of data on that. It helps with better control of diabetes. So a lot of referrals we have now are from our cardiologist colleagues, our arrhythmia colleagues, our endocrinologist colleagues, our diabetologist colleagues, where they are not able to treat the condition with the pharmacological therapy. That's when the sleep apnea diagnosis treatment comes to to rescue. There are different types of masks. In interest of time, I go ahead from here. Important point now. CPAP trial often is word used very loosely. Arey jao CPAP trial leke aao, sleep apnea aa gaya. Arey what trial leke aao? Sleep apnea, why? Because patients are afraid of it. Claustrophobia. No, you've got very good masks. I'll tell you how to tackle that. Skin abrasions due to masks. The masks have improved. In the past, disposable cheap masks were often used. Now we've got very high quality masks. Rhinorrhea and nasal dryness. Nasal dryness can occur. In Mumbai is humid, but outside Mumbai, often you will see dryness happening. But if dryness happening, you have got nasal sprays. Now, rhinorrhea. Rhinorrhea can be irritation, but there can be underlying rhinitis. You need to treat the rhinitis. We published a paper. I'm not showing you. You give fluticasone to everyone. No, it doesn't help everyone. Okay. So those with an allergic rhinitis component, it may help you. Aerophagia. Why aerophagia? Patient is not able to coordinate well. We can solve all these problems, and these problems can be solved. I'll show you when I come to the last slide. So you have CPAP. Which type of CPAP? I told you, you have a fixed pressure CPAP, auto CPAP, and a BiPAP. This is a question which often comes. The first question is, which sleep study should I do? So sleep apnea aa gaya, abhi kaun sa machine dena hai? Okay. You do a titration study. It's very important. Now, many people say, sir, क्यों पैसा खर्चने का है? Why you want to do titration study? Sleep apnea है, CPAP दे दो. Boss, you are embarking on a long-term therapy. Sleep apnea is associated with comorbidities. Whenever we embark on a long-term therapy, we want to know how effective the CPAP is. Okay? So a titration study is important to document the adequacy of the CPAP. Some people, CPAP may not be adequate. It may not completely reverse the sleep apnea. Some people may need additional oxygen along with that. Okay, so once you do a titration study, yes, you can give a fixed CPAP. This is a cheaper device, but needs a lot of follow-up. Okay, if you use an auto CPAP, you can still configure that device, and you can continue to and you can follow up the patient, their data downloads, etc. Okay, auto pipe, but it's not that ki sir abhi agar sleep apnea hai, auto device hai, de do aur chalu kar do. No, it doesn't work that way. The auto PAP device also needs to be configured. Okay, you need to see whether the patient, there are various parameters. We'll discuss that some other time. BiPAP. Now, when is BiPAP useful for sleep apnea? If the pressure requirements are very high, if the patient is not able to tolerate the CPAP pressures very well, then you can give bi-level pressures which help to adapt to the PAP therapy better. But an important therapy is whenever you've introduced the BiPAP, it may be worthwhile to document subsequently that the pressures that you are giving are adequate, and that may need a titration study with a polygraphy also. Now in interest of time, I come to the last slide. CPAP trial, which, when, and how long? So what's the approach or in of my these two talks? You need to diagnose sleep apnea properly. Okay, you cannot underdiagnose sleep apnea. Okay, and you need to accurately diagnose the sleep apnea also, particularly if you have a comorbid patients. You have to identify comorbidities. Okay, so whenever a patient comes to me for sleep apnea and has not been worked up, yes, I say, yeah, we will do your entire workup. We will do a polysomnography. We'll do everything, but we should also look for comorbidities depending on the age of the patient and the risk factors. Please look, that's an opportunity. There are so many patients we've diagnosed diabetes, so many patients we've diagnosed dyslipidemia. There are so many patients we've diagnosed pulmonary hypertension only linked to sleep apnea. There are so many patients who are first diagnosis for thyroid, hypothyroidism also. Look for comorbidities. Titration is very important. If you want to have a success with your CPAP, if you've decided, okay, I don't want to operate, I want to give a CPAP, you need to titrate. Okay, titrate with a sleep study device. The titrate will allow you to see the adequacy of the device, what are the pressure requirements, and will also allow you to administer the appropriate therapy, whether you want to give a CPAP or you want to give a BiPAP to this particular patient. Important, counseling encouragement. Counseling encouragement is not available. Hardly. I'm sorry to say that. Diagnosis is done. Kiya to kiya, 50%, in the company-driven sleep study there, the doctor has not, I'm sorry, you're recording me, but doctor has not seen the patient, advise CPAP. Patient bhi nahi dekha hai kya hai. No, it doesn't work that way. You are embarking on a long-term therapy. You have to counsel the patients. Usko educate kijiye aap. Okay, you have to give time to that. Okay, if you cannot give time, develop a team. If you feel that's your niche area, you must have a team. Encourage them. That is a simple air pressure. Encourage them. Troubleshoot them. Okay, treat their comorbidities. Give them a comprehensive plan that will allow them to accept the CPAP or the PAP therapy better. Now, important point is introduction. Introduction is not by somebody whom they have not seen. They don't know what CPAP is. Jao CPAP de do or chalu kar do. No, it doesn't work that way. If we are talking about a specialist practice, they have to, when they come to you, talk to them. Teach, give them the CPAP. Give one of your staff to introduce the CPAP for them for some time. Alleviate their anxiety, and the CPAP acceptance will zoom. Okay. Troubleshoot. Often even after counseling, they may not put the mask properly. That is not a failure of CPAP. That's not a failure of a CPAP trial, so-called CPAP trial. CPAP trial doesn't exist in my practice. In theory, in research, it may exist. No, if I want to give CPAP to the patient, I put my full effort and introduce the CPAP to the particular patient. The mask may not be adequate. Sometimes, they'd use a big mask. Somebody use a small mask, somebody use a nasal mask, but they need an oro-nasal mask. You have to choose the appropriate interface, troubleshoot it. Sometimes the patient has lost they've put on weight on CPAP also. At Badmi, I was using the CPAP for so many months. Well, now I can't use it. Troubleshoot it. Maybe the pressure requirements are higher. Okay, they've lost weight. Pressure is too much. Adjust the pressures for them. And you have to follow them up. Follow-up is important here. Follow-up either with you or with your team member. Look at the data, the data downloads. That helps you to know whether they are being very, they are compliant or not. You can tell them, "Sahab, hamara to kundli aapka aa jaiye," and you explain to them, encourage them, ask them why they are not using the device, and then you can troubleshoot it. I can go on and on. Vikas, thank you very much for this opportunity.
Thank you, Dr. Prashant. So excellent job. I think the mask is definitely an issue with CPAP adherence,
Yes.
And I think most of the companies give them that full face mask.
I think it has to be tailored. I think all of us have a different anatomy, and we have to tell the patients also that, okay, you've given a mask, it may not work. So you have to be mentally prepared to change the mask, because all of us have different anatomy. Not everybody's a mouth breather. And now we've got huge array of masks which are available. And that allows us, again, you need to give them time. We call them in the afternoon at the sleep center. We utilize our sleep center well. We give them an introduction. We give them an experience of CPAP. And that has improved the compliance very, very much.
You give them a rental basis initially and then ask them.
So yes, we can give them rent, but what I'll tell you, with the more stronger our support system has become, the less rent we do nowadays. Because the rent concept was there, yeah, trial karke dekh lo, hua to theek hai, nahi to chhod dena. No, we put the initial effort so well. You know, you've done a titration study. You've demonstrated that the CPAP is adequate for you. Why would you rent the device? Why you want to spend more money? So we count, but still, yeah, of course, there's something. नहीं, आप बोलते सब सब बराबर है, but हमको rent करना. Yes, you rent, but I can tell you the number of devices on CPAP rental has gone down. But of course, we can give them, if they want to be more confident, they want to be sure that they can use it for a longer term. Yes.
I think PAPNAP trials do work well.
Sorry?
PAPNAP trials.
Uh-huh.
That is usually meant for troubleshooting.
Yeah. So I mean, you know, people use different approaches. The way we troubleshoot is we call them to a sleep center. We have the luxury of calling them in the afternoon. We spend half an hour, 1 hour with them. They can lie down. We make a dark room there, and we say, "Bhai, hamare samne use karo," and we encourage them. So that's the way we use to encourage it. But of course, you know, everybody has a different way of how to use the trials. What I'm not trying to say that the CPAP trial is wrong. The point is how it is comprehended in practice. You know, ये trial करके देख लो, suit हो गया तो ठीक है, नहीं तो छोड़ दो. I think that is CPAP trial word should not be used in that context.
Thank you, Dr. Krishnan, for an excellent presentation.
So I think it was a absolutely wonderful talk by Prashant. And as surgeons, we obviously do not know a lot about the CPAP details. And therefore, this talk was really, really very important. Now, unfortunately, there are many patients who do not tolerate the CPAP pretty well. And that's where the role of ENT surgeons actually is very, very important. And in very short, since we're already running late, I will talk on the role of nose in obstructive sleep apnea management. So if this is a case of a 30-year-old male patient snoring, tired, BMI is very, very high, 37, AHI 20, mostly hypopneas, nose having bad deviated septum polyps, turbinate hypertrophy, adenoids, whatever. Palate is thin, tongue is not bulky. So what will you do? You'll do a pharyngeal surgery, you'll do bariatric surgery, you'll give a CPAP therapy, or you will clean up the nose. So that's where, and this is a very common scenario. We all have obese patient where we believe obviously 37 BMI surgery is not going to be effective one-line treatment. But here, in spite of the BMI being 37, his AHI is mostly hypopneas and AHI is only 20. So problem is in the static obstruction, which is the nose. So in this case, obviously, nose surgery is going to be the answer. And nose is very, very important, as we discussed in our first talk, because if the nose is blocked, the mouth is going to remain open and everything is going to collapse. And this is where you see when the patient is having a mouth closed, he can breathe well. But if the mouth is open, unfortunately, the sound is not connected. Can you just give the sound? Sound, please. Now see, this is with the mouth open and with the mouth closed during DISE. That kind of a difference you can see. This is again with the mouth open. So if the nose is not open, everything is collapsing. So the moment you open up the nose, it will still take the patient 3 to 6 months to get used to nose breathing and stopping mouth breathing. But the most important point is that the nose has to remain open. Even when you perform multi-level surgery with a large tongue base, obviously you do the nose first, then put in a nasal tube, and then do the surgery on the tongue. You can do a single stage nose and palate surgery, especially if the tongue is not large. But most of the time you require a nasal tube when you are going to perform a tongue-based surgery. So this is how the tube will pass through the nose very easily. But if you want to, for a base tongue patient, if you want to intubate, it's going to be very difficult if you want to do it from the oral cavity. And after the surgery also, you want to keep the patient in the ICU with a nasal intubation for 24 hours. So these are the important things about the nose which we have to understand if the patient is having a tongue-based surgery. Even if you want to give CPAP, this is more difficult. A full face mask. This is much easier. Very nicely explained by Prashant. If you give a nasal mask, if the nose is open, then only the nasal mask will work. All the beautiful nasal pillows will work only through the nose. So again, the role of nose is extremely important, and all the guidelines say that you have to treat the nose so that the CPAP compliance is improved. So a CT scan is a minimum investigation for the nose in a OSA patient. Gone are the days of X-ray. With the endoscope, you'll not be able to look into the ethmoids. So do a CT scan where you look not only for the septum, also for the inferior turbinate, whether it has got more bone or more flesh, because that will decide your turbinoplasty decision. You look at the concha bullosa, whether it has got air or whether it is only a bony middle turbinate. Look at the ethmoids, adenoids. So CT-PNS is a minimum investigation that you need to perform for a patient of you see a lot of adult adenoids, lots and lots of adult adenoids, because they have been they are lazy, they are feeling sleepy, so they use smoke. They smoke, and smoking further causes enlargement of the adenoids. So you get a lot, and this is again a vicious cycle. So these are the insights that you must have, and you must clear up the airway right from the anterior to the posterior end. This is how the airway actually travels through the nose. It's not along the floor, it's along the middle turbinate. So this airway has to be open in this fashion, and therefore there comes the role of detecting a high deviated septum. We all believe that when we entered ENT, we knew how to do septoplasty. So no, actually college teaches septoplasty. All workshops are happening on skull-based surgery. But basic septoplasty is something which is not being taught. I'm raising this point because, see, this is a revision case, and see how much of cartilage here is high deviated septum is left. There's a septal perforation in the lower part. I do a lot of revision revision nose surgery, and high deviated septum, such a small thing, is majority of the times is left behind. Therefore, I'm keeping this point in front, that we must take care of the high deviated septum and the inferior turbinate. Again, there was a wave of turbinectomies in the past, which completely gave down to no touch turbinate, which does not work. The inferior turbinate has to be tackled, and you can divide it into 6 parts: anterior, middle, posterior, upper, lower, upper, lower, upper, lower. And a simple algorithm, if you understand that this is the anterior end of the turbinate, the upper part of the anterior end is sinusoidal, which has got more serous glands, and this is the most expansile part of the turbinate. The middle part is convex, which can be simply outfractured. The posterior and the inferior part is polypoidal, which has got a lot of mucus glands. Now, unfortunately, this kind of a description is not there in the literature. We are supposed to write a paper on this, but if you remember this will make your turbinoplasty results very, very good, especially for OSA cases, because you want a very, very good opening up of the nose. So if you look at this is the sinusoidal part. This is the only part which is acted upon by the sympathomimetic drugs, but the lower part is all mucus. It is not even acted by your Otrivins and by your nasal spray. Nothing happens over there. So this is where you require a surgical spot. And the middle part is the bony part. There's hardly any flesh on that. You can simply outfracture and see how much of space in that area which you want to open up is created. So if you outfracture, you create a lot of space in the bottleneck area. And the last, and when you are doing, sorry, I think this slide has got jumbled up. This is about the septoplasty. So I'll just fast forward. What I wanted to show you is that once we have raised the flap, now this is a deviated septum, which is quite anterior. Now, if you rotate the septum like a flap door, you'll see your area. This is the anterior nasal spine area. So if you remain at the anterior nasal spine and you remain at the junction of the septal cartilage with the upper lateral cartilage, if you remain behind these 2 points, you can remove entire cartilage without the nose being falling at all. So this is one point which has improved my results of septoplasty greatly. So this is kind of a SMR, septoplasty SMR combination. So I'm removing a lot of cartilage for the last 8-9 years, and that has improved the results quite a bit in terms of the high septal deviation. And now this is what I was trying to show you. You can remove the lower and the posterior part of the inferior turbinate, which is polypoidal, completely with a simple microdebrider, which everybody has in the theater. And you will see that your long-term results of turbinoplasty will go through the roof. And this is just a 2-minute thing. It will not even take a long time. It hardly bleeds because it's only the polypoidal part that you are removing. And after doing this, you can take a simple scissor and remove the lower part of this bone. So if you remove the lower 40% of the turbinate, your results will remain for life. I'm telling you on last 8 to 9 years of this turbinoplasty experience. So simple things. I'm not showing any hi-fi things. I do a lot of experimental stuff. I'm not showing anything of that sort, but don't leave obviously any bare bone. Remove that small bit of bone here and there, and see when you come on the other side again. The deviated side was the left. On the right, you can see how large is the middle inferior turbinate. So just take care of the polypoidal part. Just with a microdebrider, you can remove it and touch it with a suction cautery, which everybody has in the theater, and remove the lower part of the bone. See this. There's absolutely no bleeding. And then you can remove that extra part of the bone and maybe touch with a suction cautery if required. Now, do the CT scan before you decide to operate. Now, this is a purely structural patient. There's nothing in the ethmoids. So this patient, once you do a good septoplasty, turbinoplasty, you can guarantee that for this life, this nose is not going to give any further problem, by and large. But if somebody has got a polypoidal change everywhere in the ethmoids, now this is a purely immune complex disease patient. This is whether he has got some patchy thickening or a complete full-blown. Now this posterior ethmoid cannot be left behind. This will harbor disease next. So you have to treat it like a polyposis and remove the entire thing as the first go. Otherwise, this will keep on giving postnasal drip later on. So again, these are small things that if you remember, and you can obviously give some steroid before surgery, just like you before removing the honey, honeybee nest, you give some smoke and let it go around. So similarly, you can give steroid, use navigation. I'll not get into the details of sinus surgery, but obviously removing each and every air cell and removing everything. So long-term results in sleep apnea for a polyposis patient should be something like this. Nothing left. Middle turbinate is almost 70-80% removed. Superior turbinate is removed. All the sinuses open. Skull base. Now you'll not get a recurrence, and postnasal drip will reduce by maximum. Obviously, if salpingopharyngeal fold is the problem, you also tackle salpingopharyngeal fold. Sometimes you'll get tubal tonsils. This is my own revision. I had done an adenoidectomy some 7-8 years after, and later on the child, when it became a young adult, came with tubal tonsil. So you get all sort of things in your life. So this is about the nose thing. In interest of time, I'll again take up my tonsil adenoid tips and tricks again very, very fast. So in tonsillectomy, there are only 2 challenges, pain and bleeding. Is there any third challenges? Any third challenge anybody has ever faced? Hardly any. So use a microscope. Straight away coming to the point, use a microscope, give traction to the tonsil. A very good example. Now this is an adult tonsil. I'm sure. Can you reduce the sound, please? Sound reduce, please. Sound stop. Sound stop. Okay. So this is an adult tonsil. I'm sure everybody knows that adult tonsils are more problematic. This is an adult tonsil. So you have to pull the tonsil out. It was seen quite inside, and I'm using coblation. Obviously, still I'm going into the wrong plane. So this is not the correct plane. So pull the tonsil completely out till you get the right plane. This is again message for the juniors. Tonsillectomy is not a big deal, but see, I was into the wrong plane and I have took a second look and pulled the tonsil further out. This was a pretty endophytic tonsil. So I missed the correct plane. So when you miss the correct plane and you do not see the proper plane, hold on, stop there and get into the perfect plane. So this was for the getting the, that's the correct plane. You do not need to open up the muscles. It will be quite painful. If you do not open up the muscles, even in an adult, the surgery will be quite less painful. So operate between the muscle and the lymphoid tissue. Now, as you reach the lower part, now this is a completely infected tonsil. So I'm supposed to take out the whole tonsil, and there you can see the muscles are already getting exposed now. So here I cannot help. These are the fibers and these are the muscles. These are the connective tissue fibers. So if you want to make it painless, remain between the muscles and the lymphoid tissue. But at the lower part, obviously you can see the brown muscles. They will definitely come in. Now, how to prevent bleeding in this part? Pain obviously is going to be there in the lower part. So this is a completely extracapsular tonsil, but this is where you will get the blood vessels. So coagulate on the tonsillar artery along the length, sequential coagulation, and then dissect on the medial aspect of it. Your chances of bleeding, even in an infected adult tonsil, would go down to the maximum. This is what we learned over a period of time after getting our hands burnt in a lot of cases. So this is one thing. You do a sequential coagulation of the tonsillar artery, and then dissect on the medial aspect of it. So this is one tip which can help prevent a lot of complications in terms of bleeding. See, this is a complete tonsillectomy. I'm not leaving behind anything, but still this patient should not bleed at home. So this is one tip. So and then you take out the whole tonsil. And then now let's look into the tonsil fossa. So if there's any small ooze anywhere, you can coagulate it. Otherwise, you can see that most of the fossa is not having exposed muscle, even in an infected adult tonsil. So that is the aim. Obviously, it takes quite a bit of practice. So regarding if you use too much of irrigation on the coagulation, it will not give you a great field. If you use too much, again, it will not give you a great field. Similarly, too much of suction will contribute to less of suction will contribute to clogging and pooling, and too much of suction will again have a problem on XT. So I cannot go into every single detail, but this is a very, very important concept to know your instrument properly. And now coming to the pain part. Pain happens in tonsillectomy because of two factors. One is the mucosal factor, and one is the muscular factor. So in the mucosal, the pain is a burning and continuous pain. So local anesthetic, gargle, will give you a very, very great relief if you do not, burn too much of mucosa. So this is a continuous pain which can be taken care of by the local anesthetic gargle and prevention of mucosal injury as much. So but the muscular pain is a very strong and inflammatory inflammation of the muscles lead to pain. When the patient swallows, that pain is very difficult. That obviously requires some good amount of NSAIDs, and therefore you should prevent any exposure to muscle, which I just stressed. So these tips will obviously mucosal lesion if you keep to minimum, and do not take a tie onto the muscles. That will prevent a lot of pain. Do not expose muscles. That obviously will take care of the pain part. Bleeding, I have already discussed. The main supply is tonsillar artery. Important is that tonsillar artery obviously is pretty far away from the heart. So the proximally you damage the blood vessel, the more will be the loss. The distally you damage, the less will be the loss. So if this is the diagram from heart to the peripheral vessel, obviously veins are going to be benign. They're not going to bleed because the blood flow itself is very is not very fast. But in the arteries, the blood flow is quite fast, and obviously the heart keeps on pumping. So if you if you damage this bigger part of the artery, the chances of it opening in the postoperative period will be much more. Whereas if you open up the or coagulate the smaller artery. So now this is again a very, very important concept. Tonsillar artery, if you just divide and do not suture it or ligate it, then the chances of this opening in the postoperative period is much more. Therefore, if you're using coblation or a bipolar and you go extracapsular and coagulate that tonsillar artery, it can, with the force of the blood flowing inside, it can open up. Obviously, the vein will not open up because once you coagulate, the pressure is no more. But here the pressure is coming. Therefore, in spite of dividing this tonsillar artery outside the tonsil, if you divide it inside the tonsil, which is already where it is already divided into 2-3 small branches, then the chances of this opening up in the post-operative period will be very, very, very less. Therefore comes the concept of extracapsular surgery at the upper pole and intracapsular surgery at the lower pole. So you leave a little bit of tonsil tissue in the lower pole and coagulate on top of that. So that in small kids, if you do a intracapsular surgery at the lower pole, the chances of a post-surgery bleeding will almost vanish. For sleep apnea, you do not need the lower pole to be completely removed. It's only the upper pole. I'll talk in my next lecture, the mechanism of sleep apnea. If you only remove the superior pole completely and go intracapsular at the lower pole, your complication rate in tonsillectomy will go down absolutely to the minimum. So I should not say that, but in the last 7-8 years, I have not got, touch wood, it should not happen tomorrow, at a secondary bleed. Because my patients come from anywhere in the country and they go back. If it bleeds on day 10, day 15, it's going to be a very big problem. So this was the necessity of which led to this innovation. And I would suggest everyone to use this technique, try this technique, and the sequential coagulation I already showed. So you pull the lower pole and sequentially coagulate if you want to remove the whole thing. So this one, I think I've already discussed this. Now, if you do not damage the posterior pillar, if you cut the posterior pillar, there will be no problem. But if you damage and leave it to, become fibrosed, then obviously nasal regurgitation and voice changes will happen. So if you do not do these two things in sleep apnea surgery, we typically cut the posterior pillar and nothing happens. I have operated on actors and singers and I've done their uvulopalatopharyngoplasties without a change in voice. But then you cut it cleanly with coblation so that there's minimal fibrosis. So fibrosis is the key, because if you create fibrosis, even if you have preserved the uvula, even if you have preserved the pillars, but you have used cautery and created an intense fibrosis, there's going to be a voice change, there's going to be nasal regurgitation because of the use of cautery on the soft palate. So please do not use cautery on the soft palate. And all those, I'll talk in my palatal surgery talk. So this is extracapsular, where you go from outside into the tonsil. You can also go intracapsular, where you want to guarantee. Now you have a singer. I have many of them. Bollywood singer, actor, they have a tonsil issue. They have been advised tonsillectomy. And I have performed on them, but intracapsular surgery. So you have to guarantee that you will not have a little bit of change also in your voice, because I'll not even touch your pillars. I'll remove the tonsil 90-95% from inside. So you can do it for very small kids. You can do it for actors and singers. You can do it for tonsilloliths and obviously OSA only. So here you can remove the tonsil from inside by melting. Just as you do your adenoids, you can do it. So you can keep on removing the lymphoid tissue without exposing the muscles. You go till the muscles, you go till the fascia, but do not expose them. So there'll be no pain, there'll be no bleeding, and obviously there'll be no change in the voice. Now, can you see the fascia over there? That's the fascia. So you go till the fascia. This is the gray color is the fascia. You go till the fascia, but do not damage the fascia, do not open up the muscles. Leave a very small sliver of lymphoid tissue and you will get a similar result. Now I call it CCIT, complete coblation intracapsular tonsillectomy, CCIT. So you can do a complete job. You're not leaving any lymphoid tissue behind, and that's how you can prevent complications. So I think in interest of time, what happened? And just a few words about adenoidectomy. So obviously adenoidectomy, you can have it in adults also. Coblation is the tool that everybody agrees, complete removal. And this is the limit of the adenoidectomy, which was first time on the planet we found out the limits of the adenoid surgery, which was 2016 Indian Journal. And these are the boundaries. So if you go till the boundaries, you'll never get a recurrence. You'll never have to operate again. Fossa of Rosenmuller at the back on the lateral side, eustachian tube, torus tuberous anteriorly on the lateral side, passavant ridge inferiorly, periosteum on the base sphenoid at the back, and buccopharyngeal fascia at the posterior part. These are the boundaries of adenoid. Head low position, pull the soft palate with catheter, stand on the side like fess, apply a Boyle Davis mouth gag. Usually I use endoscope 4 millimeter through the nose. Decongestion is the most important part. 4 ampoules of adrenaline, 4 ampoules in 30 cc. You have to have a very good decongestion of the inferior turbinates. Small kids, they will not allow you cleaning post-operatively. So do not traumatize the mucosa at all. Stand on this side. These are the 2 bottlenecks because you have to reach the top of the nose, back of the nose. You have to reach this part, the choana, top of the choana. And therefore these 2 bottlenecks. So you have to open up the mouth, first bottleneck, and you have to lift the soft palate, the soft second bottleneck. There you can reach there, and by bending the wand by 30 to 45 degrees, obviously this is how you bend the wand in the lower part. Upper part, there's no need to bend the wand, and it's only the lower part that you actually need to bend it. And the bend has to be, there should not be any acute bend. It has to be a very gentle bend so that the wand can reach the top. And saline flow has to be generous. This one I have already discussed. 9 for ablation and 4 for coagulation. 9 is the setting that you require in the adenoids because you want a fast ablation. Once you enter, finish your work and then only come out. Do not go in entering and coming out. Clean the scope by rubbing on the adenoids. One problem that juniors always face is that when they are inside, the scope is getting fogged. So you don't need to come out. You can just touch the scope on the tissue, or you can put some irrigation on the. So if you're operating like this and suppose if you want scope gets fogged, you can simply go and touch it on the tissue and you will get a clean scope again. And then minimum coagulation continue. Suppose if there's a small bleeding, do not stop. You keep on ablating, the bleeding will always stop because there's always a little bit of coagulation inbuilt. Endoscope is a 0 degree which goes through the nose. 70 degree can go through the mouth. I'll discuss on both the aspects. So you start from the upper part, start from the superior pole, and the wand should not be moving very fast. If it moves very fast, then your hemostasis will not be adequate. If it is very slow, then the clogging will be more. These are the 2 golden points. The speed should be a lazy paint. If you go very fast, then there will be bleeding. And again, your bleeding will spoil the whole thing. If you're very slow, then the wand will keep on getting blocked again and again and again. So this is the superior margin that you start with. Then you keep on debulking. Again, this is the speed. No, not very fast, not very slow. Then go to the posterior margin and the lateral. This is the torus tuberous and the fossa of Rosenmuller. So this is the torus tuberous. You keep on removing tissues. That's the superior margin. You can see very clearly. Now, if you have the fascia like this, you will never get a recurrence. You will never have to do a second surgery. And then that's the fossa of Rosenmuller. If you remove all the adenoids from the fossa of Rosenmuller very slowly. Now here, if you direct laterally and you have a vessel, you may get bleeding. So if you are very sure, then only direct your wand laterally, otherwise only coagulate. Or you can direct your wand medially like this and remove the tissues. So that's in the depth of the fossa of Rosenmuller. If you remove it completely, then you will again not get a recurrence. Then going to the posterior boundary, buccopharyngeal fascia, obviously if I keep on showing the whole video. Now, this is the view, you're looking from the superior, or you can look from top, from the bottom. So if you're looking from the nasal cavity, your view is very straight and very clean. So you'll see the buccopharyngeal fascia very, very clearly. But if you're seeing it from down, many people prefer it to operate from the oral cavity. The view is like this. The posterior pharyngeal wall, you're seeing side on, so you cannot see it so well. And then there's a blind spot at the top. This area, many a times you leave some tissue if you're looking from the bottom, because this is a 70-degree endoscope at the most you're going to use. So you're looking at the angle. However, if there's no view of possible from the nose, if there's a bad deviated septum or a grade 5 adenoid, so that you cannot even put the scope and see your instrument, you will obviously first debulk it from the oral cavity side and then proceed with the surgery. So in very small kids, when there's no space, like this is a 14-month-old kid. In this case, obviously, this nose is too small, even for a 2.7 mm scope. There, obviously, you use a 70-degree scope, but you see this angulation is not perfect. But obviously, you have to do a complete job, because 14 months, you'll not do a half adenoidectomy. You'll do a complete adenoidectomy, because the growth spurt is completely pending. Till the age of 12, 15, the adenoid is supposed to keep on, enlarging. So you have to do a complete adenoidectomy at a very, very young age. And therefore, again, you have to do a complete job. So this part you will be able to see very clearly. This is the back of the septum. But as I said, the posterior pharyngeal wall, you'll not be able to see straight. So you have to imagine and still do a complete job and see the complete buccopharyngeal fascia, even in a small child. Good part is that the area behind the torus tuberis you can see very well with a 70-degree scope from the oral side. So you can remove this part of the adenoids pretty well. But for here, you have to be extra cautious, because you may simply damage the buccopharyngeal fascia because you're not seeing it straight. So I'll not waste time. Revision adenoids, again, are very, very common. This is again a revision adenoid. Adult adenoids are very common now. This is a 27-year-old guy with a huge adenoid. Came with sleep apnea. Only thing was to be done on him was adenoidectomy. That's it. And look at the mustache. Right? 27-year-old, 23-year-old, 39-year-old. So, right? And they're very hard adenoids. You will spend 2 or 3 wands many times and see how black it is from inside. So they are all smokers adenoids, and they're very difficult to cut. They bleed, and you have to spend a lot of time and wand to take care of this. But 39-year-old, and you'll see this all torus tuberis. Now, if you do not remove this torus tuberis adenoid, they will again regrow. So it's not that adenoid will go away at the age of 12. Never think. 39-year-old, see the way it's enlarged. And you have to do a complete work so that it does not come again, and then put them on a intranasal corticosteroid spray for a long term. So I think smokers and allergy. So I think in the interest of time, it's already 12 o'clock. And I thank you all for your attention. So they will give the memento to Prashant.
Thank you, Vikas, for the excellent talk and the good videos. Do we have a break now? We have a break. Vikas, we are continuing or we have a break? Okay.
So I would request Dr. Milind and Dr. Rashmi to share a memento to Dr. Prashant. So Dr. Prashant, may I have you here? Right.
One for this also.
Dr. Prashant, requesting you to share a memento with
us.
Yeah. Thank you so much, sir. So we would now break for tea for 15 minutes. Thank you.
Hello. Can we have everybody inside, please? We'll start the session.
So good afternoon, doctor. For the next session, I would like to call upon Dr. Bachi Hathiram on the dais, please. Ma'am, please join us. Thank you.
Good afternoon, and I hope all of you are awake after a good session of talks and invigorating tea and coffee. So we have our next session now, where we have again Dr. Vikas Agarwal speaking on the mechanism of palatal collapse and DICE explained.
Thank you, Dr. Bachi. So we again catch from knowing in obstructive sleep apnea, where is the obstruction? What is the level of obstruction that the patient is having? There are 5 ways of diagnosing a dynamic obstruction. Static, we have already talked. One is the flexible fiber optic in an awake patient, sleep MRI, Mueller's maneuver, apnea graph, and drug-induced sleep endoscopy. Obviously, we'll not get into details of each, but an ideal tool to know where is the problem will be one in which we can see these structures, know the size of the structures in relation to the space that they occupy, and their collapsibility. So if we see a patient who is awake without any sedation, this is how the airway is going to look like. So the patient is controlling the muscular tone, and therefore the airway is not collapsing in this case. So this awake examination is good to look at the structure, but not the collapsibility, because obviously the airway is not collapsing because the patient is awake. So it's good, cost effective, but not ideal and not reliable. Mueller maneuver is one in which you ask the patient to close the nose and take a deep breath inside. So you look at the pattern of collapsibility of the airway. You see that the airway is collapsing, but here you can see the pattern, not the degree, because the patient is awake. So this is what the Mueller maneuver will show you. What is the pattern of collapsibility of the upper airway? So again, pattern will be seen, but not the degree. And obviously you'll not know about the tongue base because the patient is completely awake. Then comes drug-induced sleep endoscopy. Now you sedate this patient slightly and the patient will go into hypopnea. So his airway is now shorter by 30-40%, and that's hypopnea. You can see the airway has become narrow, but it's not completely obstructed at this point of time. You can see the pattern, you can see the degree of collapsibility. And if you sedate him a little more, then gradually from hypopnea, the airway will completely close, and that's called apnea. Now you are seeing what are the structures causing apnea. And then obviously you can deal with those structures. So DICE will show us the structures, the pattern, and both the pattern and degree of collapsibility. And it also tells you about the anticipation of difficulty of intubation, extubation, because for surgery, obviously that is a most important factor. So it's not ideal, but it's the best we have as of now. And it's reliable and reproducible. And this is the exam that you obviously need to perform before you decide to dive in. So if you have to learn swimming, obviously you cannot learn swimming sitting on this side with a nice beer in hand. You have to, if you have to go deep down, then you have to test your waters first. And drug-induced sleep endoscopy is that testing of water that helps to understand what is the kind of airway. And it takes a long time. I started my journey in 2009 and 2013. This is 14 years of this journey. You take time to get mature. And along the way, we found out that BIS, bispectral index, gives a very, very good control over how much to sedate. And this score between 60 to 80, 70 plus minus 10 is the correct score at which you evaluate the airway. And what do you see inside? Sound, please. So you have a look and feel of the airway, which part is collapsing where. This is a mild sleep apnea case. So earlier there was a snore, then there was a. So now, looking into thousands of drug-induced sleep endoscopy over years, we realized that the mechanism of palatal collapse itself was not defined. So when anatomy, physiology, pathology, pharmacology itself is not defined, how you can think of medicine and surgery? So we tried to figure out what is the collapse which is happening, and if we can understand that collapse, then obviously we can devise treatments for that regard. So we tried to make some models on how this collapse is happening. So obviously soft palate is the most important part, and we all know soft palate from the front, being ENT surgeons. But unfortunately here we have to imagine this soft palate because the collapse is happening at the back. The collapse is not happening at the front of the soft palate. And when the collapse is happening, now let me try to replay it. So this was the movement which is happening while snoring and sleep apnea. Now this is the tip of the uvula. This is the lower part of the tonsil. So this is the upper part of the upper pole of the tonsil, which is covered by palatopharyngeus muscle, which is normal anatomy. Now let's see which part of the uvula goes behind and touches. Is it the tip of the uvula or the base of the uvula? It's the base of the uvula. So anybody who says that you can trim the uvula to half and take care of the snoring, will it happen? No. So either you don't touch the uvula or remove it completely. This is the first thing I learned from this observation. Second, is it the upper pole of the tonsil or the lower pole of the tonsil? Which is coming closer? Upper pole. Upper pole is covered by which muscle? Which muscle is participating? Posterior pillar, palatopharyngeus. Is there any muscle coming closer while doing the while having sleep apnea snoring? No. So then we realize that blood supply of the tonsil comes from the lower part, but problem is only in the upper part. So therefore I said go extracapsular in the upper part and intracapsular at the lower part. You will not have bleeding and you will also have problem of sleep apnea solved. So now if we take this understanding and put it into perspective, when the person is snoring, his tonsils are moving medially, little bit superiorly, because obviously the palate is like this. And if you see it from a different perspective, this is the anteroposterior view. So the tonsils are moving medially, superiorly, but they're also moving posteriorly, because if they do not move posteriorly, obviously the posterior pharyngeal wall will never be touched. So these are the movements which are happening at the upper pole of the tonsil. The whole thing is contracting, collapsing at the back. And these are the movements which are happening. And if you see it from this angle, this is covered with palatopharyngeus muscle. Now, if we understand this movement in relation to the structures, then the whole fear of performing surgery in the soft palate will go away. Why? Because you are absolutely far away from the vital structures. So what are the vital structures in the soft palate? What is soft palate required for? If I'm speaking to you and my soft palate is not functioning, my voice will become like this, completely a hypernasal voice, because my soft palate will not create a proper sentence, the nasality, that differentiation between the nose and the oral sound. So what is that muscle response? There are 5 muscles in the soft palate. Levator palati and the tensor palati are 2 muscles which lift and tense the soft palate. So these are the muscles which are responsible for when I drink water. If my soft palate is not functioning properly, water will come out through my nose. So these are the complications that we are scared of. For both these complications, what are the muscles responsible? Only levator and the tensor, and maybe to some extent musculus uvulae. But the two muscles from the bottom, palatoglossus and palatopharyngeus. Glossus is the anterior pillar and pharyngeus is the posterior pillar. Now let's look at the function of each muscle. This is the tensor palatii. It's quite anterior and it's only making the soft palate tense. So it's a good muscle. It is not coming in your way of sleep apnea because we know that the sleep apnea is happening here. And this muscle is much, much more anterior. So forget about this muscle. Tensor palatii does not even participate in sleep apnea. Levator palatii is the most important muscle because now here you're coming close to your area of attack. So you have to only differentiate your levator from the area of attack because the area of attack was here. This is where the sleep apnea was happening from. And levator palatii is just anterior. But if you understand that levator palatii is still anterior and cranial, then there'll be no problem. Anterior pillar or the palatoglossus, obviously it's a good muscle. It pulls the soft palate forwards. So we have no business of doing anything to that muscle because it's only pulling the soft palate forward. So if at all you can contract that muscle, you can pull the tongue forward so that the whole palatoglossus is pulled forward. It is only the palatopharyngeus which is the problem. You saw that during your dice that the palatopharyngeus, which was covering the upper pole of the tonsil, that is the part which actually collapses. So if you remain below the Lakshman Rekha, which is levator palatii and tensor palatii, you do whatever you want. You excise it, you reorient it, but obviously do not use cautery on it. Do not excise too much. Do not create a fibrosis over there. And you will get a good result. And luckily, most of the soft palates have only the lower part, which is collapsing. Now, coming to tonsillectomy. Tonsillectomy is an integral part of any sleep apnea surgery because it keeps both the pillars separate. But unfortunately, we all ENT surgeons believe that we know tonsils in and out. We only know one classification of tonsils, grade 1, 2, 3, 4, right? But tonsil is a 3D structure. It not only has a tummy, it also has a height and width. So if you only classify the tonsil based on the tummy, obviously we are going to miss on the height and the width. So this classification is inadequate. It is only in one axis. These two axes, the width and the height. The width will decide how far the posterior pillar is pushed, and the height again will decide how much volume will be there inside the superior pole of the tonsil, because that is the area which is your problem. So exophytic tonsils we all identify very easily. But if this is the cause of the problem, sound. If this is the problem, then you'll have your dices like this, which obviously we do not have most of the times. So if this is the cause, you can obviously do only a tonsillectomy. Because see, when the tonsil increases in size, it also pushes the posterior pillar at the back and creates a space shortage. So when the tonsil is endophytic, it collapses still inside. And that's where it, sound please, take it. Now see, this is the upper pole of the left tonsil. So now if you only remove the tonsil, the pillar will still keep on collapsing. So you have to do something to the upper pole of the tonsil and something to that posterior pillar. That's what my humble submission is. Now what you want to do is your choice. Look at all the surgery which are there. Remove the upper pole of the tonsil and the posterior pillar goes inside. There will be fibrosis. The anterior and the posterior pillar will come closer and the sleep apnea will also go away. I'll not go into the classification system. Now, this is our own classification system, which is yet to be published. So velopharynx is divided into two parts, the upper part and the lower part. And most of the velum is only narrow in the lower part. So we call them a funnel kind of configuration because you only take care of the lower part of the soft palate, which we just showed. This is again you can see this is looking like a funnel, only the lower part. The upper part is not obstructing. Say around 5 to 10% of the palates are tunnel kind. They are both collapsing in the upper and the lower part. In this case, having only the lower part of doing surgery on the lower part is not going to be completely effective. So for such patients, if CPAP is effective, that is the best treatment, whatever is the age and whatever is the BMI. But if obviously CPAP is not effective, then you do whatever you can to the lower part and whatever you can to the upper part, which is not going to be completely effective. Then in the upper part, you also have salpingopharyngeal fold, which was again our discovery in 2010, 2012 and 2019, we came out with the classification system. It took so many years to grade it 0, 1, 2. But if there is salpingopharyngeal fold, obviously that's a separate entity which is you obviously you cannot deal with the palatal surgery, so you have to channel that. That is our paper again in the Indian Journal. Now, what are the types of collapses we see in the AP lateral circular inbuilt in everybody's mind? Now I'll just take 2 minutes to dispel this myth. This is AP. Everybody is very sure. And this is lateral collapse. Now, let's will you call it a AP collapse now or a lateral collapse? Will you call it a AP collapse or a circular collapse? So now here it is AP. Here you will call it lateral. Here you will call it circular, right? So it's all a dynamic phenomenon. You should not get fixed by AP, lateral, circular and do this surgery. This is why I'm saying you understand the mechanism and decide what surgery you want to do, because you're going to operate on the structure and not the configuration. Configuration will give you a little idea, like the Friedman classification. It will give you a little idea, okay, if the tongue is big, then my surgery may not be effective. But that's not the ultimate thing. You have to know that structure in, out. And let me put it that way. So what is collapsing? Again, it is the base of the uvula and the posterior pillar, the medial part of the posterior pillar. This is collapsing. We are seeing it from the soft palate from the back. So that is the only part possible. So the medial part of the posterior pillar is made up of palatopharyngeus muscle again. So this is how you know which part is collapsing. And again, going to lateral. So when it is a lateral collapse, now let us show which part was collapsing. This is the area just behind the tonsil, right? So what is behind the tonsil? Again, posterior pillar. There's nothing behind the tonsil. So now it is the vertical part of the posterior pillar or the palatopharyngeus. So when the vertical part is collapsing, you call it lateral. When the medial part is collapsing, you call it enteroposterior. So it's finally the palatopharyngeus muscle only, along with the upper pole of the tonsil. There's nothing else, whether it is AP, lateral, and when it is circular, it's a combination of both. So I have tried to demystify so that you don't get confused all about that bottleneck area which you saw, right? So I'll not get into all this. So, right. So what is DICE? DICE will tell you about the high tongue base collapse and this is a high tongue base collapse. Sorry, this slide came in my way. So I'm just showing high tongue base collapse is where you see the foramen cecum and the anterior part of the tongue base collapsing, and lower part where you see behind the foramen cecum, which is pressing onto the epiglottis. That's the DICE will also tell you about the details of what is collapsing, whether it is muscular, whether it is lymphoid, or whether it is a combination of both. That was muscular. This is lymphoid. This is a complete lymphoid base tongue, huge base tongue, AHI 96, but completely lymphoid. So these two are totally different because you don't have to get into muscles here. So you'll not get a big vessel inside. In spite of being very severe, this you can surgically correct. There's no other solution anyways. So DICE will tell you about the detail and also make you understand this is a primary epiglottic collapse. This is purely a glossoepiglottic fold treatment that I will take in the next lecture. And then you can do various interventions. I think Rodolfo has already talked about this. So you can bypass the nose and the soft palate by putting in a nasopharyngeal airway and then doing, DICE through that, so that you know what will happen after your nose and palate surgery, whether the tongue base will still collapse, whether the epiglottis will still collapse. So all this we started in 2010-11. Now it is all the accepted world over standard way of treating. So this was about understanding the mechanism of collapse. Once you understand which part of the airway is collapsing in what way, then you can take care of that part. I have another talk. Shall I just, in interest of time, I'll just continue with that talk. So now what surgery will do once on the soft palate, once you have understood that this is the kind of collapse, this is the structure which is collapsing in this part, what will you do? So we got our paper published on this just last 15-20 days back. Dr. Rahul Gupta from Baroda helped us to write the paper. So as we discussed, that the area responsible snoring is much lower down, but the area responsible for snoring palati is much up. So once we understand that these two areas are different, then we can perform surgery on the lower part of the soft palate and still get away without any problem in the speech or swallowing. Now, if you look the same thing, this what you saw here, if you look it in the diagrammatic way like this is the anterior, posterior, lateral, lateral. Now this is the uvula, these are the tonsils, palatoglossus, palatopharyngeus, and lateral pharyngeal wall. The airway is here, this much. If you are supposed to increase the airway, that's why I said tonsil removal is the integral part of sleep apnea surgery. The moment you remove the airway and rotate the palatopharyngeus, remove the palatopharyngeus, do something on it, the airway will become so large. Right? This is well understood since last 20-30 years. Now, God has given a beautiful structure called pterygomandibular raphe, which is always anatomically anterior and lateral. How much anterior, how much lateral will depend on the anatomy of the patient, but it is structurally, anatomically always anterior and lateral. So all the surgeries are dependent on your removal of the tonsil and some kind of rotation or removal of the posterior pillar. What additionally we can do is to suspend the soft palate. We have to deal with AP collapse and lateral collapse. If it is only AP and we try to pull it anterior-posteriorly, it may start collapsing laterally. If you pull it laterally, it may start collapsing anterior-posteriorly because it's a collapsible tube. So if we can take care of both AP and lateral into every case, matter is solved. And that's what we decided to do with this concept, that we go across the midline from one pterygomandibular raphe to the other, suspend the anterior part of the soft palate anteriorly. Now it cannot collapse posteriorly. So AP collapse is taken care of. It will never collapse. And if you also suspend it laterally, because it's always anterior and lateral, it's there. So AP as well as lateral. If you suspend both the parts, in every single case, your results are going to be permanent and reliable. So with that concept, we went across the midline and then we started using non-absorbable sutures. After 3-4 years of absorbable suture, we started using non-absorbable suture. Now look at all these surgeries. This is zeta palatopharyngoplasty. So again, they divide the uvula into two parts and make the vectors. Again, it is palatopharyngeus which is rotated and sutured. This is lateral pharyngoplasty. Again, you suture it laterally. Again, which is the muscle? Palatopharyngeus, sutured laterally. Anterior palatoplasty, you take out a small wedge and suture it, so it pull the soft palate anteriorly. Capso, barbed, all are based on the same principle, but they have not gone through the base of the uvula. Because see again here, why the snoring does not go away? Because it's not going through the base of the uvula. If you go through the base of the uvula, then only it will stop vibrating. It's not the tip of the uvula, it's the base of the uvula. So by that concept, this is again only on the sides. If you want to preserve this, by that concept, this is the suspension bridge pharyngoplasty paper. You can go through it, Indian Journal. So here you put sutures across the midline, and obviously the surgical steps I'll go in very short. GA with endotracheal intubation, Boyle-Davis mouth gag. You remove the tonsils. If the uvula is very large, there's no problem in sacrificing the uvula. Some few days back, somebody put a WhatsApp post there, 20 functions of the uvula. So once you do UPPP, all those functions will be gone. But if you can save a patient's life or his snoring and sleep apnea, that small thing can be sacrificed. And in my career, I would have chopped off at least 600-700 of them so far. You get a foreign body sensation for maybe a couple of months, which is all right. But no patient has a lifelong problem on account of uvula removal. Right? I have hardly 1 or 2 patients who say, abhi bhi thoda lagta hai. But most of them are doing all right. So if you have to remove the uvula, remove it from the line joining anterior pillar to anterior pillar. The base of the uvula has to go. If not, then do not remove it. Then this is the dissection of the palatopharyngeus. I have not shown the entire thing. Then you use barbed suture. This is the non-absorbable one. Now
From the pterygomandibular raphe.
So pterygomandibular raphe. Now this is the cut end of the palatopharyngeus. You go from pterygomandibular raphe and completely lateralize it. So now the anterior wall of the pharynx is transposed into the lateral pharyngeal wall. So AP collapse is completely taken care of. You have removed the length of the soft palate from the base of the uvula, and now you have rotated this palatopharyngeus laterally. So there's no raw area. This palatopharyngeus, we already know that we are only dividing the fibers and rotating it. So the vertical fibers here are not cut, because vertical fibers will not, we are taking the whole thing in laterally. So the vertical fibers will also stop collapsing, because the whole palatopharyngeus is now pulled laterally. So it takes care of AP as well as lateral collapse both. This is the lateral collapse के लिए किया हुआ part. Then you go from right to left across the midline. This is for the AP collapse. Now you have already resected the extra length, and to further augment this from falling, you are putting a non-absorbable suture from right pterygomandibular raphe to the left. Now this has completely changed the results, because now as long as this suture is going to be there, earlier I was using absorbable suture, so it was working for 6 months to a year, but now 3.5 years I'm using non-absorbable suture. Go to the other side and then take this one. So now you're both AP lateral and come back to the right side. This is like a suspension bridge. Now this will not let the soft palate collapse posteriorly. So the snoring just goes away. Sleep apnea just goes away. Important is that this suture should remain in place. So obviously we have taken a long time to understand how the sutures will not show up, how they will remain in place. We are still improving. Our results are far from 100%, but they are still in the range of now 90% plus. The suture does not give way. So by this, you can mimic a zeta palatoplasty, which was a very, very aggressive surgery. The results are similar to that. You come right till there, but you don't have to make all those butterflies. You do not have to take sutures. Pain factor is almost 1/10 as that of zeta. Because those days barb suture was not there. And those days cautery was used. Therefore, you could not take a mucosal incision. Now with the coblation, you can take a mucosal incision. So these are the things which have happened, and this bridge can move sideways. So suppose if this patient, I'm just showing, this is a tonsillectomized patient and only a suspension bridge, right to left and left to right. So there's nothing here, pure AP collapse. So I've gone from right to left and left to right, and now see the end result. Now this AP collapse cannot happen because the suture is holding this soft palate. Uvula is very small, so I've not removed it, but it can move superiorly. That is the whole point. It cannot go behind, so it cannot collapse. But when the levator palati and the tensor palati are, contracting for swallowing and phonation, this can move superiorly because the anchor is only on the side. So it will prevent a posterior collapse, but it can always move superiorly. And that's the whole basis of this surgery. So what surgery you want to do, and it also prevents high collapse of the high tongue base, because there's no surgery for high tongue base, but the tongue will go and sit on this suture on the lower part of the soft palate, and it prevents high tongue base from collapsing. So once you understand the mechanism of palatal collapse, then you can take your decisions on what palate surgery you want to do. Whatever suits your hand, you can do. But my effort was to make you understand the mechanism so that you can take a sensible decision. Thank you very much.
Thank you so much, Vikas, for making our complex topic so simple. Just one request: if you have a laryngopharyngoscopy or a scopy done in a patient pre and post surgery, it would make a very big difference for us to understand.
Absolutely.
Like how it's collapsing, and now after the surgery that you've performed, how the entire airway remains open.
Perfectly all right. So it's a post-op dice actually we can perform. That's a very, very nice suggestion. Thank you. Thank you.
So
yeah, so that's I showed that suture material. Obviously, it is from a Covidian company. So this non-absorbable suture material, I've used it for the first time. So it's a 3O barbed suture with one end, there's a loop so that it cannot be pulled completely. So once you pull it from one side, the loop holds on at one end, then you can complete your job and simply cut it off. So it cannot pull back because of the barbed suture. I use a non-absorbable one, and now there's a paper published so everybody can use. Earlier I was using absorbable ones. No, it's not radio opaque, no. It's same like that proline material, some butex, polybutester. Thank you.
Thank you so much. Our next speaker is Dr. Seema Sheikh. He will be speaking on decision making in OSA. So while Dr. Seema's talk is being set up, I would use this opportunity to thank the organizers and Dr. Vikas for inviting me over here and honoring me. And I'm sure all of you present over here, especially the junior residents, are definitely benefiting from this. Yeah, take notes if possible, because this is something which is very new, very different, and you are learning from people who are the best over here.
Hi, good afternoon. Thanks, Betty, for letting us start on time and we'll finish. Thank you, Vikas, for making it very easy for me now, because decision making in OSA in a 15-minute talk, I think, is not doing justice to it at all. He's covered quite a bit of it, so I will not dwell in that part of the decision making. So what I won't be dealing in this talk today is about the palatal surgeries, which he's already covered. I'll purposely not dwell into controversies of DICE. It's a huge topic. There is a lot of controversy around DICE, and I wouldn't be doing justice to it by just putting that point across and then not going through with it. And we will not be discussing about the dental and maxillofacial parts of OSA treatment. This is how we've evolved with regards to decision making. What were we doing for decision making? We were doing a polysomnography, and since the ENTs were not learning so much about it, we learned more about it. We got into understanding PSGs. We did scopies. We did them either awake scopies, then we went into DICE. We were incriminated by saying that DICE is not, awake scopies is not good enough, or your DICE is not good enough because you're not telling us which level of sleep you are in. So we advanced. We went to do DICE with BIS. We did it with advanced DICE. We also did interventional DICE. And after having these three modalities, we started deciding on treatment accordingly. That's how we've evolved. But it's not so simple, because every step of the way when you're dealing with a patient of OSA, you have decision makings that have to be done. Every step of the way. Starting with doing a sleep study, we've discussed that we need to do the sleep study. We need to know which one to do. And I think the basic take-home message there would be that try to aim for a level 1 if you can. And if it's not available to you, at least do not touch without a level 3. So you need to do at least that bare minimum. But at the same time, now again, decision-making continues. You get the report back. You have to first figure out, is that an adequate report? Is there a correct report for you to justify your findings on? So there are criteria to tell you that maybe the sleep study was not adequate enough. So you need to know the criteria, whether to rubbish off the sleep study that has been brought back to you, or whether it's really worth assessing. So in short, these criteria will be in the books for you to figure out, but important for your decision-making scenario. Then the question of doing an FNLP, and the obvious answer is a yes. That is something which is now not even a question that has to come up. It has to be done. The next step question about doing a DICE, whether to do it or not do it. That is a question now. That is the controversy. Then there is a question about in whom do we do it? If at all you're going to do it, in whom do we do it, and when do you do it, right? Now, these are the important questions that you have to answer yourself, and there's data out there which has been published, which clearly says that your DICE does not significantly affect your decision-making capacity. Now, having shown you data and evidence, I'd also like to go ahead and say, if I am a lawyer and I am defending somebody, I will bring out defense data. If I'm a lawyer and I'm prosecuting somebody, I will get out prosecution data. So just don't go by data to and fro, because it will all depend on what I'm trying to portray. If I'm prosecuting, I will say DICE is very important. If I'm defending, I will say not. So leave that aside. There's a certain rationale that you have to apply. Where would I do that DICE? That's the question that you have to answer. So if I have symptoms or sleep study or clinical evaluations which are not correlating, I definitely will want to do a DICE. That's something that I will want to do. If it's a previously operated case, definitely I will do a DICE, because I really need to know what went wrong if he's come back and it's not helped. But I will always do the DICE after I've finished tackling the nose and the nasopharynx, because that's open for me to see. I don't really need to do a DICE before that. I'll finish that as a first stage, and then I would do a DICE, except for if I'm doing a single staged multi-level. In that case, before I touch the patient, then I will do a DICE, because then I need to know what is the entire process. But if I'm only dealing with the nasal and the nasopharyngeal part, I don't need to do the DICE at that stage. I can always keep it for later, depending on as is needed. When to do it is a big next question, and you don't do it immediately post-op. This is for medical legal reasons for the youngsters also to understand. You schedule your DICE a day before. You make sure that your patient is told the DICE reports and the patient understands it and is concurring with you in what next treatment. You don't take a patient up for DICE, do a DICE, take a consent from the relatives and go ahead with the surgery, because in that case, you have already pre-decided your procedure and your DICE is of no use. So you need to be able to justify why you're doing a DICE. And there is a lot of controversy, like I said, where if DICE is not changing my treatment, like if he's already mentioned to you that you're going to do this one procedure, which is already tackling the upper part of the soft palate and tackling the lower part right to the pterygomandibular fossa. So if there's one procedure, the earlier time we had issues with DICE were because you didn't know what procedure to do. Now, if everything is boiling down and coming to separating the lateral wall and lifting up the palate, and you know there is a procedure there that can be done, how does DICE make the difference? So that's just to get you to start thinking. And there is, again, lots of controversies on that. So the decision on the surgery will be where we do it, meaning what structures, when we do it. This is an extremely important decision that you take. You don't become knife happy and you don't go ahead and tell a patient that you'll be to operate tomorrow if he's willing to do it today. You need to get to an optimal BMI situation, because that will help you give better results. Of course, patient logistics will come into the picture depending on anesthetic fitnesses, physician fitnesses, whether he's from city, outside city, etc., etc. And then what to do, we've already decided now the various structures and how we're going to be tackling them. So if it's the nose, I don't need to tell ENT surgeons about turbinate and septoplasty, because has already shown you about turbinates in the morning. You have options available to you to decide between what you have and what you don't. But yes, if you're doing nasal surgery, a CT scan is always recommended, because you want to make sure that you're not missing out anything. If you're dealing with bony turbinates, removal makes sense. If you're dealing with only engorged turbinates, volume reduction makes sense. So that's how you've got to take your decision making. When you come to the next structure of salpingopharyngeal folds, the reason why radiofrequency doesn't make sense and coblation makes more sense is because there's less dissipation of energy, and you have the carotids just lateral to your SP folds. So even though you're pulling it medially and then inserting, always better to use a coblation, because less thermal damage that you can have. Adenoids, options wide open, but consensus generally is towards coblation today. It is one of the best tools that is available for you to be using for adenoidectomy. We've already spoken about whatever we need to do, boundaries and things like that, but you need to be able to justify. Let me tell you this, you should be able to justify the tools that you're using. If you're going to say that I'm going to use a debrider initially and then use a coblation because I have both of them, that's not justifiable just because you have both your tools with you. And if at all you want to use them for your surgeon comfort, don't charge the patient for it. He should not be charged 2 technologies for the sake of doing 1 surgery. You also have to consider a very important factor between the bony tissues and the soft tissues. That's where the maxillofacial people will come in, because it's a very obvious decision when there is a bony cage issue, which can be seen visually and then taken further by evaluating it even more in detail with dimensions. But there's a gross look you can make out there's a soft tissue and a bony tissue issue. There's a bony tissue issue. Do not try to get into soft tissue surgeries first, because it's not really going to help much. And you have to understand that in such a situation, if you see, and this is something you see clinically, you see a high arched palate. There is no point in doing a nasal surgery for such a patient also, because you're not achieving that particular expansion. So what we call as a distraction osteomaxillary expansion. This is something that the MaxFax people will tell you, or our dental colleagues will tell you. It's assisted by screws, it's assisted surgically. They'll get into the details, but the idea is this. You expand the nasal floor, gives you a nasal airway opening much better. It also helps a lot in opening the posterior pharyngeal space, which they will explain to you. We all know that UP3 had failed, the classical UP3, and what we need to do for the palates, we already know. Since the lecture is over, I'll skip that and come to the base of tongue. Now we have a kind of a classification where we've decided what are the levels of the base tongue, upper, lower. There's no upper and lower anatomical defined demarcation. It's more of a visual look as to where you know where is the upper tongue and the lower tongue. And there's a simple logic to it. If you have an upper tongue base issue, it's more accessible through the oral cavity. Whereas if you have something behind, it's obviously more accessible through the neck. So if you look at it from the upper base, tongue base kind of procedures, you have options. You have RF channeling, you have coblation excision of the tongue base, you can do coblation channeling. And if you have it lower, then you use a hyoid suspension. But when we talk about the options that you have for the upper tongue base, your decisions have to be based on certain things. They will have to be based on your patient choice and comfort. More importantly, on your own expertise and training. It's not so simple to do an excision of the tongue base as it may be to do a channeling of either midline or on the sides with an RF coblation. So that's something which is very important. And even after that, you have a certain learning curve to attach the tongue base. It's not something that is very easy for the novice. So these will be your decision-making points before you start entering intraorally. If you start doing it via the neck, it's a simple procedure. All of us who do literal small neck work can very well do this procedure. And you can actually check the results of the expansion volumetrically later on. But having said that, keep in mind that the distance between the hyoid and the thyroid cartilage is really not that much. You're going to probably achieve maybe 3, 4, 5 millimeters maximally, and that too of soft tissue expansion of a muscle, which over a period of time will lose its tensile strength. So always keep that in mind when you're counseling and talking to patient with regards to results. Of course, you see an epiglottis like this, it is but understood that you've got to do some kind of a supraglottic epiglotectomy, or you do a bulgarization of the epiglottis. Bulgarization is very simple. The lingual surface of the epiglottis gets bulgarized to the tongue base on the other side, and you will have a nice airway open that can be there. The most important thing that you may have to discuss with your decision making when you're talking to them is, are you going to be doing it single level multi-stage, or are you going to be doing it single stage multi-level? A lot of this decision making will depend on whether your patient is from within town or out of town. A lot of this will depend on whether your patient is willing for multiple admissions and going through multiple admissions over a period of time, because each stage will have to be staged at least 1.5 months apart. It will also depend on whether the patient is insured and is willing to spend that kind of money or not. And if not, it's also better sometimes that if there is a lot of obstructions which you can tackle at a single stage, even if he's from within the city, and it is quite comfortable for you to do it with a lower BMI or a reasonable amount of BMI, it would make sense to get that patient through in one shot. So your decision making on this becomes extremely important as you go along with the patient. And I've told you the criteria on which you base your decisions. And the most common question that gets asked, can I do a nose and palate together? Can I do a nose and tongue base together? Can I do a palate and tongue base together? So for that, you have to understand this concept of one major and two minor. And if you look at the list, a septoplasty is no longer a major surgery because all of us do it, like has been said, not correctly most of the time. We have to learn it, but it is a minor procedure, number one. Secondly, more so because post septal surgery, I think 80 to 90% of us, all of us, are no longer packing the nose. We're either using quilting sutures, we're using splints, or sometimes we're just leaving it like that. So if your nose remains open, you can do any kind of surgery with the, so even with a packed nose, okay, just to show you a small little clipping. You do a nasal surgery, you put in a nasopharyngeal airway, you're worried about bleeding, you still put in the Avalon packs on both sides. Very comfortably they go through. And immediate post-op, it is not like the patient will have any great problems because he's got both his nose packed. So you can see the patient immediately post-op on table is so comfortable. But see the patient's BMI, see the selection. Selection has to be right. So what I'm trying to say is nose and palate is not a problem to do together. Nose, tongue base, also not a problem to do together, provided you keep the nose open and there's not much chance of bleeding. So when you understand this concept, one major, two minor, do whatever you want. All channeling procedures come under minor. All channeling, whether it's a channeling of the palate, channeling of the tongue, RF channeling, coblation channeling, turbinoplasty channeling, turbinate channeling, or septoplasty. So one major, two minor. If you understand this concept, it makes life much, much easier for you to plan everything. But in spite of that, you have tough decisions to make sometimes when you have niche practice, like what I do. So here's a guy who comes to me with a very high BMI. He's HIV positive. He's on dialysis. He's not at all happy with PAP therapy because justifiably so, that is what is given to him. And he's on the waiting list for a renal transplant. So decisions can be tough. And the only kind of tough answers that you can give such a person is a tracheostomy. That's the only thing that you can offer him as of now. So decision making is not so simple. It is involved at every step of the way. I'm not covering everything in the interest of time, but important points which will help you start your work. I haven't spoken about dynamic MRI at all. I haven't spoken about quite a few things. I haven't spoken about MaxFac, but I'm trying to give you very clear-cut messages where your decision making becomes easy. And this decision making comes from interacting with people who think logically and sensibly. And always remember, nobody remembers your PowerPoint at your funeral. And whatever advice you give your patient in today's date, remember that the patient and relatives understand this very clearly. Thank you. So don't try to give them ideas and things which you think they don't know about. They're very smart in today's date. Thank you very much.
Thank you, Dr. Seema, for a very informative talk. We will need one more SNORECON as a continuation of this because there's so much to learn on this topic.
That's the reason why I said, but sometimes it's very important to incite the interest, and you can't go on justifying every talk to be a complete talk. So very important to get out the right messages for the people who are wanting to come in.
Right. Thank you so much.
Thank you, sir. I would request you to share a memento with Dr. Bachiram. Hathiram. Thank you. I would now request Dr. Divya Prabhat to further moderate session 4. Over to you, sir.
Since Dr. Clemens is waiting in Germany, we'll take his lecture next. Dr. Clemens Heiser is one of the most well-known surgeons in the world for performing hypoglossal nerve implant, though we do not have hypoglossal nerve implant still in India. But hi, Clemens. But Clemens is trying his best to get the Nixoa company to come to India very soon. And let's learn from the master what a hypoglossal nerve implant is all about and what is the new opportunity for all of us in the country. Dr. Divya, please invite.
Welcome, sir. Atiti Devo Bhava. So I welcome Dr. Clemens Heiser, and of course, hypoglossal nerve stimulation is a new thing for all of us. We've only heard of even cardiac pacemakers or a DBS, what is done for Parkinson's, but hypoglossal is a new thing for us over here. Please, Dr. Clemens Heiser.
I hope that you can hear me.
Very well.
Yes. Okay, that's perfect. So I will share my screen. Thanks so much for this very, very nice introduction. And probably Vikas is right. And in a few weeks, months, probably hypoglossal will be also available, hopefully, in your country. So let's start with my presentation. So you should now see perfectly my screen, right? That's perfect. So we talk a little bit about hypoglossal nerve stimulation. These are my conflict of interest. I'm a consultant for big two companies, Nixoa and Inspire. That's important to know because they are involved in this topic. And this is one of my also very big conflict of interest. I'm addicted to the hypoglossal nerve. It's my favorite nerve in the human body. The main question is, why the tongue? Why should we stimulate the tongue, or how the tongue can probably help us to solve the problem with obstructive sleep apnea? It is important to know that the tongue is an extraordinary organ. It's a muscular hydrostat, and also the elephant, which you can see over here, has a muscular hydrostat. It's a biological structure also in animals to manipulate food items, and it consists mainly of muscle with almost, at least in humans, no skeletal support. It has a hydraulic movement without fluid in a separate compartment. And at least the human tongue is anchored to the bone, mainly to the mandibular, and with the geniohyoid muscle, which is actually not a muscle of the tongue, also to the hyoid bone. The tongue is free to move and can completely shape itself, right? This is something which you do not find in any other human muscle, to be honest. To have such a complex structure, a lot of different kind of muscles which are connecting to each other and able to move almost in a 360 degree. And the hypoglossal nerve anatomy is much more complex than we thought. When I went to medical schools 17 years ago, of course, we already knew that the hypoglossal nerve is supplying, supporting, innervating the human muscles, right? Everybody of us knew this is not something new. But in 2010 and in 2013, when people start to talk about hypoglossal nerve stimulation as a possible treatment for obstructive sleep apnea, two anatomic people during these times from New York, Mu and Sanders, were completely looking in much more details. And they figured out that the terminating branches of the hypoglossal nerves are 50 to 60 fibers. And they started, and this is a very, very nice publication from 2013, also to draw a three-dimensional atlas of the human tongue muscles. So they figured out which muscle group is supporting which kind of movement of the tongue and which fibers from the hypoglossal nerve are supporting this. And this is the main basic right now, which we need to understand, which we need to know if we talk about the hypoglossal nerve stimulation. So, but don't talk too much about physiology, right? Let's go a little bit more in detail how clinical routine looks like. So there are right now 3 different systems available. There is a unilateral stimulation, which is the Inspire system. I think a lot of you have already, of course, everybody have heard about it. It is available in Europe and North America. It is the system with the longest tradition with most of the publications. Then there is the bilateral stimulation of the hypoglossal nerve. The difference between unilateral and bilateral is unilateral has a cuff electrode, bilateral has pedal electrodes. Okay, this makes a difference. If you talk later a little bit about electrical fields and how you're stimulating the nerve. And then there is the target stimulation, which is the LivaNova system. Right now, LivaNova is not commercially available, also not in Europe. They are running an FDA trial, which probably will end mid of next year. And after finishing the FDA trial, hopefully with positive results, they will be also available again in Europe and in North America. So these are the difference between the systems. Of course, every system puts electricity on the nerve, but I can let you know the surgical approach is completely different between the systems, and also the activation later on and how you can stimulate the nerve differs between these different systems. So it makes a difference what kind of system you're using. But also, to be honest, right now, we do not know probably if there is a patient group which belong probably better to one of these systems, or probably which patient group you should not offer one of these systems. This is something which is still under clinical research, which we still need to figure a little bit more about it. So let's see what happens. I think for bilateral stimulation, which is very smart, is that it's completely MRI compatible till 3 Tesla. This is something which is unique. Inspire has it till 1.5 Tesla, FDA approved, but not in Europe CE approved. So let's go a little bit back to understand the difference between the system, because the surgical approach is different. So this is the muscle. These are the muscles. This is the tongue. And then the hypoglossal nerve under the hyoid bone, in most of the cases, are running into the muscle and then separating into different fibers. So there are some fibers which are responsible for muscles which you do not want to stimulate, because these muscle fibers are mainly retracting the tongue. We need them for swallowing. Then we have a lot of medial fibers, and these medial fibers are mainly supplying the GGO-GGS. That's a genioglossus muscle, our main target muscle, our main upper airway opening muscle. It has 2 compartments, the oblique compartment and the horizontal compartment, and then which is not actually from a embryological point of view, the genohyoid muscle, which not directly belongs or is count to the tongue muscles, but also important to move the hyoid bone forward and to help also on hypopharyngeal level to get a better opening. So the bilateral stimulation is a pedal electrode, which is placed on both sides of the nerve to stimulate. It's also a selective stimulation. So you're targeting the main upper airway openers. That's the same with the Inspire system, but Inspire is just on the right side, or in some cases on the left side, but unilateral stimulation, also selective. And it's not a pedal electrode, it's a cuff electrode. And then we have the Aura 6000 system, which is the LivaNova system, which is target on the main trunk of the nerve. And now everybody would say, okay, but then you're also targeting the retractors. That's completely right. But they have more electrodes, platins inside their cuff electrode. And afterwards, when they activate, they are playing around with these electrical fields and mainly then later on stimulate the opener of the upper airway. So the surgical part with the Aura 6000 is the easiest one. You just need to find the main trunk under the submandibular gland of the hypoglossal nerve. You put it around and you're done. But the activation later on will be much more complicated. So the sleep physicians or whoever who's going to do it will probably have much more efforts to put in to get the good results. With Inspire and Nyxoah, we as surgeons are more asked to do an accurate placement of these things. And it works. And this is a study which we are pretty proud of it, because, I mean, you know the discussions which are going on with the conservative sleep physician. They always ask, you have no results. Nobody knows what you're doing. You always do like big case reports or something like that, putting 10, 15, 20 patients doing surgery on them and then compare baseline to afterwards. Of course, from a scientific point of view, they are right, but everybody knows that a randomized crossover trial or a randomized sham crossover trial is not easy to do. But with hypoglossal nerve stimulation, we were able to do it because everybody, and it didn't matter if this was a responder or non-responder to therapy, were asked to take part in this trial after implantation. Then we randomized these people to 1 week of therapeutic stimulation, 1 week of sham stimulation, and then we did a crossover. Okay, the patient did not know how the IPG, it was done with the Inspire system, how the IPG was programmed. It was just a sleep tech. And we did at every part, after every week, we did a PSG, in-lab PSG polysomnography. And the results were unbelievable. The results showed, which you can see in the table over there, of course, we had a huge decrease in AHI. We could show a huge decrease also in ODI when therapeutic stimulation was turned on. And with sham stimulation, all of that were gone, okay? They almost come back to their baseline AHI. And also, if you ask the patient for ESS and FOSQ, again, the results were much better under stimulation compared to sham stimulation. And just recently, which is just EPUB ahead of print, has been published a very, very nice, I think, overview, hypoglossal nerve stimulation compared to doing nothing, to other airway surgery, and also a little bit to CPAP. But to be honest, I need to be fair to everybody. I think the biggest bias we have in comparing one surgical treatment, and that doesn't matter if you compare tongue-based surgery to soft palate surgery to hypoglossal nerve, whatever, you have the big bias that the patient selection is probably completely different. So your patient cohort you are looking for will probably differ too much from each other, that it will be hard to compare these different studies to each other. But at least they did it over here in this meta-analysis, and they showed that the post-treatment AHI below 10 and 15 events were significantly lower in the hypoglossal nerve stimulation group if you compare it to any other surgery. And also the shear success rate were significantly higher in the hypoglossal nerve group. And they also compared it to CPAP. And this was a study which we ran over. So we tried to figure it out. I'm also a sleep physician. I'm running my own sleep lab. So I took patients who received the CPAP. I took patients who received hypoglossal nerve stimulation, and I tried to make the two groups comparable to each other. So the BMI, the gender, the age, and also the AHI was in both groups the same. This is important. And this we did for every subject. And then we compared these subjects to each other. Of course, the best thing would you randomize this patient, okay? A patient who is coming into my sleep lab, diagnosing of sleep apnea, and I say, okay, now you can take part in the trial and let's see if you get a CPAP or a hypoglossal nerve stimulation. But there are, of course, from an ethical point of view, at least that doesn't work in Europe, and also regarding reimbursement, because of course, hypoglossal nerve is much more expensive compared to CPAP. But we could show, and this is something which we at Surgeon we can be proud of it, there were no significant difference. We never wanted to show that hypoglossal nerve stimulation is better than CPAP. I think we don't need to show that surgery is better than CPAP, okay? CPAP is in a certain amount of patients working perfectly, okay? So nobody needs to complain about it. That's the same with oral devices, but also surgery and hypoglossal nerve stimulation is working perfectly in a certain amount of patients. So we need to figure it out, even on the one hand, probably in the future, which patient is probably suitable or has probably the highest chance to get the best results. That's the one thing. And the other thing is probably we need to talk to the patient, what the patient really wants to have. And there, at least hypoglossal nerve stimulation was as good as CPAP. Okay, that's at least not too nice. But, you know, if you start like for instance, most of the people in the world started with Inspire. And Inspire had the problem in the very, very early beginnings that they had a complete concentric collapse on the soft palate. Okay, and they needed to exclude these patients. And the higher the BMI is, the higher the chances that you get a complete concentric collapse. That was in 2010, 2011. almost during these times, Inspire failed to succeed with their clinical trials because they had just a responder rate of 50%. And this is, I mean, who can you convince also regarding reimbursement if you have just a responder rate of 50%? So they did a retrospective analysis and they figured out that the complete concentric collapse needs to be excluded, and then the responder rate gets higher. But that was just be done during 12 patients during these times. So bilateral stimulation, probably with a greater effect on the soft palate, which you can also open during hypoglossal nerve stimulation, probably seems to solve this problem. And there was a case report from Richard Lewis, I think if you want to know him very well, where he could show that because he implanted off-label a patient with a complete concentric collapse, because in the beginning also bilateral stimulation excluded this patient, but he implanted, and this is, you see it in the table over there. So he could show with a case report that the AHI decreased from 34 to 1.6. Okay, it's just a case report, of course. But this case report then led to the trial, which was called Better Sleep in Australia. And they were looking at patients who have just a complete concentric collapse. It was a multi-center prospective open label 2-group study. Of course, in the beginning, it's always like if you want to expand your FDA CE, it's a safety and performance trial, but also they try to figure it out what were the clinical outcomes. So moderate to severe patients with sleep apnea were included, body mass index below 32, and of course, again, like in most of the countries in the world regarding reimbursement, failed or refused to tolerate CPAP. So 184 patients were screened for this across 8 Australian sites. 42 patients were implanted. 74 of these patients were male, and I think the age and the mean BMI is what you find at least most in our studies if you look at hypoglossal nerve stimulation. And these were the results, okay? Just look at the results regarding AHI responders and the mean AHI reduction. So you see we had a very, very nice 73% of AHI reductions in the entire cohort. But also if you look at the CCC cohort or the non-CCC cohort, a little bit more, probably less working in the CCC cohort, but these results were not statistically significant. So you can say that bilateral stimulation at the end works as good as in CCC patient as in non-CCC patient, because with bilateral stimulation, you probably have a better opening at the soft palate. And this is the reason, the physiological reason behind it, how you can explain it, why it's probably very nice. But what is the future? I'm also involved in some clinical trials, startup companies here in Europe and North America. The future will be a little bit more different. Of course, hypoglossal nerve stimulation was a big milestone on the one hand, but this is not the end of the story, because I'm always a little bit blaming the companies. The electricity, everything you build in your devices is 30, 40 years old, okay? This is nothing new, to be honest, okay? This has been available just to put a little bit electricity on the nerve. Every pacemaker did it already 40 or 50 years ago or something like that. So, but there are other mechanisms how we are able to open up the upper airway. Of course, the pharynx is a flexible muscle suspended from the skull base and spine. It is motivable in anterior, posterior, and also in caudal directions. And this is a little bit provocative. Even I'm also a sleep physician, but 50 years, we always thought about putting everything forward, right? Getting everything forward to open up the upper airway. But that's not the truth. That's not the whole story we need to keep in mind. There are 3 physiological supporting mechanisms, of course, the genioglossus for the IP direction, but also if you get tracheal traction, if you're stimulating the strap muscles, the infrahyoidal muscles, if you're stimulating these muscles and moving the hyoid bone forward and getting also some suspension on the tongue base, you are able to stabilize and to open the upper airway. And also, of course, if you talk about the constrictor muscle, there is an intrinsic pharyngeal muscle tone, which you are able then to stabilize the upper airway, at least during wakefulness. The tracheal traction can be easily gained by stimulating the ansa cervicalis. The ansa cervicalis is a very easy surgical approach. For the intrinsic pharyngeal muscle tone, you need to go to the glossopharyngeus. And this is a challenging part from a surgical point of view, because it's very deep inside next to the skull base where you need to consider. So this is surgery, which cannot so be easily to be done. And if you probably put these forces together, of course, they are working against each other, but probably if you have just a minimal amount of stimulating, like the hypoglossal nerve and also the antercervicalis together, then you probably have like synergistic effects, which we also have during wakefulness. And this is in courtesy of David Kent, who's a good friend of mine, and I'm also involved in some clinical trials. And I find this DICE video are the most convincible videos. He has now a lot of more data available, which has been also published. On the one hand, you see here over, like a ladder, still a ladder wall collapse in a patient who received unilateral hypoglossal nerve stimulation with the Inspire system. Okay, this patient already has stimulating, but he was a non-responder, because you can see they performed the DICE again, and you can see that this patient still has a lateral wall collapse and a kind of mimicking of a complete concentric collapse on the upper airway. However, but still there were obstructions. Okay, this patient were non-responders. What he then did in these patients, and he did in a lot of more patients in clinical trials, he did a transcutaneous stimulation with a hook wire electrode, ultrasound guided, on the ANSA. This can be done pretty easy. It's not too hard, but it's just to figure it out what happens if we stimulate also the ANSA. And this is the next video, and I think the video is the most convincing one. Just look, they stimulate the right side, but look how he is able in the same patient with the same amount of propofol, dose of propofol, also to stabilize the right side of the lateral walls. Okay. This is something which is really unique. So we think the next deal breaker or the next step in stimulation of the upper airway will be the combination on hypoglossal nerve stimulation and also on antercervicalis stimulation. And Nyxoah is right now the company who has the patent in it, who's working together with David Kent, and this will be probably the next things. So what are the results? Okay, HNS in the clinical ruling is safe, well tolerated, and accepted by patients. It shows a very good adherence. It's highly effective, and I can let you know, I just got a small future what is out there, but we will see a lot of new innovative therapeutic approaches in this field, and this probably will one day make neurostimulation to smart neuromodulation. Thanks so much for your attention.
Thank you, Dr. Iser, and for taking us into the future. So the first question that comes to our mind is that what would be a single most important criteria for deciphering whether our patient should go in for surgery or a CPAP on your procedure?
Okay, to be honest, I think we should offer our patients first of all, always CPAP, because CPAP is a treatment which works at the end, at least in a few amount. I think it differs a little bit probably from country to country. I don't know if you have reimbursement in India for CPAP, but in Germany, the insurance are paying for CPAP. So the patient at least can try CPAP for a few days. He doesn't need to pay anything. And then if he refuses, he can refuse it, and then he can consider neurostimulation. We cannot take directly the patient into neurostimulation. He always needs to try to use a CPAP, otherwise the insurance won't pay for it. And neurostimulation is a pretty expensive thing. So it's 22,000 euros or US dollars, something about this. So if you consider probably your patients to pay out of the pocket, nobody will do it. Every patient will always first try to use CPAP.
No, but over here also for DBS or even the cardiac pacemakers, the insurance company does compensate. So do you think it will run? If money is not a criteria.
Okay, if money is not the criteria, then I would always let the patient decide, to be honest. Of course, you need to fulfill the criteria for hypoglossal nerve stimulation, AHI between 15 and 65, BMI below 35. CCC excluded Inspire, not included in Nyxoah. If everything is fine and money don't talk about it, let the patient decide. Let the patient probably decide which treatment is probably the most suitable for him. But keeping in mind, a CPAP you can try, just lay down, put it on his nose. Neurostimulation, you need to do the surgery. there is no chance of trying if it's working or not, or how it feels like, or something like that. But I would always get the patient into this decision, to be honest.
Can we decide by examining the oral cavity if the tongue is floppy or the tongue is atrophic or smaller in size? Would that be an indicator for your procedure?
There is no data available on that right now. No, we know that a female, older, thinner lady has the highest chance for responding. But to be honest, who has an old female thin lady normally coming into the office and asking for getting a surgical treatment for sleep apnea? I don't think that this will be a lot of patients. I mean, more patients are normally male, a little bit higher BMI, and probably mid of age or a little bit older, at least over in my department. But there is no other criteria right now. We are still looking for it. We are also trying to figure it out from PSGs to look if there is any phenotyping, endotyping, all these things, and probably who could be a better responder. But right now, there is no reliable scientific data.
Well, there's nothing like a old lady, basically. So thank you very much. We had a wonderful time, and Dr. Rahul will be.
Hi, Dr. Clements. Rahul here. Excellent talk as always. Always a pleasure to hear you. So my question is: have you ever, if you're aware of any data which has taken what David White and Denny Eckert's group has done with the genioglossus EMG? They're trying to take the amplitude of EMGs and trying to quantify the neuromuscular tone. So if you know if any study has looked at that versus effectiveness of hypoglossal nerve stimulation.
No, I think not regarding the EMG. It was just the group around Olivier van der Wegen in Antwerp, together with Andrew Holman, who were analyzing the PSG data from the STAR trial on phenotyping and endotyping. And they figured out if somebody has a low arousal threshold, he's on a higher chance to be a non-responder. If he has also a high loop gain, he's on a higher chance to be a non-responder. And this were the criteria they could get out of these trials, but not regarding the genioglossus tone. I would totally agree with you that probably from a physiological point of view, somebody who has a low genioglossus tone and shows a great responsiveness if the genioglossus is activated and it's not a muscular, if it's a neuromuscular problem, then probably this will be a candidate for being a better responder. On this, I agree, but there is no real data showing this. It's just a theoretical construct right now.
Right. Thank you so much. Thank you.
You're welcome. Thanks.
Thank you, Dr. Vikas.
So, hi, Clemens. I just wanted to thank you from the bottom of my heart. It was a wonderful talk, and the audience is already thrilled at the possibility of we getting the neurostimulation soon in our country, and all thanks to your efforts. Thank you once again.
We will do it, and you have a good chance that it probably will happen. It's just probably more a legal thing what needs to be done to get the devices to India.
Yes. Thank you very much. Bye-bye.
Perfect. You're welcome. Bye-bye. See you soon. Thanks so much. Have a good meeting.
Yeah. Now, so I request Dr. Mihir Shah will be speaking on. We are having a lot of food for thought now. So, Vaishali, you can wait. So, Dr. Mihir Shah is getting ready. We'll be speaking on myofunctional therapy.
Yes, sir.
Of course, for us, ENTs, it's a new thing. In our books, we have never read about myofunctional and all those things. So, I mean, even though we can all practice it, we can all do it in our OPDs. So, it should be a very useful thing what, Mihir, you are going to give us.
So good afternoon, everyone. I'm sincerely thankful to Dr. Vikas Agarwal and team from Cipla, Orient, SNORECON. I'll be very quick in my presentation about myofunctional therapy and various dental interventions for obstructive sleep apnea and sleep disordered breathing. So let us see these two X-rays over here. When you see these two X-rays, which patient is more susceptible to obstructive sleep apnea. I'm sure everybody will first see at the area on the left side, on the patient on the left side, where there is a severe enlargement of the tonsils and adenoids. And because of that severe enlargement of the tonsils and adenoids, he is more susceptible to OSA. But what I want you all to look is at the craniofacial morphology of the maxilla and the mandible in this patient. And when we overlap these two X-rays, you can see that in the first X-ray that I've shown you, there was a downward and backward growth of the face. That is, the vertical growth of the face is one of the major culprit for obstructive sleep apnea as well as the crooked teeth. So we have a common enemy, that's the vertical growth. Apart from the soft tissue, as Dr. Seemap sir said earlier, that it is important to evaluate the craniofacial structure, and that is extremely important in order to understand which patient may relapse in future, or there may be a recurrence in OSA in future even after doing the surgery. So the people who are suffering from OSA tend to have a downward and backward growth of the face, and people who have a forward growing face, they are usually less susceptible to OSA. And what determines that where there will be a forward growth of the face is the position of the tongue and the lip seal. So if there is a good lip seal and a good tongue position, there is a forward growth of the face. However, if there is a low tongue position and the lip seal is missing, during childhood, there will be a downward and the backward growth of the face. And this is very important because the increased gonial angle, position of the hyoid will be more towards the pharynx, and that is going to increase the susceptibility to obstructive sleep apnea. And we need to prevent, when we are talking about the prevention of obstructive sleep apnea, it is important for us to understand this growth aspect for them. And for that, we need to understand the position of the tongue. I encourage everyone, if you all can just do the tongue suction maneuver right now, and if you all can check like this, do a tongue click first, and then get the tongue in a suction position, and then try breathing from the mouth. You will not be able to breathe from the mouth. So the nature has given us two important barriers to mouth breathing. The first is the lip seal, and the other is the tongue suction position. And this tongue suction position keeps the whole tongue engaged to the soft palate, and it prevents the collapse. And this is how naturally we were supposed to grow. And if this tongue position is in a lower, it's not high on the palate, it's touching the teeth or it's touching the mandible, that is when it starts collapsing and there is no mechanical stability. When the tongue is on the palate, it provides the mechanical stability along with the suctioning effect onto the soft palate during sleeping. And that is what is important for us to understand. So now I'm going to go to about discuss about myofunctional therapy, where we discuss about breathing, getting the lip seal, and for good tongue position. And all these dental and myofunctional interventions are done to achieve nose breathing and an optimum good tongue posture. So before going to the solutions, let us see what are the various type of skeletal problems and the soft tissue problems that we need to see to make appropriate referrals to a dentist and a myofunctional therapist. So you all are all aware about the typical adenoid faces that we see regularly in children suffering from obstructive sleep apnea. They have an open mouth posture. They have a hypotonic upper lip. They are unable to close their lips. According to Guillemot, mouth breathing is one of the main reason which leads to increased enlarged adenoid tonsils as well as obstructive sleep apnea. So we need to correct these incompetent lips with the help of various dental interventions, which I'm going to discuss ahead. All these kids have a downward growth of the mandible. They have a receded and a weak jawline. They have a chubby-like appearance because of the hyperactivity of the buccinators and the mentalis muscle. So all these children need myofunctional therapy. So now we are going to see some dental signs. I encourage all of them to use just a pair of cheek retractors to see what are the various dental problems which help us to evaluate the craniofacial morphology problems in all the patients suffering from sleep apnea. And that will help us all to identify which patients will require dental interventions in further. So let us see what is normal. A healthy patient will have a good occlusion of the maxilla and the mandible, where the maxilla maxillary teeth will be 2 millimeter in front of the mandibular teeth. Now let us see the problems. So whenever there is an overbite issue, or it is also called as an increased overjet, the gap between the maxillary teeth is almost about 4 to 5 millimeter, and which denotes there may be a smaller mandible. A smaller mandible will have a posteriorly placed tongue, and the tongue will keep on falling into the airway. So these needs to be corrected. So you can see some kids also have a gap of almost 10 to 15 millimeters. So it's called as an increased overbite problem, which shows that there is a smaller mandible. The other problem commonly seen is an smaller maxilla problem, which we call as an underbite, and often it is called as a crossbite, where the chin gets more prominent at the age of 7-8 years of age. And they have a smaller maxilla. Smaller maxilla means the base of the nose is smaller, the breathing passage will be smaller. They often will be seen like a crossbite. It could be an anterior crossbite, where the anterior teeth are behind, and there could be a posterior crossbite. So all of these will require simple dental corrections in order to improve the airway. The other problem that we commonly seen is an open bite, where because of the forward positioning of the tongue, in order to open up the airway, the child, there is an open bite development because the teeth don't occlude because of the tongue. And these are very common orthodontic problems that we see in every single day of our practice. And so now moving on to the solution, the first step we follow, and we encourage all our dental colleagues to follow, is to get the complete ENT evaluation as well as non-surgical or surgical management to be done from our ENT doctors. And in the myofunctional therapy aspect, from the dental perspective, we majorly have three major things: is the maxillary expansion, the mandibular advancement devices, the breathing retraining, which comes under myofunctional exercises itself, and the exercises in detail that I'm going to discuss. So first, I'm going to talk about a little bit of the skeletal interventions. What can we do to increase the size of the maxilla or the mandible? So when there is a smaller mandible, we usually enlarge the mandible, advance the mandible with the help of very simple plates, which you can see here the child is wearing. And this is very effective if it is done before the age of 15 years of age. You see a buck teeth every single day, and these buck teeth children have a smaller mandible. And when you open up the mandible and you get it advanced, the results that you see are very beautiful. These are to the upper and lower plate, as you can see, and these bite blocks helps to advance the mandible. And these bite blocks are only supposed to be worn only for 6 to 8 months, and we can easily advance the mandible up to 1 centimeter or 10 millimeter, and you can open up the airway. In this case, we had first, the patient visited an ENT doctor. They had given a non-surgical treatment for the child. They were prescribed medication. This was followed by the mandibular advancement device, and we were able to, over a period of 1 year, the mandible position improved. At the same time, the airway improved as well. We were also able to change the position of the hyoid because of the tongue exercises that I'm going to discuss ahead. So now moving to the other problem, which when there is a smaller maxilla. So whenever there is a smaller maxilla, which can be seen like a crossbite, it could be an anterior crossbite or a posterior crossbite. However, in some cases, you may not see a crossbite, but there will be a crowding into the teeth. And even these cases will require expansion. We measure the transpalatal width. What is the transpalatal width? The transpalatal width is the width from the from the palatogingival groove of the first permanent molar from the right to the left, and any reduction in the width below 35 mm requires some amount of expansion treatment. So when we do these expansion, it is a very simple procedure. We take dental impressions. You all must have already, if you have visited a dentist, you may have undergone impression procedures. This is followed by a fabrication of cast, and the appliance is made, and this is how we fit the appliance. It is a very easy non-surgical treatment, and here the expansion device I'm going to fit inside the patient's mouth. You can see there is some crowding in the anterior crossbite region, and this is how we fix it with the cement. And this procedure before the age of 14 is absolutely non-surgical. Not a single speck of blood is seen, and this is the beauty if we start it early. And this activation that is shown is with a simple key which the parents does it. It is so easy that the parent can do it over a span of 15 days, and we are able to achieve an expansion of almost 8 millimeter in just a span of 2 to 3 weeks. In this case, we are able to achieve 8 millimeter of expansion in just day 16 days. And if we are doing this procedure before the age of 15, it is non-surgical. The procedure does not require any bleeding, and however, after the skin chondrosis fused, we may require some surgery. And how does this palatal expansion improve the OSA? It expands the nasal cavity, it expands the nasal floor, decreases the resistance to airflow. Also, it expands the oral cavity, so the tongue has a good can raise and it go into the palate and reduce. It doesn't fall back into the throat. It also reduces the pharyngeal collapsibility. I'm not going to go in detail how exactly it does that. In some papers, it is also shown to reduce the tonsil size of tonsil and adenoids, but it is not the first line of treatment. It is always to be done after. We don't recommend it for any of our children as a first line of treatment. The first line of treatment is decided by the ENT doctors. And now I'm going to talk in brief about myofunctional therapy. A lot of people believe that myofunctional therapy is just about wiggling of tongue, and you see some videos on YouTube and you can correct, you can improve your tongue position and it will help in sleep apnea, but it is absolutely not myofunction. It is not that. So the sleep is an 8-hour marathon for the mighty genioglossus, and each and every word over here has some meaning, which I'm going to discuss now. So what is a marathon? Marathon is a 10, 20, 40 kilometer race, which a normal genioglossus can work very well for the span of 8 to 10 hours during the sleep. However, people suffering from OSA, their tongue keeps on sprinting. What do I mean by that? Is people suffering from OSA have a more of a white muscle fiber or a type 2B muscle fiber. And these type 2B muscle fiber are different from people who have a normal tongue or non-OSC people. They have more of a red muscle fiber and they are able to run a marathon. And these white muscle fibers are more prone to fatigue, and they have a lower concentration of myoglobin, lower concentration of mitochondria. However, a normal person will have a more of a type 1 fiber, and they will have a higher concentration of mitochondria and myoglobin. And this genioglossus structure is very important to understand. In order to change this structure, we use this myofunctional therapy, and there are specific set of isometric and isotonic exercises which are of low intensity, high volume, and this helps to change the shape. This helps to change the phenotype of the fibers, and that helps to improve the posture of the tongue, and which will help gradually in the sleep apnea. So this is now being used by Insight OSA people, which is a company which have gone some tongue stimulation device which works to change the fiber from type 2B to type 1. And the same can be done with various tongue-based exercises that I'm going to discuss. We teach all these children about various postural exercises, various tongue exercise, various lip exercises, and correction of good body posture is very important in order to improve the nose breathing and to get the tongue on the palate, because mouth breathing children with a forward head posture have a progressively worsening of the spirometry values. And there are lots of tongue isometric and isotonic exercises which help to improve the tonicity of the tongue. Your kids are performing exercises to strengthen their genioglossus muscle. These are exercises which help us to get the tongue on the palate gradually over a span of 4 to 6 months. And these kids are learning how to get the tongue on the palate. And getting this tongue on the palate is an extremely important maneuver along with lip position in order to achieve the stability of his oropharyngeal region. We teach children to eat a lot of hard fruits and vegetables. Here you can see how the child is learning to bite on a fruit, a hard fruit, in order to improve the tonicity of the muscles. There are a lot of other exercises these kids are performing in order to strengthen their muscles and improve the tone of these muscles. There are some other props that we also use, like myo brace, a lip trainer, a myo tape, which help us to improve this tone and to get the stability of these oropharyngeal muscles. And we get these kids a lot. We do a lot of follow-ups via WhatsApp, we do it they send us exercises, and that's how we are able to achieve this correction of the whole problem of sleep disordered breathing along with the ENT colleagues. And so this is in the summary just the protocol I'm showing you and what are the various mechanisms we can correct it. And thank you, and going a little bit beyond time. Sorry. Thank you so much, sir.
Thank you, Dr. Mihir.
Thank you.
For a okay, for a very lucid and a comprehensive talk.
Thank you so much.
And only thing is, I wanted to ask you that you mentioned about adenoids and tonsils and all, because what we have been taught is that with the adenoids and all being large in size, there is a overriding of the upper incisors and the facial features are changing. So whether it's a consequence of it or it's a sequelae or a prequelae.
It's a chicken and egg story. Nobody can say exactly. So we can keep on discussing. But as sir, we just try to get the solutions right. So we send it to ENT doctors and they do their management. And most of these patients, sir, we never tell them that we are going to treat sleep disordered breathing or OSA. We tell them that we are working on these craniofacial structures in order to improve their occlusion, and a positive side effect to some extent will help that it will help in their breathing. So we always tell them that the first line of treatment will be by the ENT doctors, and we don't tell them that we do this treatment in order to cure the tonsils and adenoids. We never tell them that way.
Okay, because what happens with the overriding incisors, they land up with the dentist first.
Correct.
And many a times we see them coming to us directly with the braces on.
Correct.
So
that's
why
what we are now trying to change. We are trying to increase the awareness by getting more people on board. And even before we put any braces, we send them for an evaluation. The moment we take a lateral ceph, if we see an enlarged adenoids, we send them for a medical referral.
Chalo, thank you. Wonderful presentation. And we'll break for lunch. Okay, sorry. 1 minute.
I would request sir to please give a memento to our speaker. My talk, I'll keep it after the lunch because we are quite late. Sir, please. Sir.
Thank you.
So, dear doctors, we'll break for lunch. We'll assemble here at 2:30 sharp. Thank you.
Hello. Can we have everybody inside, please? May we invite Dr. Sanjay Helale and Dr. Vikram Khanna to chair the next session. And the first talk is by none other than Professor Claudio Vicini, who is considered the father of sleep surgery in our world. And we have also learned almost everything in sleep and robotics from Dr. Vicini. And Dr. Vicini, I have requested him to talk on his lifetime experience and the way he has seen this field evolve and what he perceives as the future of obstructive sleep apnea surgery. So, Dr. Sanjay and Dr. Vikram, Professor Claudio Vicini is ready.
Yes, I'm ready. Can you hear me?
Hi, Professor. Very nice to see you, sir.
Can you hear me?
Yes, I can hear you well. Can you increase the sound a little bit?
I try to do on my side.
Yeah, no, it's absolutely fine, Professor, now.
Better now?
Yes.
Great.
Yes, Professor. We are all eager to listen to your words of wisdom based on your vast experience. And it's our privilege to be in the audience today. So it is my humble request to please start sharing your slides.
I don't have slides because Vika didn't require to me. I try to explain just in a very direct way my experience, my long so far experience in sleep surgery, if you agree.
Yes, sir. We are all
Okay,
eager
okay,
to
sir.
listen to your words of wisdom. Please proceed.
Thank you. First of all, thanks to Vikas, to all the organizers, to all my good friends in India. Sleep surgery is becoming one of the mainstay of our training, of our experience. ENT originally was not trained for doing sleep surgery, but now sleep surgery is probably one of the most common activity in our daily life. It wasn't the same when I started my activity. I started my activity 43 years ago. That's a long time. I would like to discuss 3 points that, in my opinion, are crucial for build up a sound experience and a sound activity in sleep surgery. Training, research, and last but not least, publishing and sharing what we did and we are doing, what we will to do. Training is crucial. When I started, I was very lucky and I was very happy because when I was training in the University of Pisa, one of my teachers was Professor Pompeiano. I don't know if you remember Professor Pompeiano, Moruzzi, and Professor Magoon. They discovered the activating reticular system. So at that time, we could breathe the taste of sleep since the beginning of my training. After that, I was committed to Professor Lugaresi to take care for the surgery of the patient, and it was great. But it wasn't enough, and probably it's not enough for all of us, or all of you. If you don't find knowledge in your country, you have to move. All of us moved too much. I moved in many countries for a long time, for a very long time. I went to US, I went to France, I went to Netherlands, I went to Far East. You have to find the best where is in every place in the world. And my first teacher, no question about that, was Dr. Kamami in France, where I learned LEOP. It's interesting because all of us included one special surgery in his armamentarium and stopped to do. Experience means that you learn, but if you are critical to the technique that you introduce, you must be able to stop it. We did many times. And the history of my sleep surgery and the history of sleep surgery all over in the world is that we start with a technique and we stop this technique in order to include a new one. I did with LEOP, but LEOP was my first technique that I did. After that, I moved to US in Stanford. Here, I met Bob Troll first, Casey Lee, Nelson Powell, and Bob Riley. They were a great teacher for me, and I learned from them UP3 and even more hyoid. Hyoid surgery was a great tool for me. We did about 1,000 cases of hyoid. But we don't do any more hyoid now because we have different technique that took the place of the hyoid. After that was the time to introduce Bimax. I learned Bimax in US, but I was trained in Italy. I was trained in Italy by Professor Ugo Baciliero in Vicenza, one of the most outstanding maxillofacial surgeon, and I could do a significant amount of Bimax. But after that, I learned that the main activity for ENT surgeon is to manage soft tissues. And for that reason, I tried to develop new techniques in the palate area and in the tongue base area. For that reason, I devised first TORS, after the teaching of Professor Weinstein in US, in Philadelphia, and I devised the technique of BRP, deeply inspired by Professor Lee in Far East and Tucker Woodson in US. So training and learn is important, but I am learning, attending this meeting today, and probably sharing the data all of us, we increase every day. So the First point is start in the best way. And if you have a problem, talking with all over the patient, the subjects all over in the world, you will have something to share in order to overcome your problem, because your problem is a problem of your colleagues in India, as in China, as in US. So sharing problem is the best way for overcoming the problem. Point number two is research. Every single country have a different, I can say, managing of sleep. In Italy, when I started my activity, sleep was introduced by neurologists and pulmonologists. No single ENT was able to take care of patients with sleep disorders. Now, many ENT surgeons in Italy may perform PSG and any other types of examination that are needed for approaching the patients. At that time, we have to face every day with neurologists and pulmonologists, and we have to work really strictly together. But our job is to develop new surgical technique to apply surgery and to help our patients by surgery. In surgery, includes also special techniques that we are able to manage, that is DISE, sleep endoscopy. So for me, the key point for a sleep surgeon now is to manage any really up-to-date surgical technique and to manage at the best DISE, sleep endoscopy. You can do nothing without sleep endoscopy. So in my opinion now, sleep endoscopy entered into the basic armamentarium of a sleep surgeon. And the key point is to be able to offer to your patients any single surgery that is required for be addressed. And if you have a sufficient expertise, you can build up you can change the original techniques, or you may be able to introduce a completely new technique in order to fit to the requirement of the single patient. That's very important. Point number three, it's the scientific method for approaching sleep surgery. To run randomized controlled trials in surgery, as you know very well, is quite difficult. It's quite very difficult. What we did, and all of us did, and we must do better and more commonly. What we needed to demonstrate that surgery is worth to be offered to our patients. And in order to do that, you have to publish and you have to share your expertise. Publishing paper, writing books, organizing meeting like that. Vikas is a master for that. And to organize fellowships. Fellowships in the area of the sleep surgery is crucial. Is one of the most important experience, because learn sleep surgery means to stay behind a surgeon to discuss with him in the OR. That's the key of the training. And what you have to do is to demonstrate in the era of the evidence-based medicine that surgery is a good tool for helping the patients. One of the questions that was introduced by Vikas is what will be the future? It's difficult to ask to an old surgeon what will be the future, but anyway, I try to do my personal opinion. After maybe more than 30 years of experience and 42 in general ENT, I am convinced that the future of sleep surgery with the multimodal approach to the patient. You can't do everything by simple surgery, because as you know, sleep apnea is a chronic disease with an evolution along the time. Every single patient is different from the other. Now we are aware that beside anatomy, we have some functional, not anatomical traits in the endotypes of our patient in a different combination. So what we have to do is to individualize the single profile of endotyping and phenotyping, and to build up not a single surgery, but a special program for each subject. Every single subject deserves a special combination of treatment. And treatments may include surgery, of course, may include myofunctional, may include a support by positional, med, and so on. So and last but not least, of course, not now, but very soon, special drugs. So what I expect in the future from the surgical point of view, from the therapeutical point of view, is to be able to know how to combine the best options, multiple options for any single case. I would like to discuss the problem of the sleep registration. You know that we are getting, or we are inside the era of the artificial intelligence. Artificial intelligence is changing very deeply our way of studying patients suffering from sleep apnea. But it's another issue. I don't think that a surgeon has the sufficient expertise for discussing this topic. So again, if you like to build up a sound experience, move all over in the world. Everywhere you can find something of interesting for you for increase your expertise. Point number two, try to develop the best surgery in your setting. I travel all over in the world. I could see that the setting in different countries is different. Robot is not available all over. Coblation is much more easy. Hypoglossal nerve stimulation is not available all over. What the key? Find the best in your setting, in your country, in your hospital, in your practice. That's the key for optimize your activity and for be able to do the best for your patients. That's the key point. But travel. And accept fellows from all over, because I could learn a lot of new issues and very interesting stimulation from the fellows. Point number two, try to increase the efficacy and effectiveness of your surgery. Surgery is a never-ending story. Any single typical surgery is not the same in your hands, in my hands, and in hands of different surgeons. Everybody has his own interpretation. It is nice because you can improve your expertise according to what you did in your past. And again, last but not least, share. If you have something new, don't keep in your bag, but expand the experience of others. Extend the knowledge, the basic knowledge. That is summarizing my philosophy. And in the future, in my opinion, the real future of sleep surgery is a better understanding of the pathophysiological mechanism, what now we are labeling as endotyping and phenotyping. Now they are available also in our offices if you are able to apply, and be able to combine different solutions for any single patients. I don't go ahead because it's boring attending an old surgeon just talking without any slides, but I try to summarize in a short time what was my experience, and it was my feeling for the future. But if you have additional question, of course, I am available for all of you.
Thank you, sir, for your pearls of wisdom that you have shared from your vast experience. And the two important take-home messages are that you can learn any surgery, especially sleep surgery, only by doing a dedicated fellowship, by standing behind the surgeon and asking relevant questions. And secondly is that we, in order to, master this art, understanding of the pathophysiology. So, every patient is unique and we need to customize and tailor make the treatment for that particular patient. So these are the two important take-home messages that we have, taken very seriously from your talk. And we are extremely grateful that you have guided us, you have enlightened us with your vast experience and wisdom, and we are forever grateful. Thank you, sir.
Sir, good evening.
All of you.
I'm Dr. Sanjay Hilale. I have been to your center in 2014. So those days you used to do robotic based tongue surgery and you used to do a tracheostomy. So you convinced me safety is a paramount.
Yeah.
But with the yeah. So with your new concepts of phenotypes and endotypes, can you just enlighten on that? What modification you did recently? And how do we proceed with the base tongue problems involving causing OSA?
You mean the development of our technique of tongue-based surgery by robot?
Yeah, not only robot, in general.
Okay, in general, now we are much more open to different solutions for tongue-based surgery. At that time, we were more enthusiastic about the wide application of robotic surgery in a tongue base. We are still enthusiastic, but in a special type of tongue base. What we need is to have a mainly lymphatic tongue base, especially if there's a very huge lymphatic mass in the tongue base, and it's better if the lymphatic mass in the inferior aspect of the tongue base. What is not, what doesn't fit for sleep surgery, for tongue-based surgery by robot now, in my opinion, is a very high and muscular tongue base. So a very high and completely muscular tongue base is not the best candidate for TORS. But if you have this kind of patient, we have to offer them different kind of solution. For that reason, I'm proud to tell you that we introduced, and we hope to have a complete certification by our government, the hypoglossal nerve stimulation. In many countries, hypoglossal nerve stimulation is a struggle against the system, against the healthcare system. Why? Because it's very expensive. And so they try to keep low the ratio of this procedure. In Italy, I did last weeks the procedure number 7. In Italy, we did just 8 cases, 7 in Forlì and 1 more in the north of Italy. We are still struggling. I'm quite sure the hypoglossal nerve stimulation will be one very interesting tool in the future, not for many patients, but for very targeted patients. Again, if you have a patient with a tongue base included in a severe collapse of the upper airways, don't forget BIMAX. We did no more than 55 BIMAX, but we were very satisfied. I did by myself, but now I'm sending patient to the maxillofacial surgeons, and to some extent, these patients are very interesting to treat. Again, in the tongue base, if in a special situation, a positional may help. And to some extent, the combination, including myofunctional, may help as well. So what I tell you is robotic surgery is a great tool, but acquiring more and more experience, we became more and more selective in the selection of patients. And now, again, we are reducing the number to a minimal extent, the number of tracheostomy that were 100% at the beginning for safety. Safety is crucial, but we have to balance safety and compliance of the patient. Now we are happy because we did no more than 20% of the tracheostomy in the group of tongue-based surgery by robot, and we didn't register any significant problem to this respect.
Thank you so much, sir.
So thank you very much, Professor. Thank you for being with us this afternoon. And your words, it's no longer, I really cannot say, you're saying an old surgeon talking without slides. Your each word is worth more than 1,000 slides for us. Because every sleep surgeon, every sleep surgeon in the world, as of our generation, has learned from you. So we'll keep on asking you to deliver your thoughts for us. And please accept our greetings from the bottom of our heart. Thank you.
I'm proud. It's my honor. Thanks for inviting me.
Thank you. And I see, yeah, there's a round of applause for Professor. And here's another great friend of ours, Dr. Peter Baptista. So please invite Dr. Peter. He'll be talking not elderly.
So from one stalwart to another, and now we have Dr. Peter Baptista, who will be sharing his experience and wisdom on treating OSA in the elderly. Over to you, Dr. Peter.
Thank you. I'm trying to share my slides, and I don't know if you could see me now. You could see my slides. Can
Yes,
you
sir.
see them?
We can
Okay,
see your
cool. Thank
slides,
you.
and we can
Well,
hear you also very clearly.
well, I really feel very humble and very excited to be speaking once again with India, and thank you so much for the kind invitation. As I said, I feel very proud and honored. And after the speech of Dr. Vicini, well, it's going to be kind of difficult to carry on, but I would just like to bring up something about the challenge of obstructive sleep apnea treatment in the elderly. So we know that we're in a world where life expectancy of the population is growing. For both genders, it's 73.4 years. For females, it's 76 years. For males, it's approximately 71 years. Actually, these are data that I just took out today, and we could see here that the country with most life expectancy is Hong Kong. It's practically about 86 years of age. India is in the number 126, but the life expectancy is practically of 70 years. So I mean, we're definitely in a growing group, especially, and I include myself. Okay, I'm not over 65, but I'm close. And definitely global population age 65 is growing faster than all age groups. And that's a problem because there are not enough young people. It says that by the year 2050, 1 in 6 people will be over 65. So we're all aging. And one of the most important aspects is we see also that our leaders, okay, and I try to put this up, all our major leaders are over 65. So that is something very important that you have to have in mind, and definitely think about when we are seeing patients with sleep apnea. The younger generation is going to see more and more patients of these ages. We know that obstructive sleep apnea has a very important impact in quality of life, on cardiovascular problems and metabolic problems, and neurological problems, of course, in mortality and economy. When we think about an elderly, we know that obstructive sleep apnea does increase with age. Most of the time, unfortunately, it's not diagnosed, and those parameters that I spoke about in the previous slide get worse with time. And unfortunately, there is not enough evidence that we know of the improvement that will occur with the treatments. Therefore, that is why I wanted to bring up about what's the importance of treating in the elderly. When we speak about the elderly patient, there are definitely changes in anatomy. These changes in anatomy are going to occur at the level of the pharynx, where the fatty deposits there is a reduction of the fatty deposits in the wall. There's a change in the morphology of the neck. This is a person, okay, at a younger age. This is a person about 50 years old. And as they grow older, there is definitely a big change in how the neck looks, how it is. And on top of that, we have a loss of teeth. So there are also physiological changes. There's a dysfunction of the muscles of the pharynx. We don't swallow the same, we don't move the same. There are differences also in the dilatory reflexes of the pharynx. There is greater instability of breathing, and also there is a change in the sleep architecture during the nights. This is something extremely important, but and on top of that, if we add there are other frequent comorbidities that occur, cardiovascular, neurocognitive, and also metabolic changes. So definitely when we speak about this, treatment for obstructive sleep apnea will depend, of course, on the severity of the disease, of the patient's symptoms, and also the presence of comorbidities. I would like to analyze each and one of the different treatments that occur. Of course, lifestyle changes. This is something important. We do need to do cardiovascular disease exercise to improve. That is something that's a must that we all know. In any type of disease, weight loss is something extremely important. But what occurs as people age? They start receiving different medications. So definitely they become polypharmacy. Okay, there are so many medications that they're taking at the same time that will produce and probably will worsen the obstructive sleep apnea. Also, of course, you need to avoid certain stimulants, caffeine, alcohol. Of course, that is extremely important. And after this, I would like to speak, of course, about the use of CPAP in elderly, mandibular advancement devices, positional therapy, and also, of course, of surgery. Okay, so let's start with CPAP. One of the most important things, and this is a review, of course, of what I found in the literature, is that adherence to CPAP in people who are elderly is usually there's limited information. We don't know exactly. There are only a few studies that actually show that the adherence is practically similar to those and to those that are a younger group. There are people, okay, definitely that there are neurocognitive diseases like Alzheimer's disease that need, of course, their treatment, but also need the CPAP. And we've seen that that the adherence is pretty good. And of course, there is a need many times to educate the patient, to produce modifications, to change the devices and different things like that. And probably the new technologies of remote titration could improve knowing if the patient is using adequately. This is one of the few studies that are published out there, which show that the adherence to the CPAP falls, of course, with age. Of course, people go dying off. There were approximately 70% of patients that had good adherence, but approximately 30.4% did use it for less than 4 hours a day. One of the reasons, okay, there are many reasons that we all know about the reasons, of course, that probably it's the leak of the mask, this and that. But definitely when we think about elderly people, most of the time the reasons are quite different. Probably there's an inadequate symptom resolution. People at a certain age, they don't feel, okay, that it's solving their problem because they're tired the whole day. The other problem is nocturia, okay? Having to go to the restroom many times during the night, they take off the mask, especially if males with benign prostate disorders. Also, cigarette smoking is one thing because people do not stop smoking even if they're elderly. The lack of participation, of course, in support groups. Another thing is insomnia, and of course, just having to put on the mask, okay, many times because their upper extremities is weak, and of course, they might have a problem with central sleep apnea. What about functional impairment, ambulation, hearing loss, psychiatric disease? Well, these are other problems that do exist, but in this study, definitely it showed that probably it wasn't so important as the other problems. would like to show you this photo. This photo is of my mother-in-law, okay? So my mother-in-law at this moment, she's 90 years old, okay? She's been diagnosed since 20 years ago of obstructive sleep apnea. Of course, I just wanted to show you where the CPAP is. If you all think, that's great. I mean, it's right on the table and she sleeps with the CPAP on the table. She does not use it at all. Or if we tell her to use it, she takes it off. So definitely, there are studies that demonstrate that the CPAP, okay, does have an improvement in cerebrovascular disease. I mean, it does reduce the possibilities of stroke, and it does give better chances of avoiding a stroke in patients. So definitely, there is it's a positive effect. When we say about cognition, definitely CPAP allows for the deterioration of cognitive function to be less. And there are randomized clinical trials, okay, that are required to actually show this aspect. This is my mother-in-law once again, and definitely one of the most important things here is that we're seeing how she is sleeping during the day. So definitely, okay, if she doesn't use the CPAP, she's going to be sleeping the whole day, okay? And this is something that occurs constantly. Of course, this is something with age, and definitely the use of CPAP is going to improve the quality of life and outcomes. So people are at a certain age, definitely. There are many things to think about when we are suggesting the use of CPAP. The magnitude of treatment and economic benefits are probably not the same as those shown, okay, at middle age. There are needs for strategies to improve adherence in the elderly and careful identification of those who are going to respond adequately is absolutely necessary, those phenotypes that are adequate. Okay, so what about mandibular advancement device? What's out there? Well, definitely there are results that show no difference between patients, elderly patients and younger patients. However, there's something that we should have in mind is that most of the time, the denture of patients at a certain age is precarious. Most patients don't even have teeth. Therefore, it's probably impossible for them to use mandibular advancement devices. What about positional therapy? Well, definitely positional therapy is probably a possibility with those patients who actually snore or have sleep apnea when they're on their backs. And there's no reason to think that otherwise that not using positional therapy or using positional therapy is going to be different to other age groups. So definitely, this is something we have to have in mind. And of course, the only problem is that many patients have body ache at a certain age. So definitely, it's not so easy to tell them how to sleep. What about obstructive sleep apnea surgery? Well, there's only one study out there that has shown, it's from Robson Capasso and his group in Stanford, that have shown where they analyzed patients that were less than 65 with patients that were over 65. Unfortunately, these elderly patients did have high blood pressure. They had scores for the anesthesiologists that were higher. They had higher rates of wound complications. However, when they looked specifically, okay, at rates of complications at a nasal surgery, palate surgery, tongue surgery, or multi-level surgery, they did not really find any significant differences between the two groups. So this is something important. Okay, what about hypoglossal nerve stimulation? Well, there are studies outside there that show which are the predictors of success with hypoglossal nerve stimulation. One is to be a woman. The other one is a BMI of less than let's say 32. And the other one that's important is that increasing age seems to be a factor that allows a better success. And when did they see that? Well, definitely they saw that, especially when they divided patients in two groups. One group was less than 65, the other group was over 65, and they actually saw that the AHI improved in a significant way compared to the others. The Epworth Sleepiness Scale also improved, and the usage, which is probably the most important aspect, improved. Okay, so definitely, let's say that doing hypoglossal nerve stimulation in a patient that's over 65 is probably of benefit. However, as we know, it's definitely expensive, and we know also that it might it's not only expensive. Of course, you could get a private patient to pay for it because usually people might have enough money to buy it, especially in certain countries where it's not covered. However, there's one important aspect is that we have to have in mind that many of the patients, as I mentioned before, elderly patients do have problems to fall asleep, or they wake up during the night, and therefore this becomes a motive of anxiety and anger. So we have to choose very well probably which are the best patients in this case. What about bariatric surgery? Well, there are studies. There's only one study outside there that actually says that it's safe. There are similar outcomes and a reduction of complications. And the complications are pretty much as younger groups. So not much has been said outside there about it. When we think, of course, of a patient of elderly patients not only have a flaccidity or they have flaccid tissue, and there's a change of fat around the whole area, but also might have bone problems, as we could see here. Their muscle tone will be different. Therefore, these are patients that we really have to think about. And also, I would say, the same way that we consider not doing a partial laryngectomy to a patient that is older than 65, okay, well, probably we should consider also surgery, especially changing or modifying the way they swallow, because these patients might have slight alterations, slight disturbances that make things worse, and therefore we have to have this in mind. Even though we might think, okay, we are still young, and I include myself. I mean, I don't think I'm young. I think I'm in good shape. However, we know we don't run, we don't walk, we don't move the same way as we did, okay, 20 years ago. So this is an important aspect that we have to have in mind. So the take-home message here is that I would say, first of all, there is a need to analyze, there is a need to investigate adequately what is the right treatment for each patient. Each patient should be customized, but also there is good evidence that supports the use of CPAP. However, this must be individualized. Also, age should not be considered a barrier for assessment and treatment of obstructive sleep apnea. Surgery might be an option, but take care, be careful, and there's a need for very important studies to be able to know or have more information. Just to invite you next year, there's the CBICS meeting. I'm sure Rodolfo put up his slides about this, and definitely I'm happy to answer any questions. Thank you so much, and I appreciate it.
Thank you so much for such a marvelous piece of information which you gave. There's one question. Is there any correlation of severity of obstructive sleep apnea with dementia and Alzheimer's disease in elderly?
Yes, there is. There
Alzheimer.
is. Well, there. I mean, there's no paper outside there that actually says that according to the severity, but there is a complete correlation. Okay, but each person is going to be different. Okay, so we might have patients that might have moderate obstructive sleep apnea, but with time, okay, or might develop, but it's according to other comorbidities, other factors that they might have, and probably genetic factors that will produce the dementia.
Thank you. Thank you so much.
Any questions from the audience? So thank you very much, Dr. Peter Baptista, for sharing your experience and wisdom with us. Now we have Dr. Vikas Agrawal.
Thank you.
Yeah, Dr. Vikas would like to say a few words.
Sure.
So, thank you, Dr. Peter. It was, I mean, a very different presentation. I had never heard this kind of a talk before, and we never really thought that with advancing age, we'll have to think so much in different about the same problem. So I would request you, if time permits, you be with us, because there are one or two more talks, and then Dr. Rahul is going to present some case scenarios, and will
Sure.
require your expertise on that.
Okay.
Dr. Kalpesh, our anesthetist, is on the way. Till that time, I'll take my lecture.
So till Dr. Kalpesh Shah comes and gives his talk on the anesthesia part, we have Dr. Vikas Agrawal speaking on base tongue and epiglottic surgery in patients with OSA. Dr. Vikas Agrawal does not need any introduction, so I will take the liberty of inviting him to deliver his talk.
Hello. Can I have my slide, please? लगा हुआ है ना? Yeah. So a very good afternoon to all of you. And hypopharynx is the most important cause of failure of sleep apnea therapy for the last 35 years, because many times the soft palate can be opened by the CPAP, but the tongue base is very difficult to lift. And we have low tongue base, we have high tongue base. So this is an example of a low tongue base, which is also pressing on the epiglottis. And if you can see, CPAP will not be able to lift this epiglottis. So definitely it is important to reduce this tongue base. You can see this is a both lymphatic as well as a muscular tongue base pressing onto the epiglottis. Now, this is my own failure. This patient, I had performed a UPPP in 2007, which miserably failed. And when in around 2010-11, I did his sleep endoscopy, we realized that it was a large tongue base that we had missed to operate at that point of time. So obviously, when we talk of tongue base, it is the tongue base. You cannot operate on the anterior 2/3 of the tongue. So this is the picture, because in the tongue base, most of the important structures are away from the midline. So this is our own dissection of the cadaver tongue. You can see the lingual artery going out of the tongue, and it's almost 1.5 centimeter away from the midline. And that gives us opportunity to reduce the volume of the tongue base to a great extent. And you can always see where you are exactly, and you can measure the position of the lingual artery with a color Doppler before the procedure. To perform the surgery, you have to pull out the tongue with a stitch, and you have to use a mouth gag, which is one size smaller. You have to bend the coblation wand. You can use coblation, you can use robot. The coblation wand is much more commonly used, so because of the cost factor, and you can bend it by 35 to 40 degrees, and layer by layer, you can reduce the volume of the tongue base so that you can get quite a bit of volume reduction. What is important is that the lymphoid tissue of the tongue base has to be reduced in layer, and then you will not get any big vessel inside the lymphoid tissues because it is submucosal. And the area that you have to reach is the median glossoepiglottic ligament. So you start from foramen cecum and go right till the median glossoepiglottic ligament. And in the lateral part, you have to go right till the lateral glossoepiglottic ligament. Now see, the area which seemed so near is actually quite far, very, very deep. So it is that deep inside. And if you have a bleeding from that area, it's not really very, very easy to tackle. So you have to have your learning curve. This is a muscular tongue base, which we are reducing with the help of coblation itself. So you have to reduce it layer by layer, and you have to have the right equipments to reach that area with great vision as well as with the right instruments. So on both the sides, layer by layer, we have removed around 4 to 5 millimeter or 6 millimeters of the muscular tongue base and perform a glossopeglottopexy. Now this is a completely muscular tongue base with retrognathia. The patient was the right candidate for Bimax, but he was not ready for that. So this is an surgery in which you take out a lot of bulk of tongue tissue after performing tracheostomy. This is a purely muscular tongue base, and you go right inside the muscular tongue base, remove a large volume of the muscular tongue so that you can actually compare it to whatever you can remove in bimaxil or maxillomandibular advancement. So, and then we fill it with the tissue glue for faster healing. Robotic surgery I learned from Professor Claudio Vicini in 2012, and for many years we are performing a lot of robotic surgery. However, the cost inhibits the use of robot in every patient, and therefore coblation takes the upper stage now in our country also. However, the amount of tissue that you can remove with the robot is quite a bit, and you get a very, very clear vision and 3D vision, and you have both the hands to work. So robot is a great tool when it comes to resection of the muscular tongue base, and in addition to the lymphatic tongue base. And then you can measure how much of tongue base you have removed. Like from 2.56 to start with, we have gone up to 1.17. So it's almost 1.3 centimeter of the volume reduction which has taken place in this particular case. So that is how you can predictably remove a large amount of tissues. Obviously, after a large tongue-based surgery, you keep in the patient in the ICU for 24 hours so that the possibility of a primary or secondary bleeding is taken care of. And most of the times, lingual vessels do not come, but muscular bleeders can be troublesome. And this case, which we had around 5 years back, came with a post-op bleeding from the right tonsil fossa on the right side. But once that was taken care of, accidentally the tongue base area was injured, and then this kind of bleeding was encountered. So one must remember that anybody can have a troublesome bleeding from the tongue base, and here you can see this is absolutely in the midline above the epiglottis. So this is a muscular bleeder in midline, which is the profunda lingual branch of the lingual artery. And the bleeding was unable to be controlled with all the means. So if you hit a large artery and the tube is not in place, then you can have a very, very difficult time. And therefore, anybody who's embarking on tongue base must remember the possibilities. So finally, in this case, we had to, because the tube was in place, so we packed the patient, we did a tracheostomy, and then finally we performed a embolization. So for epiglottic surgery, we used to do a lot of epiglotectomies before, but gradually with time we have shifted to glossopeglottopexy, in which we only stiffen the median glossoepiglottic ligament. You can see the artery here. Can you see this artery here? So laterally you will have those arteries and you have to remain away from them. And the moment you perform epiglotectomy, you have to remain supra-hyoid epiglotectomy. That's what Professor Claudio Vicini actually taught us, to remain away from those arteries. But if we only remain in the midline and coagulate the median glossoepiglottic ligament, that itself does a great deal of good for the primary epiglottic collapse. So this is glossopeglottopexy, which is a minimum surgery, which gives maximum result. And this is a daycare surgery. Patient can go home by the evening itself. And similarly, in this case, as you can see here, you only coagulate the median glossoepiglottic ligament with coagulation, and that gives a very, very nice and fantastic result. So I can go on and on, but because of lack of time, I would say thank you. And I think Dr. Kalpesh is already here. He will talk about the safety of anesthesia. Dr. Vikram, will you invite Dr. Kalpesh? So thank you very much.
Thank you, Vikas, for your talk. And it is very rare, in such SNORECONs or any conference where a surgeon actually shows his worst case and how he could manage it by a modality other than his own surgery. So, Vikas, I really appreciate and applaud your sincerity and transparency. Now, a surgeon is incomplete without anesthetist. Any surgery is incomplete without anesthesia. Just like we all want to be safe surgeons, there are certain aspects of anesthesia where the anesthetist must make sure that optimal safety is maintained. And we have an expert anesthetist, Dr. Kalpesh Shah, with us. And I would request him to share his wisdom and experiences so as to make our surgery more safe from the anesthesia point of view. So we are getting the audiovisual ready and Dr. Kalpesh Shah is here.
Again? Yeah.
Yes. Dr. Kalpesh Shah, over to you.
Yeah. Good afternoon, everybody. First of all, I would like to thank organizers and specifically Dr. Vikas for giving me the opportunity to speak about the safety in anesthesia in OSA patients. Before I start my talk, I would like to emphasize and tell you about something about the safety in anesthesia. So I am working in a group practice that we are 20 anesthesiologists working together, and we are managing anesthesia as well as intensive care unit also. And my team's name is also Safe Anesthesia Solutions. So our entire focus of all our anesthesiologists is to how to provide the best safety to the patient. And me and Dr. Vikas are working together since many years. So OSA patients we have tackled to a large number. Why I am emphasizing about my team and my background is that there is a lot of role of a team in providing a safety to the patient. So these patients require attention right from the beginning of pre-operative, intraoperative, post-operative, everything. So one team can make this entire journey very safe. Now, let's move on to my topic. So my topic is anesthesia safety for OSA patients. I would break my talk in a couple of headings. One is a pre-operative preparations, intubation, maintenance of anesthesia, extubation, recovery, and discharge. These are the 5 points where, as a team, we as a team in the operation theater can look at various aspects of OSA and safety in anesthesia. So, as we know, however good we want to perform, and our preparation needs to be the best. So what preparation anesthesiologists can do is by doing a pre-operative anesthesia checkup is like kind of a gold standard. So if anything which is difficult given to the anesthesiologist will be able to plan if there will be a chance for him to see the patient pre-operatively. Though this habit is not there in every institute, but I would request every one of you, that you please emphasize and request your anesthetist to see the patient pre-operatively. Because what happens that everything in OSA is my preparation. However, if I am well prepared, I will be able to deliver a better results. If I suddenly go to the operation theater and I find 120 kg patient with a lot of comorbidities, and if I'm not prepared mentally, forget about the equipment wise, then also the result makes a difference. So preparation is the most important thing for the success in the safety of anesthesia. So please give a chance to give a pre-operative anesthesia checkup, and that will build a little rapport between the anesthetist and the patient relative also, so we can understand them better. We need to see them preoperatively because we need to optimize certain preoperative conditions, which are comorbid conditions, diabetes, hypertension, asthma, and other issues, along with the physician. So that communication is again very, very important. Special investigations are most of the time needed in patients of high BMI, specifically dopamine stress echo test. Now, this test has got a lot of value in the preoperative setup when the patient is high BMI, overweight patient, not walking much, not having a physical exercise, and we want to subject this patient to the supramajor surgery. And then this investigation, we have to decide collectively whether this investigation is indicated or not, and we have to advise accordingly. Pre-operatively, CPAP or BiPAP, we have to optimize the lung condition also. So for that, we need to decide how many days before that pre-operative CPAP or BiPAP is required to optimize the lung condition, and what would be the plan post-operatively, because all these patients are on the CPAP or BiPAP this thing. Now this stop bang theory, we know that then entire journals of anesthesiology is been filled with the risk assessment. What the anesthesiologists generally do is a anticipation of problem. What is the meaning of anesthesia for us as a practitioner is anticipation of problem in anesthesia, and anticipation is a kind of a scientific calculation for the risk. Our journals are filled with data that this category of patients who has more than 3 of these top questionnaires or bang theory, then the risk is 3 times higher than a normal patient, even in a non-OSA surgeries. So we are dealing with a perpetually high risk patient, perioperative complication patient. So when our target is a complicated, our target is high risk, then our preparation has to be little more than a normal patient, a normal individual. So now, I mean, once we are prepared with a plan, here there are no role about the other kind of anesthesia. So there is a straight away general anesthesia with endotracheal intubation and all. Now we all know that OSA patients having a not only difficult intubation, they are difficult to ventilate. Now difficulty in ventilation is the most catastrophic thing. Many a time our focus is to put a tube inside the mouth. But the tube is only a method to give oxygenation. The entire goal of the anesthesia induction is a maintenance of oxygenation with the maintenance of normal hemodynamics. So here ventilation plays a huge role, and this ventilation, assessment of this ventilation or possibility of difficult ventilation can be judged by discussing the drug-induced sleep endoscopy actively with the ENT surgeon. So me and Dr. Vikas, or wherever we work, we discuss this drug-induced sleep endoscopy. We watch this drug-induced sleep endoscopy a couple of times to understand which part of the airway is collapsing. How is the shape of the epiglottis, whether it is big, it is hanging, or it is a triangular shape, or if it is a large, or how is the base of the tongue, or how is the lateral collapse, or how is the palate is behaving, what are the problems in the nose. So all these things collectively discussing with you in an operation theater before going ahead with my plan makes the things very easy. And over a period of time, we have created a certain kind of protocol in our mind that this category of patient, which of course Vikas must have discussed in your conference, that upper airway, lower airway, tongue size and all. So here, what I am trying to emphasize, this is a dynamic airway assessment, which our books have also started recognizing. Maybe another next 5 years down the line, we will come up with some great discoveries via drug-induced sleep endoscopy in our non-OSA surgeries also, because we are very fascinated with this, and we do believe that this gives us a lot of insight for our planning. So when we have a difficulty in mask ventilation in otherwise general population, if it is a bearded patient, obese patient, old patient, edentulous or tooth having a problem, or a patient having a snoring, they all are difficult mask ventilation. And our OSA patient having a more than one criteria to fulfill and understand that we are going to deal with a difficult mask ventilation patient. Now, when we have a difficult mask ventilation, we have a simple algorithm. This algorithm is true for any kind of difficult intubation also. When we have an anticipated difficult ventilation, what we typically do, then we typically give a minimal dose of the induction of anesthesia drug, that in the form of IV is propofol or a sevoflurane as an inhalation anesthetic agent. We try to maintain the spontaneous ventilation so we don't lose our oxygenation of the patient. Patient is still breathing spontaneously. And then we try to attempt the positive pressure ventilation. Now, this looks very, I mean, for an anesthesiologist, for somebody, it looks very easy. Arey, kya hai, thoda drug de diya, and then we are trying to ventilate. No, but here the tricks all comes that if we are not able to ventilate this patient positively in a easy manner, then we really have to intervene with something. Otherwise, when we give more drug, we will be in a trouble that we are not able to ventilate, and now the saturation is falling. So we have a very clear-cut guidelines. If we are able to give a very good positive pressure ventilation easily, then we straight away go to the muscle relaxation or increase the dose of anesthesia drug, or else we straight away go to the something else. Now, what this something else is, the most important thing is either we increase our efforts to mask ventilation by holding with the two hand and somebody else is ventilating the patient. If that is not happening, then the next step will be either nasal airway or an oral airway, if that is permittable in that particular patient. But if that is also not permittable, then straight away comes the laryngeal mask airway. This is a fantastic tool, and this has to be in the operation theater, and anesthetists must be using this as and when required, because it bypasses all the upper airway related problems. Straight away sit in front of the vocal cords, and we can ventilate the patient. And once our ventilation is satisfactory, muscle relaxation effect is good, then we remove a laryngeal mask airway and we put the tube. And now we have a intubating LMAs also. So the LMA, we just put a tube, remove the LMA, and we are most safe for providing a airway control in that particular patient. And another thing is, we should have certain accessories which help the patient in a position. This is kind of ramp position. We require such kind of accessories so we can put the patient in a proper position to manage the proper view. And these are the some graphical presentation how position change the axis by which we can directly target the trachea. So now when we have a conventional laryngoscopy, the entire learning goes around the oral, pharyngeal and tracheal axis. And for that, positioning is most important. So I would request everybody should be proactive while the intubation is going on, along with the gadgets, while the positioning of the patient also. Now, when we have an anticipated difficult intubation, Anesthesia Association has come up with the guidelines that whenever you have an anticipated difficult intubation, you need to have a certain gadgets to manage that anticipated difficult intubation. And that gadgets are different kind of oral nasal airways. Along with that, we require a different kind of laryngeal mask airways. Along with that, we require a different kind of laryngoscopic blade, and that also says that we need to have at least one type of video laryngoscope. Because whenever we are observing or when we are watching from a direct laryngoscopy, our angle is totally dependent upon the patient anatomy. But when we use video laryngoscopy, that video laryngoscopy will enhance that angle. Video laryngoscope itself has an angle for the vision, and that will correct the problem of the normal laryngoscope not able to intubate. Now, use of video laryngoscopy, I would just run a quick thing about video run not a problem. So we have a couple of video laryngoscopy equipments in our operation theater. Now, all the video laryngoscopy, I will just give a brief idea about the video laryngoscopy, why it has to be in the operation theater. Video laryngoscopes are available with the visual angle starting from 32° to 82°. So 32° angle is also available, 45° angle available, 56° available, and 82° available. 32° angle available are the common video laryngoscopes, which are company called BPL, company called King Vision, Ambu. All this company makes, and they are literally within a less than 1 lakh rupees range. the video laryngoscope which has got 45-degree angle. What I mean by 45-degree angle means when I look at the vocal cords, even if that vocal cords are 45-degree away from the normal vision, I can visualize the vocal cord, and with the help of a stellate, I can intubate that patient. So the highest and the best video laryngoscope available is a CMAC, that is TORS, and that is 82-degree. Literally, if patient having a completely anterior airway and with a zero neck movement, we can intubate the patient. Now, this is the highest form of the safety. If we can achieve, we will never miss a difficult non-intubating condition in if we have such kind of equipments. So why we are emphasizing on this? Now, this is in March 2014, where the lot of talk has started about the video laryngoscopy, and then people have started thinking that video laryngoscopy has to be there. Now, 2014 to 2023 and now 24. Now, it has been totally established that we have to have a video laryngoscopy, and now we are coming up with the guidelines is first shot, best shot. Why you want to use a normal laryngoscope, not having a intubation, and then you try with the video laryngoscope, and you are not very much expert in a video laryngoscopy also. So the entire thinking process in 10 years has changed from the anesthesia perspective, that you learn your video laryngoscopy so well that when there is a difficult intubation, you are like managing like a cakewalk. So it has to be like everyday situation of using a video laryngoscopy. So your hand are extremely good when the difficult situation comes, and when you are using it, use it as a first shot, best shot. No hemodynamic disturbance, no hypoxia, no time delay. Use it, 30 seconds, you are done. And the guarantee is almost 99%. Why I am telling on almost 99%? There are few conditions where even if with the good video laryngoscopy, we are not able to intubate. That are very, very rare scenarios and having a lot of anatomical issues or post-radiation kind of issues. But by and large, if we are mastering video laryngoscopy, we are removing the most important fear of not able to intubate and not able to give oxygenation to the patient. So very, very important to start with the first shot, best shot. Now, what is the most important part here is an maintenance of anesthesia. Now, why it is most important? Because high BMI patient with variable body and variable physique, the requirement changes. Now, what common anesthesiologist or routine anesthesia practice, what we are doing is I have given a sevoflurane in per annum concentration, and I assume that my patient is under anesthesia in a proper depth, right? So all this thing used to be assumption, that my patient is properly deep, my patient is not showing any tachycardia, hypotension, that means my patient is enough deep. But that's not the case, because every patient is a different patient, plus that OSA population having a lot of variable. There are thin OSAs, there are high BMI OSAs, and there are variable kind of the patient with the variable comorbid conditions. So our requirement has to have one endpoint. That endpoint is anesthesia gas monitoring system or a bispectral index, which is called a BIS monitor. Now, these monitors will tell us that how much deep is your patient. If this patient, this is a bispectral index, this is how it will be applied on the head, and the normal reading of under anesthesia is 40 to 60. If it is 60 to 80, then it will be sedation. Patient may listen to your voice, and patient may react to the surgical stimulation. Or if it is less than 40, then patient is deeper enough, or maybe more than the required, you can reduce the doses also. And this, when we start using, we will get accustomed to it. Now, one more point about the BIS monitoring is when we are doing a drug-induced sleep endoscopy, we keep the BIS index at between 70 to 75. So that 70 to 75 will ensure that my patient is having a natural level of sleep only, not under a deeper plane of anesthesia because of the medicine, and we do not have a false positive results of drug-induced sleep endoscopy. And then we have a drug anesthesia gas monitoring system. Whatever the sevoflurane or desflurane I am delivering, I should be having some endpoint, that end tidal concentration of sevoflurane is 1.5, and that has to be maintained for the prevention of the surgical stimulus or a prevention of the patient being aware in that awareness under anesthesia. So to deliver all this thing intraoperative, we really required a workstations, which has got a good ventilator. And I would emphasize that if we have a higher quality of ventilator, that really matters a lot if our surgeries goes more than 2 or 3 hours per patient, because our ventilation is our key for our extubation. There was a video for AGM and use also, but never mind. Now the last part is extubation. Now, what extubation we are, what principle of extubation in this case? Principle of extubation is fully awake patient with adequate muscle and tone power, properly responding, following your verbal commands. And that's the key. But that key is not that easy to achieve because we need to maintain a great hemodynamic control at that particular time. Because patient is awake, patient having a tube inside, there are surgeries done, patient may have little pain, and we do find hypertension, tachycardia very often now. So we need anesthetist's job is to get a good hemodynamic control. If I have given hypotensive anesthesia at that particular moment during the surgery, my job is to get the blood pressure up to the normal level and then tell my surgeon that now, boss, you control the bleeding. So good hemodynamic control, good hemostasis is extremely important for an anesthetist for the extubation. If I am not sure about my surgeon's hemostasis, I'll be very shaky and struggling for my extubation also. So it's a proper teamwork between you and me. Good hemostasis, good hemodynamic control, extremely awake and adequate muscle relaxation, fully following the commands patient, and then extubate the patient. Once patient is extubated, head up position, 100% oxygen, or a CPAP mask. There are CPAP masks available which are not claustrophobic to the patient. They give 7 to 8 millimeter of H2O pressure post-operatively. We can keep it easily. And if patient is on the CPAP, we must have planned CPAP post-operatively as per your surgical allowable surgical conditions. And this is how it's been extubated. These are the nasal CPAP. Now, one important thing is happening across the world is that, the data is telling what are the problems in the post-operative conditions. So data has said that crucial time is 30 minutes. First 30 minutes, we do take care of our patient. Whatever happens, we are there with the patient and we are ready for the repeat intubation, and we are ready with if there is any bleeding from the surgical side. So our readiness in the next 30 minutes is extremely important. Second most important is up to 2 hours. Once 2 hours is done, then we can literally be relaxed, and after 6 to 8 hours, we are literally having a very, very minimal chances of having a complication related to anesthesia. Patient can be discharged on the same day. If we have used all the short-acting drugs like fentanyl, dexmedetomidine, sevoflurane or disflurane, and a good muscle relaxation with Sugamadex as a reversal of the patient, then we can rest assured that these patients are absolutely normal in 6 hours of time. And if there are no other conditions, they can be shipped. So they can be sent home. That does not mean that I am advocating to shift the patient to home, but ERA's protocol, enhanced recovery protocols are saying that we can safely do that. So across the world, there are papers have started publishing from the day 2005 dated that we can shift this patient out of the hospital as early as possible. In a conclusion, higher AHI, higher BMI, or multiple comorbid conditions should be kept in the hospital, should not be sent home. Rest of the patient you can take case by case scenario. Video laryngoscopy, again, all the generals are embarking on video laryngoscopy as a first line of strategy. Use it for your first shot. Don't wait for the first shot to fail. So in a summary, we have a 4-5 point. PAC is extremely important. Pre-anesthesia checkup is extremely important. You cannot miss it. Second is prepare all equipments well. Third is a ventilation. Fourth is a video laryngoscopy. Fifth is a BIS monitoring. And sixth is an extremely good hemostasis, good hemodynamics, and extubation in awake patient. I hope I have delivered it well to the point. Thank you. Thank you so much. Thank you.
Thank you, Dr. Kalpesh Shah. It was a very comprehensive lecture which covered the A to Z of anesthesia safety. I am going back as a very enlightened surgeon with a lot of tips for my anesthetist. So thank you very much for making me a safer OSA surgeon today. Thanks. We would just like to give you a token of appreciation. I now invite Dr. Rahul Modi to carry the proceedings further.
Hi everyone. Okay, so we have had a very long day, very entertaining, lots of discussions happening. Okay, perfect. So what better way to wrap up the day with some interesting case discussions? Huh? Any audio? Yes. So I hope everybody has taken that printout which was available outside. Everybody has a copy. If you don't, if I have the Cipla guys around, they can help out with. I hope every participant just follow the case-wise cues that we give. I think Dr. Peter will have to do with the online.
Can you take Dr. Peter in PIP?
So I have purposefully kept some very simple basic patients, and emphasis is on just getting the basics right. Looking at our young audience, I think it's something that will keep everybody interested. So without much delay, I think our panelists here need no introduction. We have Dr. Vikas Agarwal, we have Dr. Nilesh from Pune, a very senior rhinoplasty and sleep apnea specialist, and we have, of course, our very own Dr. Seema Sheikh.
And Dr. Peter also is
And
online.
Dr. Peter Baptista from Dubai is also joining us to give his expert comments. So great. So first patient, 55-year-old lady, banking professional. She comes to us in the clinic, standard variety symptoms. She doesn't feel fresh during the day. There is a lot of sleepiness, loss of concentration, tends to snore loudly in the night, has non-refreshing sleep despite sleeping for 8 hours. If you see, each and every word is important because you need to ensure that the patient has slept enough to quantify their sleepiness, and it tends to doze off during meetings, watching movies, chatting with friends, feels very tired, and she's on medications for hypertension and diabetes mellitus. Dr. Seema, anything else that you would like to know when you are dealing with patients in this age group, which is essentially a common age group for patients with OSA?
Postmenopausal.
Okay, so
I'll ask her
postmenopausal.
about that.
Sure. Anything else that you would like to know from the history part?
Medication to a good extent when it comes to hypertension. Some of the beta blockers are known to cause a good amount of sleep apnea also.
So, I mean, more than that, I would also like to insist on sleep history. So, a couple of points like, when the patient goes to bed, how long does that patient to fall asleep? Whether there is any insomnia component or not, whether there is any restless leg syndrome component or not. So, just to complete the sleep history. Now, in terms of clinical evaluation, we have discussed the stop bank score enough for the patient. We typically suggest that patients, just to simplify what Dr. Prashant Chhajed mentioned earlier in the day, if there are more than 3 things positive in the stop bank score, you are certain that the patient is high risk for sleep apnea and you can go for a home sleep study. If less than 3 are positive, then you should choose something more dedicated like a level 1 sleep study. In our patient, she snores loudly, she feels tired, there is high blood pressure, BMI and age again meets, so we went for a level 3 sleep study. Now the BMI we know. Clinical examination also showed a deviated.
Can I just add to that?
Yes.
Because ASM, American Academy of Sleep Medicine, actually has come out with guidelines that none of the patients that have OSA with comorbidities should be going in for anything other than a level 1.
So that is specifically for cardiac issues where you are expecting something more than garden variety conditions, not for any comorbidities. So it is not for any comorbidities, but specific conditions like accelerated hypertension. If you're having congested cardiac failure, you are having any specific neurocognitive conditions. But for this garden variety kind of a presentation with high risk, level 1 is very acceptable. Now, the local examination. Anything specifically that you see in these patients, Dr. Seema, while evaluating? We can have inputs from
this
Dr. Vikas
particular
also.
one, right?
Just on this particular patient.
So there's a gross big spur there. There's obviously a very high tongue, which is letting us not see the palate. These are the two things what you've shown me I can make out. If you want
But
me to look
anything
for
else?
anything else, I would
Yeah.
like to look into the nasopharynx behind
Okay.
and look from top down whether there are any other obstructive lesions behind.
Right. Dr. Vikas, any inputs from your side for these patients?
Thyroid, definitely.
Okay.
Thyroid. And obviously diabetes, if at all.
Okay. So general examination.
Yeah.
Anything locally you would like to comment? Anything else that you would like to test?
Anything
So I mean, no tricky questions here. The whole idea is to convey. So one thing that we are always taught is the Cottle's maneuver.
Cottle's test.
Okay.
To look for
Dr.
nasal wall.
Peter is also sitting,
Yes.
so you can ask him questions.
Yes. So Dr. Peter, anything else? This is not exactly the elderly patient that you were mentioning in your presentation, but still, given the Indian scenario, we are a youngish country and this is what we get, and sometimes they are not in the best shape. So would you say anything else specifically? Say if it was an elderly patient, instead of 55-year-old, if this was a 65-year-old, would you evaluate them any differently?
No, I would keep on evaluating the same way, but she's definitely overweight. She's
Yes.
she's very overweight.
Yes.
So that's probably a very important aspect in this lady. That makes her have the sleep apnea, makes her have also diabetes. I mean, it's predisposes. It's a comorbidity, and they interact together.
Yes.
So that's what we're seeing in this lady.
And what would be your preferred? Like, we would prefer to do a level 3 study for the sake of simplicity. Would you recommend a level 1
Well,
sleep study for her?
Look, I mean, let's put it this way. A level 1 study is very difficult most of the time because of two aspects. One is because it's expensive. The availability is not complete. And what we're trying to discard in this lady is definitely obstructive sleep apnea. So we probably should go for, we could actually go for a lower level, okay, to discard the sleep apnea, as she has many aspects that do coincide perfectly with obstructive sleep apnea.
Right, perfect.
Rahul?
Yeah, sorry.
So one of the other logics that I would apply to going for a lower level sleep study is the fact that with her BMI and with her all these issues, she's obviously not a very surgical candidate.
Sure.
And I don't think a level 3 versus level 1 would tilt her towards surgery otherwise.
True. And you're not suspecting that you will, more importantly, get additional information from doing a detailed level 1 sleep study. See, for any investigation, if you're going to order, then you need to have the advantage of additional information. If I'm suspecting somebody has got epileptic seizures in the night, if I'm suspecting somebody has got ventilation issues, if I'm suspecting somebody has got other things at play, then a level 1 sleep study makes all sense given the cost and everything also. But till that time, level 3 sleep study is fine. We discussed the stop banging for her. Now I want everybody to go through the sleep study and just focus on the various metrics that are shown. So I believe the faculty has it. I'm highlighting here. I hope the slide is clear to Dr. Peter also out there. So can you just read out the sleep study for us, Seemap sir? What all things that you will look for in a sleep study? Just the basics, Dr. Nilesh. This is case 1.
Yeah, the respiratory event index, one of the major things to be looked at. Besides that, I think I would go in for actually trying to analyze what is the lowest desaturation. That's at 67.
Right.
Besides that, then coming to the respiratory events, whether they are purely obstructive or central, a central component seems to be there to good extent also.
Right.
Besides that,
and would you comment on the
body position, basically?
So positional data. So so essentially what the message here should be that whenever we are evaluating a sleep study, we should look beyond AHI and not just AHI alone. Can Dr. Vikas, can you tell us AHI versus REI, the difference between apnea hypopnea index versus the respiratory event index, because it's mentioned REI here, because that may cause unnecessary confusion.
Yeah, so there are a lot of confusing terms. I'll try to make things simple. Like in this case, if I am supposed to read this study, the overall AHI is around 50.6,
Right.
which is pretty high.
Right.
But if you break it into central apnea, obstructive apnea, mixed apnea, hypopnea,
Right.
if you take the breakup of the indexes,
Sure.
you see that the obstructive apnea is only 15.
Right.
Central apnea is 14.7.
Sure.
If that is recorded correctly, then this lady is having definitely some issue with the central problem.
Right.
Then you see 13.7 mixed apneas and hypopneas.
Right.
So all this is because of possibly the weight and the central disease that she can
Sure.
have. So 100% she's not a surgical candidate because her obstructive apnea is only 15.6.
Right.
Her weight is a problem. Then, as you said, RERAs, like Dr. Prashant said, respiratory event related arousal.
Right.
So the arousal rate can be much more apart from the obstruction rate.
Right.
So if that's what you wanted to ask.
No, so basically, just to simplify to the juniors out here, Dr. Seema would like to. So there are essentially, when you read the literature, there will be primarily three metrics which are going around. There will be the AHI, which is the standard apneas and the hypopneas, divided by total sleep time. I'll see if I can pull up a slide for that. Then there is the respiratory disturbance index, that's the RDI, which is apneas, hypopneas, RERAs on total sleep time. Now remember, in a level 3 study, you don't have EEG monitoring. You know, it may sound a little technical, but you guys should know, you cannot compare apples with oranges. So we have got a level 3 study and there is no EEG monitoring here. So if there is no EEG monitoring, you cannot define a total sleep time. So to differentiate AHI technically, which is derived from a level 1 sleep study, the terminology used is a respiratory event index, which is total number of events upon recorded time for the number of hours the recording was going on. So you should not compare in a patient level 3 study versus a level 1 study of that patient. You should compare level 3 with level 3 and level 1 with level 1, and ideally from the same device, because there will be inter-night variability, inter-device variability, and variability amongst levels. And AHI, can you just tell the important metrics that you just enumerate? You look for the AHI.
Yeah,
You look
I
for-
would be looking more at the central apnea versus obstructive apnea also, because you have to keep in mind, if it's like a 20% of the entire events are central, then they become significant. If the central are not 20% of your entire obstructive events, we don't give it that much importance. The other thing that one has to understand about these sleep study level 3 is the fact that whatever you get, like Rahul said, total sleep time, sleep time is always going to be lesser than total time in bed. So when they are calculating this index, it is calculated with total time in bed. So obviously what you're getting at a say 50.6 actually will be much higher because he slept for lesser time and the denominator will have increased.
Also, level 3 will miss out on a large number of minor events. And that's not the case. I mean, even if it is the AHI turns out to be 70 with a level 1 sleep study, I think our essential plan of management will not change much realistically. Okay, so that's the reason that we are not pushing for a level 1 sleep study here. But point being, if you are not comfortable reading a sleep study, if you are not able to extract, then you will be very lost following up this patient, how to know whether this patient is doing well or not. Okay, so this was our initial plan to the patient, and patient was, I think everybody will agree with this plan. Anything specifically, how like you do with these patients with the CPAP trial? Dr. Chajad was suggesting no more rentals. I can't imagine a world without renting CPAP. I mean, that's me. I mean, any inputs from the house?
Same. I didn't get a chance to ask him why he says no for that. But
Yeah.
yes, I would do exactly this. The patient has to give a trial with the CPAP. I would go to the extent of saying, if not CPAP, also try a BiPAP.
Right.
I think I would support what Dr. Prashant was saying for the major reason, and as I mentioned, the level 1, majorly being that central events, again, as you said, it's polysomnography.
Sure.
It's not just a polygraphy.
Right.
So that actually helps you to identify central events much better.
Right.
It's going to give you a much better analysis of the RERAs.
Right.
Because RERAs need to be manually calculated.
Sure.
It is not something that comes on most of the software algorithms that most of the companies are using commercially.
Right.
That is where I would say now in the previous one that you just mentioned, the central component seems to be of a good amount.
Yes.
These kind of patients, if it turns out to be a higher amount of central apneas, auto CPAPs don't work. That is where you need to shift to fixed CPAPs. So fixed CPAPs need to be going in for titrations. So that is the reason, as he was saying, that why you need to do
I'm
that.
going to pull your leg on this. So
Yeah,
okay, so I don't
do
think
that.
that's just.
I will also
I mean,
do
like I think so. Basically,
the
the
split night
difference.
titration is what they're talking about.
No,
basically.
so basically, essentially, we are confusing too many things here. One, I think auto CPAP will work in scenarios where fixed CPAP will work. So I think that topic is settled. Let's not confuse people more. Second is essentially, and these are important discussions because when you're treating patient with sleep apnea, you can't just say that I will do only surgical patient. You are not my patient, go away. As a ENT surgeon who's, so to say, doing some amount of sleep apnea, you need to know the CPAP terminology and be comfortable with the initial CPAP management. Dr.
No, I rather I would say, first of all, whether this patient should be given CPAP or is there any surgical procedure which is warranted on this patient?
No, so I'm coming to that.
Yeah, that will
Yeah,
come
I'm coming to that.
septoplasty.
I'm coming to that. I'm coming to that. So we will get our chance.
Yeah.
We are
that
going
will
to
ideally
operate.
come after
This
the
is a surgeon conference. We get to operate. Okay, on all our patients. So don't worry, but we'll reach there. We have to be patient for that, right? So that's my next slide. But inputs from Dr. Peter. How would you go about like advising CPAP for this patient? Dr. Baptista, are you still around?
Yes, I'm right here.
Yes.
So, well, before, I mean, I do think that definitely the use of CPAP is something important, but also I think that she should be sent to an endocrinologist, first of all, to lose weight. So we know that there are medications at this moment, okay, that could help you lose weight. Okay, she's in the borderline actually of morbid obesity.
Right.
And therefore, I think that, I mean, this will definitely help her in many senses. Okay, of course, then we have to treat her obstructive sleep apnea. But as you saw, I mean, she has central events. Sometimes just using a CPAP is going to produce also more central events. So she has to be very, very, I mean, studied in a very good way. She has to have also a checkup with the use of CPAP also while she's using it. And definitely what we saw before, she has a very important nasal spur. So that's gonna increase the pressure, okay, of the use of the CPAP. So doing the nose or doing a surgery in the nose will improve her quality of nasal breathing and could reduce the pressure of the CPAP, which could definitely help.
Right. Perfect. So the whole point I want to highlight here is you have to think before doing anything and try to visualize how the patient's passageway is going to be. And lo and behold, the patient had high pressures. We had given the CPAP for 2 weeks. She had very poor compliance on the days that she could use the CPAP. She was feeling better the next day morning. So the EDS was reversing. But, anything that we can do to improve the compliance. So we got surgery. That's one, right? That's a given. We are surgeons. We'll knock out that spur and we're going to do some turbinoplasties. Anything else that you normally do for your patients?
I wouldn't do that turbinoplasty and septoplasty if she was CPAP compliant.
Absolutely.
Let's be very clear about that.
That goes without saying.
Just because there's a spur in this will not do it if she's CPAP.
Yeah, 100%. So I have had patients, and I'm sure Dr. Seema has also seen patients. Everybody has seen patients where you feel that this patient is going to have a lot of trouble using CPAP and he'll come back very happy. He's like, boss, life set hai. And my thing to that patient was, you've got the perfect treatment. I'm talking about the other pathway. If the patient is compliant to CPAP, my job as a sleep apnea specialist is done. I'm going to say, take 6 months, take a year, lose weight, come back to me in normal weight, and then we talk about how to go forward. Okay. Then we talk about how to move forward with this. But our patient is not liking the CPAP. The pressures are very high. Part of it is perhaps because of her weight also, and part of it is the spur. But any other measures that you typically do. So what I'll do, I'll tell you. I'll typically give a trial of CPAP. If the spur is there, then more likely spur is responsible for the high pressures. In a patient where spur is not there, and the pressures are still high, then I will be essentially, then perhaps in that select group of the patients, I will plan to take the patient back to the lab and do a little more detailed analysis. That will be 1 out of 10 my patients. So I will be able to avoid this lab journey for 9 out of my patients, because practically still there is no insurance reimbursement happening for these patients, and it's a pay out of pocket system, and it's cumbersome. And each day the patient is going without any treatment. I am not comfortable once I have diagnosed moderate to severe sleep apnea and patient is otherwise accepting to the idea of CPAP. So I would not like to delay things, put her on CPAP, and then think about anything else to improve compliance. Everybody is clear on the difference between CPAP and BiPAP? No questions on that? Okay, so BiPAP is a technology where you have a different pressure while exhaling, so it makes it easier to exhale. CPAP is a single pressure. Okay, moving ahead, nasal surgery we did, nose evaluation we have talked about. So this is a very nice paper by Dr. Camacho from Stanford, and Capasso was also part of it, including Christian Guilleminart, which showed that the average CPAP pressure reduced by about 2 centimeters when you did surgery for these patients, nasal surgery, and 57 of 64 patients. So 88% of patients who were not able to use the CPAP earlier, after a simple septoplasty, turbinoplasty, which I think most ENT surgeons should be able to do a very good job, were able to do. So communicate with your pulmonologist and tell them that if your patient is not compliant with CPAP, then we can help you out there with a simple nose surgery, and it's a low risk affair. Especially, I mean, nothing is low risk affair with a 35 BMI, but we always have Dr. Kalpesha around us to help us and make life easy for us. So shifting gears, this is on the other side of the spectrum. Case 1, anything additional points Dr. Vikas, Dr. Nilesh would like to make? Okay. Patient number 2, 29-year-old male, IT professional, comes with bed partner complaining of loud snoring, got recent weight gain. He's got recently married, 6 months into marriage, and the patient is actually a school friend of mine. No dryness of mouth, no witnessed apnea, sleeps 6.57 hours a day, feels refreshed, has a lot of allergies. Efforts is 3. Okay, no comorbidities, hypertension, diabetes, mellitus. Anything else that I'm missing out? Younger patient specifically that you would like to look? No trick question here. I'm just open-ended questioning. Okay. No, he was not 29 now. This I'm saying few years, not my batchmate, couple of years junior, but I'm taking this is an old patient. So BMI 27.5, not very obese, has turbinate hypertrophy, Friedman tongue position of 3, tonsil grade 2, not the best kind of a scenario, but yes, some obstructions there. Stop bang of 2. Now, technically, how should we move forward? What would you counsel a patient who comes with sort of primary snoring? What would be your approach where symptomatically you feel that there may be primary snoring? Dr. Seema, would you always advise a sleep study? Is there anything else that you would look for?
So the sleep study goes without saying. I mean, I don't think I would not advise a sleep study to anyone.
Okay.
The initial protocol will remain the same, exactly like what you said, sleep study followed by a CPAP trial. Yes, I know that there are obviously 2 or 3, 2 at least obstructions that I can handle.
Sure.
Both in the same sitting if required, the nose and the tonsil.
Right.
I will come to the tongue obviously after I've assessed more.
Right. Dr. Peter, in your practice, does primary snoring, are there any patients who snore who come to you and you will not advise a sleep study? Let me put it that way.
No, I always advise, because you see, I mean, each patient is completely different the way they feel. Okay, especially young patients. Okay, they have a phenotype, but definitely they might not feel tired at all, and they might have obstructive sleep apnea. And most, I mean, there's the partner, if the partner witnesses, or their family member witnesses, but sometimes they sleep alone. So it's impossible to say, and there are even apps, okay, at this moment. But unfortunately, I've done paper about the apps. We cannot say that the app is going to be adequate. So a sleep study is, I mean, I will feel completely the need for a sleep study always. Now, patients are hesitant about it. That is true.
Right. Right. And so, okay, we do a sleep study. Which level? Just to add more spice to the game. Which level would you advise? I know the answer, what I would do in practice. Theoretically,
I
is
would
different.
still go with the level 3 for this person. But just a point to make here is that the whole point that I said in my talk also, you need to identify simple snoring and snoring with apnea. And you can't do that until you have one basic sleep study. So you cannot shy away from a sleep study.
Right. Any inputs, Dr. Vikas?
So to my mind, this is the most difficult patient to treat.
100%.
Why? He has got simple snoring.
Right.
He is not having a problem by himself. He's at the most, the sleep study will tell he has upper airway resistance syndrome, or he'll have a mild sleep apnea. So he will not accept a CPAP. No simple chota mota surgery is going to help him because he has got a loud snoring.
And
His nose is normal.
And he's your school friend. So
Whatever. So if at all you want to do a surgery, you'll have to reduce the length of his soft palate or do something very big, which is not acceptable because he's not a severe sleep apnea patient. He's not symptomatic. So he is one patient which is most difficult to treat in my view.
So you have the person who's doing it for 14 years, has done highest number of cases, telling you a very simple point. Simple snorings are the most difficult to treat. So don't get tempted in kind of embarking on something surgical just because you feel it is simple snoring. Don't touch this patient with no symptoms whatsoever without a sleep study. Dr. Vikram, your question. So we are coming to that. We are coming to the management, but we are just discussing about initial steps in terms of it. So I assure you that I have covered that in the care plan for sure. Now we start the allergy medication and the patient gets, I follow what the panelists tell me, what the experts tell me. I get an expert comment and I do a level 3 sleep study for this patient. I want everybody to go through the case too. And specifically, I've already kind of highlighted and given the kicker here. If you notice, Dr. Nilesh, can you just mention what is highlighted for this patient and why is that relevant?
Supine AHI, or rather respiratory events are maximum in the supine position. It's a moderate sleep apnea. And I think I'm getting refractory errors.
So basically what Dr. Nilesh is trying to tell, or I'm trying to interpret what he's trying to tell me is, see, you have a patient with an AHI of 17.4. So something that we were considering it to be primary snoring turned out to be technically a moderate OSA. He's got an LSAT of 82. Why do I need a sleep study in a patient who's not complaining of daytime somnolence, who's not worried about his snoring? Is because 50% of my patients won't have excessive daytime sleepiness. 50% of patients with severe OSA, with moderate to severe OSA, will not have excessive daytime sleepiness. I'm worried about their blood pressure. I'm worried about their cardiovascular risk factors. I want to look at their oximetric parables. However, I need to look a little more in detail. There are two important points that I've kind of like highlighted here. If you see, the supine events are 22.2. However, when he goes into left or right position, that's in the lateral position, his events drop down drastically. Especially when he's in the right lateral position, his events drop down to less than 50% of the supine component and they are below 5, which is the criteria for defining as positional sleep apnea. So can I label this guy safely as positional sleep apnea? And even though his LSAT is 82, if you check the time this person spends below 90%, you see that T20, the oximetric, the T90, the T less than 90% that I've highlighted, it's hardly 0.3 minutes. So he's not spending a boatload of time in that level. So I'm not really worried that tomorrow this guy is going to have a heart attack if I don't treat his snoring. Tomorrow this guy is going to have some major issues. If I hope everybody in the audience agrees. So you want to look at the quantum of desaturation also, and not just a singular level when we are talking about desaturation. Now, the standard advice for this patient, we did what Dr. Vikram had suggested. We did aggressive allergy control. Role of a CPAP trial in this patient. Will you give CPAP trial to this patient, Dr. Vikas?
No.
Dr. Nilesh?
No.
You will not even give him a trial? No rental?
For documentation purposes, yes, I will. I will always give it.
But beyond that, Dr. Peter, would you like to give a CPAP trial to this patient?
Well, look, the way I look at things is a bit different. I mean, I always inform the patient of the possibilities, okay? So I think that the first thing is I tell them, look, the traditional way of treating this is the use of CPAP. However, you're a young patient, okay, and you have certain features that might be susceptible to improve with surgery. Therefore, it's up to you. I mean, I want to treat you like how I would treat myself, okay? Because I want to give you the information, but and you're the one who's going to actually decide. I know I'm the expert that's supposed to inform you, but at the same time, it's up to you. Because I don't like to push patients to do surgery. What I like to do is actually the first thing is always tell them, you know, you could try the CPAP, okay? If you don't like it, then you'll have surgery. Done. They're truly convinced about the situation. So that's the way I look at things. I don't know if it's right, if it's wrong, but that's the way I look at things.
Yeah, so perfect. So what I would do is I would like to give a CPAP trial for the simple reason to know if there is any real neurocognitive issue going around and his youth is not able to realizing. Many a times when you give CPAP to patients who are not upfront complaining of daytime sleepiness, they will say that, doc, I have never felt so fresh in my life. I thought I was feeling fresh, but this is definitely better. And if the patient is feeling better, they may agree to use CPAP, but this is not a guy that I'm going to sit and push CPAP, but I'll definitely give him the option of trial. But obviously,
in fact, the trial also I would give him after maybe about a month or so of proper allergic rhinitis treatment.
Perfect.
Only
Perfect.
after that.
Perfect. Makes sense. So, young guy, we told them trial, he refused totally.
Would you like to look in insomnia part of it?
He does not have insomnia. The lady had. And positional therapy. So point I'm trying to make is we are all surgeons, but we need to look beyond CPAP. See, I've taken some off the beat cases because this is what you will get when you start out doing sleep apnea. You are not going to get juicy grade 4 tonsils who will come with all the proper symptoms and then you will operate and these are
so Rahul,
yeah.
All I wanted to add is that this is a typical patient I was talking in the morning.
Right.
Is going to progress in next 10 to 20 years into frank sleep apnea because if he does not maintain his body weight aggressively and does not take care of the nose allergy, gradually he'll cup weight and will turn into
100%. So we need myofunctional therapy going on for this patient. We need a muscle re-education. We need good allergy control. We need good weight control for this patient. And any role of oral appliances in these patients, because that's the typical criteria that is mentioned by the American guidelines. Dr. Peter, any experience with oral appliances in this patient with good allergy control?
Well, there is the possibility. I do think that, you know, while we do the drug-induced sleep endoscopy, we could actually see if the patient airway could improve with my mandibular advancement device. I mean, it's just titration at the moment and see if that's a possibility to see. But we have to see the airway first. That's the first thing. I mean, I won't give them blindly at all.
Perfect.
The mandibular advancement device.
Perfect. Thanks. Excellent point. So another message is, even if you are thinking of giving an oral appliance, look at the airway, do a drug-induced sleep endoscopy, mimic a jaw thrust maneuver or what we call as an SMAS maneuver, as Dr. Vikas has shown us today, how the airway responds, how does the snoring respond. Don't be blind, do a directed, tailor-made treatment for your patient. So oral appliance, check for suitability with the DICE is also an option. We all know about DICE. Now, a couple of points that I made about positional sleep apnea, and essentially it's very common if you look for it, and it's easily treatable with positional therapy. Now, quickly coming to the last case scenario, any other additional points for primary snorers that you would like to make, and anything else? How will you counsel for surgery for these patients? If you at all you want to touch this patient, operate this patient, what will be your counseling for surgery? Do I want to treat what is the problem now, or I want to prevent it from getting worse? Why would I want to operate?
So actually both. So I have operated on a lot of primary snorers, young patient. I'll give you example of primary snorer and maybe mild sleep apnea.
Right.
I got a guy, ENT surgeon from Patna.
Sure.
This is around 4 months, 5 months back.
Right.
His main complaint was snoring and daytime sleepiness.
Right.
So he had a deviated septum, turbinate hypertrophy, and a little longer uvula, soft palate. So I took out his tonsils, which are not very large, but I said, I cannot knock off your uvula. Your HI is only 7.5.
Sure.
I did his nose. He called me up after 2 months. Sir, I'm feeling fresh, very fresh. But my problem is my snoring is still the same.
Right.
Because I even did a barbed suture. I tried everything, but his soft palate was pretty long, and for fear of not resecting the uvula, I did not do that. His snoring persisted. He said, I want to get rid of my snoring. My wife is after me.
Sure.
He came back. I knocked off his soft palate. His snoring is gone.
Sure.
So the point is that if you want to take off the snoring, you have to take off it completely.
Sure.
So even if you're treating simple sleep apnea, as I said, you have to do a much bigger job.
Right.
To treat simple sleep apnea. And it's very difficult to satisfy those patients, because even if there's a little bit of sound, they'll say, no, snoring sound to hi hai.
So there is some research to show that even if you do just the nose surgery in patients, you may not, isolated nasal surgery, I'm saying, for sleep apnea, you may not get fantastic improvements in AHI in a lot of patients, but a lot of their symptomatology will improve. Their sleepiness will go down. In my experience, in patients that we do polyps and who are like borderline OSA and all of that, one thing I've also noticed, and the panel here, the expert panelist here, Dr. Hilale also does a fair amount of work, can give inputs as to sometimes post-operatively, after a month or so, once the nose settles, patients may complain that their snoring has actually gotten worse. Because they had a collapsible palate is how I think, but there is a huge gush of air now reaching there, so there is more vibration happening, and the patient sometimes message me, doc.
No, they're sleeping more deep.
They're sleeping deeper, and that's a nice way of putting it. So it takes the responsibility of the surgeon.
No, in fact, this case that we did yesterday, Kalpesh, that boy from Surat, we did his sinus surgery and nose. He's actually a case of moderate sleep apnea. I've only done his nose because his major complaint was sleepiness and not being able to sleep well in the night. He's awake till 3 in the night.
Yes.
And it's because he feels suffocated.
Yes. Perfect. Now coming to the last case. Okay, I hope this makes the surgeons in the audience happy. Till now we are like, not in surgery mode. So I have a 35-year-old male hotelier comes to me, complains about he's diagnosed with OSA 2 years back. He does not have his previous sleep study, has good ESS, socially unacceptable snoring, wife is troubled, has intermittent CPAP usage for the past 2 years, and he feels better when he uses a CPAP, but has absolutely poor compliance. He is kind of in the category of the patient who does not want to use CPAP. Okay, so you'll get two categories. One is they cannot use the CPAP, and there will be a second category who will not use CPAP. So he's in the will not use category, and no comorbidities, otherwise healthy person. He's not used CPAP for the last 3 months. Anything else in the history would you like to take? Anything else? Do you really push for more CPAP usage, Dr. Seema? To make life easy, explain them what are the good parts, use CPAP.
I'd rather actually ask him why he is averse to CPAP, because since 2 years he's obviously not chosen to look for anything else. So why now? Right? So obviously something has happened or something about the CPAP has disturbed him, and if it's something small, I'd like to attend to that initially.
Yes. But it is not surprising. A lot of patients still don't know surgery is an option for sleep apnea. I mean, that's so we need to do more work for
So
that.
we have a lot of one old ENT doctor is going to come. One colonel came from army. So,
Right.
so I mean, they have used CPAP for 10, 15 years and still they want
Not
to get
happy.
it out
Yes,
of it.
yes,
I mean,
yes,
they want to
yes.
get the surgery done.
And surgery is, I mean, for a lot of patients, surgery is surgery, right? For them, it may be like every surgery is like open heart surgery with the risk attached. I mean, patient philosophy. Yes. Now coming to the facts, BMI is 25.5, not very high. Nose has bilateral turbinate hypertrophy. Friedman tongue position 1, tonsil gate 3 is something that I think when you see these kind of patients in the OPD, you are like, next 24 hours, I need to get these tonsils out and send this
Question
patient.
is only tonsillectomy will snoring go away? No.
No, it won't. So obviously. But so we did a stop bang of 4. Please go through the sleep study, case 3. We are going to get our sleep study expert, Dr. Nilesh, to opine. And so you see the numbers there, crazy bad numbers, right? For a 35-year-old, we got a fresh study done. REI of 100, AHI, LSAT of 65. You know, saturations dipping down, is spending close to 2 hours below 90%. So by all aspects, severe sleep apnea in all parameters, I think everybody will agree here, and someone that needs to be treated. You can't let this patient go without treatment. You need to do something about it. And the numbers are out there. What is the care plan for this patient? Would you like to try something else before going for surgery?
Nose, you said?
Nose turbinate hypertrophy, septum is midline.
Okay, and the BMI?
BMI less 25.
25, yeah. So says there's something more to the story than what we see. AHI 100 cannot be just because of this.
No, so essentially, I agree with you, but
so there could be lingual tonsils.
So there weren't. We took the patient for DICE. Basically, I think the patient has done enough. 2 years of CPAP. There is no point convincing him more. He's 35. We cannot. He's got bad numbers. Something needs to be done. I mean, he is not going to be. And my target is ideally that. I mean, something needs to be done. We have tried enough of CPAP. 2 years of CPAP is enough of CPAP in my book. And for me, I think he's a good candidate for DICE to look at as to how we are doing. DICE has kind of like, you know, a severe kind of a picture. There is Dr. Seema or Dr. Vikas, any of them, your inputs regarding the DICE? The tongue base is actually not falling.
So you can see a pretty long soft palate.
Yes.
So and you cannot even see the tonsils coming right now. That's what I was telling. Knocking off the tonsils is not enough.
Yes.
So you'll require to do a resection of a part of the soft palate.
Right.
A proper uvulopalatopharyngoplasty, whatever variation you want to do.
Perfect.
But
Perfect.
because
So
only tonsillectomy will not help.
Focus on that word, whatever variation you want to do. Okay. So you can decide on.
So I think the less number of variations now left for us to choose from.
Right.
And so it's like coming down all the way. We've ruled out all the other variation, and you stick to doing a barbed with a suspension along with that if you want, or you do a barbed with an anteropaloplasty. That remains when I say barbed, I'm not talking about barbed pharyngoplasty. It's basically a lateral pharyngoplasty, getting the palatopharyngeus onto the
with the easier suture, which
whatever
saves
this.
time. Yeah.
So it boils down to that, and I think, like you said, you know, this is the right way. Before getting into that, the DICE was needed to see below, because you can't see anything in the palate from outside. So nasal surgery and tonsillectomy plus or minus barbed under one sitting, because it's quite ideal to do this under one sitting is what I would plan for this.
I think Dr. Kalpesh will agree. One sitting में करने देंगे हमको.
ये तो बहुत ही easy case है. इसमें करने
Exactly.
BMI कम है, AHI 60 है, तो कोई खास बात नहीं है.
Dr. Nilesh, anything else? What will you counsel to this patient? He's got an AHI of 100. You're operating.
AHI was 60.
No, 100.
REI was
100.
So
that was obstructive apnea was 60.
Obstructive only apneas are 60. It's severe sleep apnea. What kind of a counseling you will do for this patient? What are the chances that you will benefit the patient from surgery? I think we all agree that we'll benefit the patient from surgery. He's not using CPAP. he'll feel better. But any special counseling, because it's very important how you communicate with the patients, right?
I won't use the word cure. I will also tell him that the post-operative sleep study will not be of that much significance, provided you are symptomatically better.
Sure.
That means your HI will still remain 100.
Even if it does, it won't matter to him. That's the point that I will make.
No, but I'll take an exception there, sir, because for me the oximetric data is going to be significant. I mean, I will not.
You have to open up the software.
Yeah.
You, see, a Zeta would be a very, very good option.
We'll do a palatoplasty, whichever you are comfortable with.
So saturation part, yes, I do agree with you for that.
Saturation part, but what will you say to this patient? You're going to operate a patient with an AHI.
May or may not need a CPAP later on.
I would say that you should
Quite
be
a
ready
few
to
chances,
use a CPAP.
yes.
Chances are once you open up your nose and palate, you will perhaps tolerate CPAP better. I am doing this because there is no other alternative with me right now. And I'm doing this to reduce the disease quantum by itself. So hopefully some numbers will improve and we may get lucky. But essentially you heard the guarded way the bosses are talking. Absolutely. Absolutely.
No, so that's what I'm saying. This patient seems to be very, very difficult.
Sure.
But this patient will improve much, 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 much more than the simple sleep apnea snoring patient, because his definitely
the disease volume is so much.
Volume is so much
that he'll feel
yeah,
better.
even if you remove 70-80% out of it, he will be very good.
His anatomy is very favorable. So this is one patient you won't want to let go.
Yes. So whatever the case, so you saw that very, very important comment. You are at the end of the day a surgeon who are treating anatomy. How the sleep physiology will respond to an open anatomy is very difficult to predict in the pre-operative setting. And that is why you need to go forward with lot of caution. Any special post-op care tips because of the high AHI and the bad numbers, saturation numbers?
Nothing really. I mean, the repeat sleeps.
Yeah, Dr. Peter, thank you so much for your inputs. Really important, really, and for your talk. It was a pleasure as always. And thank you so much for taking time out on a Sunday for us.
Thank you. I appreciate very much the invitation. Bye-bye.
Thank you for being with us on a Sunday. Thank you.
Bye-bye. Bye-bye.
Okay, so repeat sleep study we have discussed. I think ward classification we have discussed. It's done. Now, this is the sleep study of this patient done 6 months down the line. It was a surprise for me also.
Huge difference.
Okay. Yeah. So, I mean, these are those. So, point I'm trying to make is you take AHI as one of your decision-making matters and don't be in a rush to tell or deny surgery to a 35-year-old whose anatomy is very favorable. Okay, go ahead, Vikram. So this patient came to us after using CPAP for 2 years. So definitely, that's why we give a CPAP trial, right?
Yes.
In actuality, now my principle is that a person, unless if he's a heart patient, if he's a COPD patient, if he's already on blood thinners, if he's a very bad surgical candidate, very bad obesity, only those are the patients whom I really push for CPAP. Rest, unless I am not sure about giving results, I would advise surgery to almost everyone. Why not? They need a cure. If I can sense a cure, I will offer that first. You are absolutely correct.
No, so I feel a trial should be given to all patients.
Yeah.
It does help. I'm not saying that I'll wait for 2 years for him to suffer. My typical
So he's saying that before advising a stapedotomy, there's no harm giving a hearing aid trial.
Yeah,
that's what
That is the logic behind it. Basically, you
and
just need
CPAP, see, I'll tell you what, Vikram. I'll tell you what. These neurocognitive symptoms, now you are assuming it is because of sleep apnea. The symptoms which are not going to reverse with CPAP will not reverse with surgery, and that helps in very much counseling. You will get patients with depression who are snoring, whose wife is unhappy, who are complaining, having marital discord. You operate them, the snoring is not gone completely, AHI is improved, but he's like, my neurocognitive symptoms have not reversed, which would have saved you a lot of trouble if you had given him CPAP to begin with. You have seen your symptoms are not reversing. Let's work on reversing your symptoms. Let's explore alternative reasons why you are not feeling fresh. And then we can always do surgery to improve your AHI numbers, but your neurocognitive symptoms will not improve. Go ahead. That's why the rental model. Yeah, I mean, that's a tragedy, right?
Without addressing the pathology, it is the opening of the airway and giving good sleep and good oxygenation. Your pathology still remains and you're dependent now on the machine. And it is not easy to wear the CPAP. Try wearing yourself for sleep. You can't do it for
But the other side is that we have hardly 10-20 surgeons in the country for sleep apnea.
No, I think everybody is a sleep apnea surgeon until proven otherwise.
No,
So availability of a sleep apnea surgeon is even less.
I would personally say that you need to take it with a pinch of salt. Any surgery when it comes to sleep apnea, this is a lifestyle disorder. This is not something which is a disease, which is the patient is going to, it's something that you can, it's like cancer, you just remove it and it's done with. Or maybe
it's
not.
A chronic disorder. It's not a lifestyle disorder. It's a chronic disorder. Patients really suffer. Our patients really suffer, Dr. Nilesh.
They do suffer. I'm not saying no. What I'm trying to explain is that the patient needs to choose the surgery. You cannot be biased.
Absolutely.
You can never be biased in surgery when it comes to sleep apnea, because if at all, the way Rahul said, if it doesn't work, you don't have anything to show for it. And that is where the CPAP trials actually give the patient another option. If he's willing to take it, let him take it. If he's not willing to take it, come on to the table.
Now, some challenging scenarios. So you want to make a point?
Yeah, I'll do that at the end. Basically, it's not really a lifestyle issue. That's what we're fighting with all the insurance companies. They put it as a lifestyle disorder, and that's why we're not getting anywhere.
Right. So this question is more for the pulmonologist, essentially. You get a patient like that 55-year-old lady, case number 1, who has persistent excessive daytime sleepiness, despite the CPAP download showing that the residual AHI is less than 5. She's using the CPAP well. She is very diligent with it. How do we manage it? Any inputs from the audience?
No.
Send to your favorite
personal EDS has to be persistent EDS, can't be always related to low saturation then.
No, so
there could be some other cause for that, central cause, neurological cause.
So that is one we should rule out.
That is one I should
Sleep
rule out.
hygiene issues we should rule out.
Yeah, but you're saying that she's using the machine regularly.
She's using the machine regularly. This is a patient, again, which in my book requires the best level 1 sleep study lab with a manual scorer sitting there, confirming that there are no RERAs happening and not just relying on the CPAP downloads.
By default, the neurologist will advise that only when we send
not the neurologist, but I mean, it depends upon what specialty is leading the 4 in your hospital. But yeah, that is that. Now, patient is happy, but AHI is above 5. Again, this is post CPAP. Again, assuming that there was a pulmonologist in the mix, but I think the experts will have to order.
If patient is happy, I'm happy.
You're happy?
I'm happy.
Residual AHI of 15, are you happy?
I'm happy.
Even if patient is happy?
If the patient is happy and I'm not sensing that there is likely to be future complications. So there's a lot of evaluation, obviously.
Sure.
But if the patient is happy, I'm happy. If the residual AHI is still higher.
Right.
Unless I have judged somewhere that, okay, there is something more that I need to remove and get that AHI lower.
Perfect. Persistent snoring after surgery. How do you manage? There is some snoring.
A lot of questions first.
You play your magic.
Lots of questions
first. Tell.
So the first questions would be whether he was evaluated completely prior to the surgery.
And we have to consider mouth breathing. If your surgery has been done well, the patient is still snoring, sleeping, still having apnea, mouth breathing is a very, very common. Persistent mouth breathing.
Right. How do you treat that?
No, you have to give chin straps and persuade the patient to.
So myofunctional therapy comes to your rescue. in treating persistent snoring post-surgery along with measures to improve nasal breathing, worsen snoring post-surgery, post-nasal surgery. This is what we discussed. But how do you manage?
Do a dice and perform this
Figure out
surgery.
Where lower down is the problem.
Right. And lastly, you get a big residual AHI after surgery. I promise last question of the day.
Again, same attitude. If the patient is happy, it's okay. But residual,
I
I'm
like to
saying
do a
if
dice.
there's-
I like to do a dice to see where is the problem.
No. So this
More
is
than 20, na?
presuming that post-surgery pre-dice has already been done. So then if I'm saying
You are
residual
the surgeon.
AHI would be a second stage which was not done in the first stage.
नहीं आपने सब सर्जरी कर दी अभी बच गया तो क्या करोगे क्योंकि ये it's not uncommon, right? I mean, if you operate enough, you'll get a lot of these patients who are still having snoring, who are not complaining. They're happy that they got the surgery done. But can medico-legally you can leave someone with an AHI more than 20 without advising any treatment?
CPAP.
So you can try oral plans. You can try improving the mouth breathing. You can try to do myofunctional therapy. And if all of that doesn't improve, then perhaps you can think about CPAP. The point is OSA is a chronic condition, somewhat similar to nasal polyps, probably a little less forgiving. So you need to follow up these patients. These patients are going to be your patients for a long period of time to come. So don't be in a rush to operate these patients without understanding the pathophysiology, and be prepared and counsel the patient in the pre-operative setting about possible limited success or partial success. That's about it. Any closing remarks by Dr. Vikas? We'll start with Dr. Seema, then Dr. Nilesh, Dr. Vikas.
With the white beard, the only thing I would like to say is that don't try to sell your surgeries. Let the patients buy them. Don't take any risks when it comes to surgeries. You need to be safe on paper as well as a very good rapport with the patient, because these are the kind of patients that can really create hell for you post-surgically.
Yep.
Indication in your practice or only frameworks like biomedical? Perfect indication.
There is no perfect indication, sir. If it's a bony box constriction somewhere, whether it is the maxilla, mandible, whatever, it has to be done.
So,
but let the max facts people decide exactly on what needs to be done.
If I can volunteer to answer that.
Please.
So essentially a patient who's cannot or will not use CPAP, whom you think there is extensive retrognathia, there is high arched palate, there is a big crossbite, and someone who understands the risks attached with such a big bony framework surgery. Okay, bony framework surgeries are not without their side effects. It's a lot of commitment. I'm sure you have done a few of them. I'm aware you have done a few of them with a good friend of mine. So, and you need a lot of orthodontic treatment. Getting those kinds of patients and for them to understand, and I'm talking about the Bimax here. I'm not talking about simple genioplasties. I'm not talking about even a dome for that matter. But doing a proper MMA needs a lot of awareness and understanding of the condition. India, that way, I feel, is a surgically averse country in general socially. So typically patients would look ways to use CPAP. Perhaps they'll be happy if you do their nose, do some soft tissue work if they are anatomically favorable, and then review again. So if you follow a very strong filter, patients will generally accept CPAP as an alternative. Bimax are good if the patient understands, in my book, again, the risks attached to it and has a very gross, peri-Robin kind of a retrognathia in place and those things in place. Just for the fact that he does not want to use CPAP and he is 30-year-old, I mean, those combinations are not very common to see in practice.
So I would say, even if you see a retrognathia, definitely do a dice. Many a times you will see that in spite of the retrognathia, the tongue is also not large and it is still a long soft palate. So you can still do a uvulopalatopharyngoplasty and get a great result with a palate itself, even in a retrognathia patient. Even if you get around 70%, 80%, the patient will be very, very happy. I have many of them.
So basically what he's referring to is the Stanford two-phase protocol. That in phase 1, you do the soft tissue surgeries wherever you think that there is going to be intervention. See how the patient is doing. If there is significant residual sleep apnea, you feel there is significant bony framework weakness or deficiency, then you can consider. Right.
They get 100% result.
Right.
But the morbidity part of it, the post-op,
the Bimax you're saying, na? Absolutely.
Sometimes it gets infected and we have to remove the stool and all that.
Malunion is there, relapse is there.
So I have almost stopped advising this surgery. It's a headache for us. Patient is they're happy.
No, sir, I don't think that would be the right approach. We should advise them, leave the headache to the MaxFax people, because you have to understand
get a good maxillofacial.
the effort taken for this kind of a surgery versus the results are definitely worth it.
And
the results are worth it.
But again, I mean, the whole point, I think for the right patient, we will all agree that,
That's the reason that
yeah.
the right patient.
So right patient is severe maxillofacial deficiency. And that severe part is something that you'll have to sit with your maxillofacial guys and decide and try everything else. See, this is a condition for which there are non-surgical options available. So if the non-surgical...
Sir, in the Bimax surgeries, BMI is not a limiting factor for them. They always do a tracheostomy and they go ahead with it and then they repair it later on. So BMI, I think BMI should not restrict us from doing that particular procedure. Yes, 100%. Thank you, Rahul. Beautifully done. Thank you.
Can all of us join?